proceedings. Firstly, there is the speakers might vary. Okay, for the people who have got the agenda, otherwise don't worry about that. Most importantly, you guys have to know that December 22nd, we guys had spoken to you at the end of the talk about a live mock exam, which is going to simulate the similar one which you're going to have in January. We are just going to focus it on a single paper, 10 questions, 100 marks. So it's going to be from 10 in the morning to 1 in the afternoon. So you guys can take that period, write down your answers. If possible, please do share those answers. We do have a live debrief session on the same day at 4 p.m. So it's also going to be a free webinar, like how we are having the current webinar. It's only focused as to how that you have, how you have to answer, particularly during the exam scenario. Okay, so it's definitely going to be an icebreaker for you guys. You'll get to see the real time scenario as to what happens. So this flyer is what you're seeing on the screen.
Talk and discussions will be predominantly on basic sciences. So my topics for discussion are on permissive hypercapnia, hypoxic pulmonary vasoconstriction, management of ICD. That includes the relevant anatomy and management of a intercostal drain and the waterfall effect in relation to COPD management. So first topic we'll be discussing is on permissive hypercapnia. So the topics I'll be discussing under these are definition, the physiological effects of hypercapnia, the indications, contraindications, technique, cessation of permissive hypercapnia, and the adverse effects of permissive hypercapnia. So coming to the definition, permissive hypercapnia is a ventilation strategy that allows the unphysiologically high partial pressure of carbon dioxide to permit lung protective ventilation with low tidal volumes or low minute ventilation to be more precise. So the physiological effects in relation to hypercapnia can have its effect on various systems: cardiac, central nervous system, the diaphragm, the lung, that parenchymal and vascular, and miscellaneous that can be at the level of the intracellular level and other areas also. So first coming to the effects on the lung, I would have mentioned a plus sign over here and a minus sign over here. The plus sign means it has a positive effect, and the minus sign indicates it has a negative effect. So, with relation to hypercapnic effects on the lung, it has a positive effect in relation to its anti-inflammatory effect. That is, it helps in suppression of neutrophil adherence to the endothelial cells in the lung, thereby helps in attenuation of ventilator-induced lung injury. But on the negative side, it causes impairment of the alveolar epithelial cell function, thereby reduced fluid absorption is there from the alveoli. Though this is more of theoretical, for my exam perspective, it is important to know about it. And regards to the effects on the circulation, that is pulmonary and systemic, one, on the positive side, it helps to augment the hypoxic pulmonary vasoconstriction, plus it helps in decreasing the intrapulmonary shunt, thereby helping in improvement of gas exchange. It helps in creating a rightward shift of the oxygen hemoglobin dissociation curve, thereby improving oxygen delivery to the tissues. Increase in PaCO2 levels helps to increase the sympathetic response, thereby helps to increase contractility and heart rate, thereby increasing cardiac output. And on the downside, it causes intense vasoconstriction of the pulmonary vessels. So, increase in PVR can lead to increase in pulmonary afterload, RV afterload, thereby leading to impaired RV function in susceptible patients. With regards to effects on the CNS, most of them are negative effects. That is, it has a cerebral vasodilatory effect, thereby increasing cerebral blood flow, which leads to increase in cerebral blood volume, which can contribute to an increase in ICP. It can lead to agitation. It can lead to a comatose state, that is somnolence, which can become stupor and then go on to coma. And it also decreases the seizure frequency. So notable cases, patients who already have a previous history of seizures, creating a hypercapnic environment can actually predispose to seizures. So with regards to the effects on the diaphragm, hypercapnia usually augments the myogenic tone of the diaphragm. That is, if it is less, PSO2 is less than 80. But if it is more than 80, it starts to produce a inhibitory tone on the diaphragmatic muscles, which become more pronounced at effects more than 100 millimeters of mercury. And prolonged hypercapnia can itself lead to skeletal muscle atrophy because it leads to release of reactive oxygen species, which can lead to muscle injury and that can lead to atrophy. And miscellaneous effects, it can cause intracellular acidosis, thereby leading to inhibition of the actin-myosin linkages, leading to impaired muscle contractility. So that is a negative effect. And another effect that it causes is it can predispose to increased risk of infections due to a variable host response. So, like I said, it has an effect on the lung, it has an effect on the vessels, that's the systemic and pulmonary vessels. It has an effect on the cardiac muscle. It has an effect on the CNS, diaphragm, and miscellaneous effects. That is intracellular acidosis leading to impaired muscle contractility and increased risk of infections. So, where do we use permissive hypercapnia? So the main two documented indications are in patients with ARDS managed with low tidal volume strategy and patients ventilated for exacerbations of asthma or COPD who require low minute ventilation to reduce auto PEEP. And we also need to know what are the contraindications. So contraindications are patients with cerebral diseases, as we already know, because an increase in PaCO2 is ultimately going to lead to an increase in the intracerebral pressure, which is going to be more detrimental to the brain function. We don't want that. So in these subset of patients, we do not want an increase in PaCO2. And in patients with an already a pre-existing coronary artery disease with heart failure with reduced ejection fraction or presence of cardiac arrhythmias or patients with pulmonary hypertension with evident RV dysfunction, it's very much preferable to avoid hypercapnia because that itself can further worsen the underlying cardiac status. And even though I said that in the initial cardiac effects, cardiac output helps to increase the cardiac output by increasing the chronotropy and the inotropy, but it has a downside also. Thing is, in the pulmonary vessels, it helps to augment pulmonary vasoconstriction, but in the systemic vessels, it causes systemic vasodilation. So patients who present with a hypovolemic shock and if they have hypercapnia also, it is likely to exacerbate the shock in relation to hypovolemia because increase in PaCO2 causes a peripheral vasodilatation. So that also needs to be kept in mind. So how do you go about uh, proceeding with permissive hypercapnia? So with regard to the ventilatory adjustment, permissive hypercapnia is a ventilator strategy in which hypercapnia is tolerated rather than being a ventilatory goal per se. So they say the clinician should incrementally decrease tidal volume or respiratory rate gradually and monitor the trend of pH and the PaCO2. So they say to go over the tidal volume change of 20 to 50 ml and a respiratory change of 1 to 2 breaths per minute and gradually assess the change in the pH and the PaCO2. The most important thing is the patient should be very much deeply sedated and if needed paralyzed also because hypercapnia can cause significant significant patient discomfort. So usually a target pH of more than 7.21 is well tolerated but should be individualized based on the patient's comorbidities and the tolerability. So usually we keep the target between 7.2 to 7.25. Usually we don't go less than that range of 7.2. And the most important thing to keep in mind is there is no role for sodium bicarbonate in the event of severe respiratory acidosis. It does not have any role, it is not beneficial, and it will not serve any purpose also. So, in patients who have developed permissive hypercapnia, which is with severe respiratory acidosis, that is less than 7.2, no role for sodium bicarbonate. So once you have managed the patient that with the ARDS or with the ACOPD, and you have the gas exchange has improved, that's when you are going to slowly come out of your permissive hypercapnia. So it is initiated only when the gas exchange improves and ventilatory adjustments are made slowly, that is over 24 hours, by incrementally increasing the tidal volume and the respiratory rate. Like I said, there is no hard and fast rule, but they say you go slowly. You slowly increase the rate by 1 to 2 breaths and increase the tidal volume by 25 to 50 ml. Although there are no data that is available to facilitate how quickly can be done, an approach that results in less reduction no greater than 10 Hg per hour is the most appropriate measure of proceeding for cessation of permissive hypercapnia. So the adverse effects are, as you know, as I mentioned, the contraindications are mainly involving the CVS, CNS, and RS. So the adverse effects are related to these systems predominantly. So in CVS, it can cause arrhythmias, it can cause hypertension or hypotension. The mechanisms which I had explained previously, it can cause exacerbation of your right heart dysfunction and it can cause coronary steal in ischemic heart disease patients. Whereas in CNS, it can cause increase in cerebral blood flow, which can lead to increase in ICP, can lead to narcosis, it can cause a decrease in seizure threshold, and it can lead to a cerebral steal phenomenon in patients with ischemic strokes. And in respiratory system, it can worsen hypoxia, though it's a very rare scenario, but it is a possibility. So these are the things that we have discussed under permissive hypercapnia. So we discussed about the introduction, the effects on various systems, indications, contraindications, how do you initiate, how do you discontinue, and the adverse effects. So there are 7 areas we have covered. So usually if it is asked as a 5-mark question, within 2.5 pages, I think covering all these would be sufficient. So the next topic is about hypoxic pulmonary vasoconstriction. So under this, we'll be discussing about the introduction, physiology, the HPV mechanism, the physiological factors influencing it, and the clinical implications. So coming to the introduction, so hypoxic pulmonary vasoconstriction is a reflex contraction of the vascular smooth muscles in the pulmonary circulation in response to a low regional partial pressure of oxygen. So I'll just repeat it once more. It's a reflex contraction of the vascular smooth muscles in the pulmonary circulation in response to a low regional partial pressure of oxygen. So it is an important mechanism for matching regional perfusion and ventilation in the lung, occurring through the pulmonary arteries smooth muscle cells. That is also called as PASMC. So that actually has the main role in the mechanism of inducing HPV. So as you can see here there is normally ventilated lung units and as blood flows, deoxygenated blood flows and passes through these ventilated units, it gets oxygenated and returns to the patient. But when there is an area which is not ventilated, a unit which is not ventilated, it induces a HPV response whereby these blood which is present in this area is diverted to the well perfused, well ventilated areas. So there is a good amount of gas exchange which occurs, thereby producing a good delivery of oxygen to the patient despite a few lung units which have been non-contributory to the oxygenation. So coming to the physiology of it, systemic circulation causes vasodilatation in the presence of hypoxia. But in contrast, the pulmonary circulation vasoconstricts in response to hypoxia via the HPV, that is a hypoxic pulmonary vasoconstriction. So this is a protective physiological reflex that aims to divert blood away from the hypoxic areas of the lungs to areas with better ventilation and oxygenation, thus acting as an important process to maintain oxygenation. So coming to ventilation perfusion matching. So matching of ventilation and perfusion is a crucial determinant of gas exchange. This is something which all of us know. Because in an ideal lung where ventilation is heterogeneous, that is in upright position, more perfusion and less ventilation at the base, and more ventilation and less perfusion at the apices, HPV reflex aims to improve matching of ventilation and perfusion, though its role in healthy lungs is minimal. So it will only cause minor changes because there's not going to be much significant influence on the oxygenation. But in contrast, the role of HPV is more significant in patients with COPD and interstitial lung diseases. So in these conditions, maintaining normal gas exchange is dependent on optimizing the VQ matching, which is influenced by HPV, which aids in oxygenation. So inappropriate delivery of supplemental oxygen in these scenarios, in addition to use of some drugs, can attenuate the HPV response and can lead to VQ mismatch, ultimately leading to hypoxia, that is deterioration in the oxygenation. So coming to the HPV mechanism, so the main stimulus for HPV is the tissue partial pressure of oxygen in the region of the pulmonary arteriole. So it's a very big term to think about, but on the easier side, it is determined by two factors. One is the partial pressure of oxygen in the alveolus and the mixed venous oxygen. That is the P capital AO2 and the mixed venous oxygen, that is the P small v O2. So the site of action where this HPV occurs is, as I told, the PASMC, that is the pulmonary arterial smooth muscle cell. So the mechanism involves three steps. One is the biological oxygen sensing, that is the area where this hypoxia is being identified. Then the PASMC contraction and the modulation of activity. So these three things needs to be kept in mind. I'm just repeating it once more. One is the biological oxygen sensing, the PSMC contraction and modulation of activity. So the biological oxygen sensing occurs by because there is an inadequate oxygenation that occurs. That is, the gas exchange is inadequate in that lung unit to the vascular cell. There is going to be mitochondrial free radical production, that is reactive oxygen species production because of hypoxia in that lung unit which is devoid of oxygen. That will also be associated with the alteration of the cyclooxygenase and lipoxygenase systems. And eventually, because of hypoxia of the alveoli, or that is poor oxygen delivery of the alveoli, it will cause activation of the transcription enzymes via the hypoxia inducible factor. So these three are the most important factors that contribute to the biological oxygen sensing, which then triggers the PSMC contraction. So now this PSMC contraction, it is nothing complex. It is similar to what happens in a skeletal muscle contraction. So it acts by membrane depolarization after sodium ion influx, leading to an increase in cytosolic calcium ion concentrations. This causes an increase in the calcium ions available for binding to calmodulin, causing activation of the myosin light chain kinase, ultimately leading to contraction of the smooth muscle. So whatever we have learned in this skeletal muscle and smooth muscle contraction pathway, it is almost the same thing. So that is about the PSMC contraction. So once the biological oxygen sensing is being identified that there is a site of hypoxia which is present, then this PSMC contraction occurs, causing contraction of the smooth muscle. So these are the initial two steps. Then is the modulation of activity. So there can be two paths. One, there can be enhancement of activity, or one, there can be inhibition of activity. So enhancement of activity can be via endothelial one, which can cause potent vasoconstriction, or there can be inhibition of vasoconstriction via nitric oxide or prostacyclin, which can cause potent vasodilatation. So this is just a summary of what I just told, the three steps of it. So when there is a low alveolar oxygen which is being identified, the smooth muscle cells I have a biochemical O2 sensing. So, like I said, at the cellular level, reactive oxygen species will be increased. Then there will be alteration in your lipooxygenase and cyclooxygenase pathways, and there will also be release of your tissue inducible factor, that is hypoxia inducible factors. So that will cause activation of your PSMC, and modulation can be based on your other hormones. That can be endothelial one, or it can be because of other chemokines like nitric oxide or prostacyclins. So coming to the physiological factors influencing HPV, so there can be increase in HPV that can be associated because of hypercapnia, acidosis, hyperthermia, or initially at birth there can be an increase in the HPV, or HPV can be associated with iron deficiency and high altitudes. Similarly, decrease in HPV can be associated with alkalosis or hypothermia. So coming to the clinical implications, there are three important disease states which needs to be noted. One is pulmonary hypertension, ARDS, and high altitude pulmonary edema. So with regard to pulmonary hypertension, it can occur acutely or as an acute on chronic manifestation in critically ill patients. In many instances of acute pulmonary hypertension, it may go undiagnosed. And the most important thing is the choice of inotropes or vasopressors that are taken for management of cor pulmonale should be taken into consideration about its effects on the HPV also. With regard to ARDS, the impact of hypoxia, hypercapnia, lung volumes, PEEP, and atelectasis, all these can have activity on the HPV as a whole. And with regard to high altitude pulmonary edema, here HPV is activated in all lung regions due to hyperbaric oxygen, hypoxia. So that causes an increase in the pulmonary capillary pressure, leading to stress failure of the pulmonary capillaries, leading to extra vascular fluid accumulation. So drugs that are associated are inhibition of HPV can be through the phosphodiesterase inhibitors like phosphodiesterase 3, like milrinone, or phosphodiesterase 5 inhibitors like sildenafil, inotropes like dobutamine, dopamine, adrenaline, acetazolamide, ACE inhibitors, prostacyclins, vasopressin, inhaled nitric oxide. So all these drugs can cause inhibition of HPV, and there can be activation of HPV via vasopressors like noradrenaline at doses more than 0.5 mg per kg per minute and phenylephrine. So these are the important takeaway points related to the drugs which can modulate your HPV. Uh, just a second. I'll just be back in 1 minute. Sorry.
If there are any queries, you can actually post in between. The talks on basic sciences is focused only on paper one. Mostly you will get this here, or sometimes even in paper three for recent advances. So most of the topics that we have chosen is for your paper one or paper three topics. So few drugs are being considered just to give you an overview as to how to approach to them. And these are basic concepts in respiratory physiology, few other things that we have picked up where they can ask as a relevant anatomy or physiology. Navneet, I think so. We can mute the recording till Srihari is back. Let's wait for Navneet to turn on the recording.
Yeah, sure, sure. So I hope everyone just had a note on the drugs that modulate HPV, that is inhibitory drugs and drugs that can activate it. So the next part we will go into is on the management of the intercostal drain and the relevant anatomy. So here I'll be covering the anatomy, the indications, management of a thoracostomy tube drain, and complications in relation to that. So coming to the introduction, thoracostomy tube placement belongs to one of the most performed procedures. So it's most commonly done as a life-saving scenario for tension pneumothorax, for enhanced recovery, that is post-surgical patients, for symptomatic relief in cases of malignancies. So despite many benefits of thoracostomy tube drainage, there is a potential for significant morbidity and mortality associated with use of these thoracostomy tubes. Hence, regular assessment and troubleshooting of complications is crucial for ensuring improved outcomes. So, coming to the anatomy, this was asked last year as one of the questions. That is anatomy of that's a triangle of safety, and they had asked about ICD management. So, if you see the way that we need to answer is you can go with medial, lateral, and superior and inferior. So this will be the approach to that. So if you see the anterior part of it is by the lateral edge of the pectoralis major muscle, and the posterior part of it of the triangle is by the lateral edge of the latissimus dorsi. The superior part of it is by the base of the axilla, and the inferior part of the triangle is by a line drawn from the fifth intercostal space. So the anterior part is by the lateral edge of the pex major. The posterior part is by the lateral edge of the pectoral latissimus dorsi. The superior part is by the base of the axilla, and the inferior part is by a line drawn from the fifth intercostal space. So it is mainly called triangle of safety as it avoids the damage to the chest wall muscles and the breast. And another important thing I just wanted to emphasize here is thing is, for those who do ICD insertions on a regular basis, I don't think it would be a concern. But for for the first timers, it is always important to note you need to place the ICD in the superior border, not the inferior border. For the simple reason, the neurovascular bundle that you can see over here is placed along the inferior border. So if you go along the inferior border and insert the ICD, there is a high chance you may injure the vessels, and that may further complicate things. So that is the important thing I just wanted to tell in relation to this slide. So coming to the indications, it can be for removal of air collection in the pleural spaces. That is, can be like a tension pneumothorax or a simple pneumothorax if patient is on mechanical ventilation. For removal of fluid collection in the pleural space, like hemothorax, malignant pleural effusion, if it is symptomatic, chylothorax, complicated parapneumonic effusion, or an empyema. Or use as a delivery conduit to introduce medications or fluid into the pleural space. That is internal warming via installation of warm saline. Fluoridesis with talc can be instilled to promote scarring of visceral and parietal pleura. Hypothermic intrathoracic chemotherapy in cases of malignant pleural mesothelioma and metastatic diseases. So in this, in every heading, at least two indications can be kept in mind when you're applying, when you're writing it in the exam. So coming to the chest drain system, we have a one bottle, two bottle, and a three bottle system. So the one bottle system, as you can see here, has two main functionalities. One, it acts as there is a water seal and there is a drainage bottle. Both of these are in the same compartment. Whereas in the two bottle system, one bottle is dedicated for the water seal and the drainage, as you can see, similar to a one bottle system. And the second bottle is specifically dedicated for a suction control. In a three bottle system, there is each bottle is dedicated to a separate function. That is, one is for drainage, one is for water seal, and one is for suction control. That is three specific functions. So just for memory purposes, in a one bottle system, it is seal plus drainage. In a two bottle, there is seal plus drainage for one and suction for the other. And in a three bottle system, we have one for drainage, one for seal, and one for suction. So thoracostomy tubes placed in hospital patients require daily assessment to determine the presence of air leak, provide ongoing adjustments of suction level, and monitor for malfunction, which may include obstruction, malposition, or disconnections. So this is very important, needs to be kept in mind when you are managing a thoracostomy tube. So management of a thoracostomy tube drain post in placement has five important areas that needs to be covered. That is, one is precautions during initial drainage, monitoring of the patient, assessment of the thoracostomy drain, chest physio, and patient transport. So coming to the precautions during initial drainage, the amount of thoracostomy drainage should be assessed on a regular basis, which has to be hourly in the setting of trauma. So what they say is, with traumatic hemothorax in general, immediate drainage of 20 ml per kg or accumulation of more than 3 ml per kg per hour of blood is an indication for thoracotomy to identify and manage a thoracic vascular injury. In cases of massive pleural effusion, the fluid drainage should be very slow. Not more than 1 liter should be drained in the first go itself. So if at all almost 750 ml has been drained, it needs to be clamped, and thereafter it has to be drained at intervals of 1 to 2 hours, about 300 ml of a time thereafter, with a tube clamped in between. This is very, very important, because if it is not done properly and you in one go you allow a large volume of fluid to be drained out, that can lead to re-expansion pulmonary edema and further worsen oxygenation, necessitating to the extent of intubation and mechanical ventilation. In the rare case of a large effusion with active air leak, it is a very controversial area, because in one side the tube cannot be clamped. But if you keep the tube open, the leak component is also not going to be addressed. So usually this scenario will be asked in Viva in the practicals. So I just thought I'll give it here for completion's sake. So if at all they ask a scenario where there is a large effusion and an air leak also, what do we do? The drainage tube can be draped from the insertion site to a level above the patient's head and then back to the drainage system, which is ideally situated on the floor. So this creates a fluid trap that allows the air to be safely escaped but slows the drainage of fluid. I'll just repeat it once more. In cases of a large effusion plus an active air leak, the drainage of the tube can be draped insertion site to a level above the patient's head and the drainage system, which is ideally situated on the floor. The main purpose of this is to create a fluid trap that allows the air to be safely escaped but slows the drainage of fluid. So if the collection bottle gets filled with drained blood or fluid, it should be emptied and after clamping the tube, and it is to be done in a completely sterile manner. The drainage system must be kept upright for the water seal chamber to function correctly. That is also a very important thing to be noted. And the chest drainage system must be lower than the chest to facilitate drainage and prevent backflow. So the next part of it is about the monitoring. So monitoring of the patient, the basic is the vital signs. That is the heart rate, BP, saturation, respiratory rate, and the GCS. Then the pain assessment. Because if it is a pigtail catheter, the pain is relatively less because it has very less impingement on the surrounding nerve structures. But if it is a ICD, there is more amount of muscle tissue that is involved. That is going to cause more pain and discomfort, and that is going to impede on your physiotherapy and rehabilitation. So adequate pain management needs to be addressed. And the site of insertion and the dressing needs to be assessed on a regular basis. Especially if the ICDs are being kept for a long time, it has to be looked as a potential source of infection. So the site needs to be looked upon for presence of pus, or and during the initial phases, there should be always assessment for presence of any soakage of blood which is present in the dressing. So that should be a concerning sign. And respiratory parameters, that inspiration of bilateral chest movement should be seen, and auscultation of the chest to assess the intensity of the breath sounds. That is like pre-insertion and post-insertion. If there is any improvement in auscultation, that would be a good aid to identify the success of your intercostal drain insertion. But in our current era, focus plays a better role. Chest X-ray is done to assess the exact position of the chest drain and to evaluate the status of the underlying chest expansion. And Another important thing is to assess for the presence of subcutaneous emphysema. Sometimes one of the holes of the ICD tube may be little dislodged and be placed in the subcutaneous plane. So that itself, for a period of time, if it is not looked into adequately, can lead to the increased incidence of subcutaneous emphysema, which may further increase morbidity. So assessment post-insertion should be at least every 15 minutes for the first hour immediately following chest tube insertion. And any alteration in the patient's hemodynamics or respiratory mechanics should be monitored for appropriate management. So the next part is about assessment of the thoracostomy tube drain. So the first thing is about monitoring for tidalling. So what is tidalling? When the fluid along the dependent portion of the tubing is seen to move back and forth with the respiration, it is a sign that the chest tube is patent and it is affected by the negative pressure created by the diaphragm. So absence of tidalling may indicate there is a tube occlusion which needs to be looked into. The second thing is assessment of integrity of the drainage system, that is the amount and character of drainage. The important thing to note is if there is any significant changes compared to the initial findings. Assess if the tube is kinked or bent, which may interfere with the drainage. Check the water levels in the water seal chamber. If it is inadequate, there can be excessive suction pressure that can occur on the delicate pleura. And make sure the chest tubes are not clamped. That is a very, very important thing to be looked into. Then the one of the most important things for assessment is assessment of air leaks. So presence of air leaks should be assessed to determine whether the tube can be removed. So most intrathoracic air leaks will usually seal spontaneously and resolution can be tracked by witnessing decreased bubbling in the devices over days. So bubbling within the chamber can also be related to a air leak anywhere within the circuit. Now, our usual mentality is if there is air leak in the system, it is usually associated to a bronchopleural fistula. That is not the case. You need to go in a stepwise approach. You need to isolate where the exact source of the leak is because it can be downstream also. So what they say is you begin evaluation at the chest tube insertion site to evaluate if there is an atmospheric air tracking into the thoracic space via the chest tube insertion site, that is the incision site or the tube position. Then clamp the tube near the patient and briefly to assess if the leak is downstream, that is from outside of the patient. So if it is so, then you need to replace the unit. And once all these are ruled out, then you look for any intrathoracic pathology, that is like a bronchopleural fistula. So qualitative air leaks can be classified as follows with increasing severity. So if it is only present with forced expiration, that is like with Valsava maneuver or coughing, it is just a mild leak. If it is present just during the expiratory phase, it could be an alveolar pleural fistula, which is also under a mild scenario. Whereas if it is present also during the inspiratory, uh, more during expiration than inspiration, then it could be an alveolar pleural fistula or a bronchopleural fistula. Whereas if it is continuous, that is, there is continuous bubbling which is occurring during both inspiration and expiration equally, then it is a true bronchopleural fistula which needs to be taken seriously and for which a cardiothoracic surgeon's consultation would also be needed. So the level of suction. So the initial level of suction used in the clinical setting is -10 to -30 centimeters of water. When the thoracostomy tube or catheter is placed for fluid drainage, -20 centimeter of water is a reasonable place to start. And the level of suction should be increased as indicated with the goal of achieving full lung expansion as determined by the chest radiograph. So many a times we just have connected the patient's ICD to a negative pressure suction and just leave it for days without any manipulations. But that is not the right practice. The ideal thing is to assess the clinical scenario and assess the radiological clearance of fluid of air, and then accordingly take a call whether to continue on suction if it is needed further or not. So for a collapsed lung due to pneumothorax or copious pleural effusions, large differential pressure gradients should be avoided during lung re-expansion to prevent re-expansion pulmonary edema. And if suction is not ordered, ensure that the port is left to open. So the next part is related to the chest physiotherapy. Under this, the patient should be encouraged to ambulate as soon as possible. So deep breathing and breath holding exercises should be initiated as soon as possible after chest tube insertion. So this facilitates effective lung expansion and drainage of fluid. And the last part of it is patient transport. So during transportation, the chest tube bottle and bag should be always kept below the level of the chest level. It is important not to clamp the chest tube as continuous drainage is the safest approach. In cases where there is an air leak from a lung surface, clamping the tube will lead to accumulation of air in the pleural cavity, causing lung collapse and sometimes increasing the risk of developing a tension pneumothorax. So coming to complications, you can classify it as organ-specific complications, whereby any of the system surrounding the lung can be involved. That is esophageal injury, gastric injury, bowel injury, hepatic injury, splenic injury, diaphragmatic injury, lung injury, which can be associated with perforation, infarction, or bronchopleural fistula. There can be cardiac or major vessel injury, intercostal arterial hemorrhage, especially if you're going in the through the inferior border, and chylothorax if the left lung is being sorry if there is a left-sided pleural disease and an ICDB has been inserted for the same. Then you can have technical complications, whereby there can be a non-functioning tube because of a kink clot or a dysfunctional closed system. There can be a subcutaneous placement, especially in very obese patients, whereby you may not be able to identify the plane direct correctly. There can be tube dislodgement or removal, or there can be physiological complications like re-expansion pulmonary edema, and in very rare circumstances, there can be vagus nerve irritation. And infectious complications, that is at the insertion site. In the most severe scenarios, it can cause necrotizing fasciitis, and also empyema can be another also associated complication in relation to thoracostomy drains being kept for a very long period of time. We did have a lot of cases in relation to empyema during the COVID era, because during the second wave, there were a lot of patients who had an impaired mechanics. So invariably, many patients developed pneumothorax and had an ICD in situ, and they were not able. We were not able to wean off ventilation because of their underlying lung status. So the ICD was inside for a very long period of time, and that itself led to new infections. And one among them was empyema, which was actually very difficult to treat. So infection complications should always be kept at the back of the mind. So the last part of it is in relation to removal of thoracostomy tubes. So to minimize the risk of infectious complications, the ICD tube should be removed as soon as it is safe to do so. So the criteria in cases of pneumothorax, number one, the lung should be expanded fully. There should not be any visible leak present, and air does not accumulate when suction is removed. If the patient is on mechanical ventilation, the patient should be on pressure support mode, preferably prior to ICD removal. Whereas in cases of a pleural effusion, the first criteria is the lung is adequately expanded, the drain output is less than 100 per day, there is no fresh or altered blood or pus draining from the chest tube. So with regard to the removal technique, before removing the chest tube, the nurse assistant should be ready with the following: a dressing set with sterile gauze pieces and artery forceps, sterile water impermeable adhesive wound dressing, and or a adhesive tight dressing. So at the peak of deep inspiration, the chest tube should be pulled out gently. One person pulls out the tube, the other person should be ready to tighten the purse string sutures to prevent any air entering the chest, especially with post-surgical drains. A water impermeable occlusive dressing is applied at the site of insertion, which is then removed after 48 hours. So post removal, it is important to assess for respiratory distress, and a chest X-ray should be done to look for pneumothorax or any other abnormalities. So these are the first three topics that I discussed. One is permissive hypercapnia, HPV, and ICD management with the relevant anatomy. So the last talk for me is about the waterfall effect in relation to COPD. It is also called the Pride's waterfall analogy. So I'll be discussing it under two headings. One is the introduction and the topic proper. So coming to the introduction, normally the lung at end expiration generally approaches a relaxation volume of the respiratory system. That is, the lung volume determined by the static balances between the opposing elastic forces of the lung and the chest wall. That is, the pleural pressures play an important role in maintaining the lung patency from getting collapsed. But in patients with an airflow limitation, that is, in patients with an acute exacerbation of a COPD or an asthma, the end expiratory volume may no longer be determined by an equilibrium between the static forces, that is, the elastic recoil forces between the lung and the chest wall. Instead, the end expiratory lung volume may exceed the predicted FRC of the lung. Because the rate of lung emptying is slowed, expiration is interrupted by the next inspiratory effort before the patient has exhaled to the static relaxation volume. So this is termed as dynamic hyperinflation. So the main reason why I had explained about this is to understand the waterfall effect, we need to know a small basic understanding of dynamic hyperinflation. Only if we do understand about this, we'll be able to apply the concepts in relation to that. So factors that influence dynamic hyperinflation are: one is increase in tidal volume, prolonged time constant. So time constant is nothing but a product of resistance and compliance. So a prolonged time constant for emptying the respiratory system and a shortened expiratory time. So all these factors will lead to dynamic hyperinflation. So at normal end expiration, the static recoil pressures of the respiratory system is usually zero, whereas a positive value is observed in patients with dynamic hyperinflation. This positive recoil pressure is called as auto peep or intrinsic peep. And the problem with this is it is associated with increased work of breathing. So the increased work of breathing from auto peep can be decreased by various therapeutic measures like bronchodilator therapy, use of a larger size endotracheal tube, decreasing the minute ventilation by controlling fever or pain, minimizing the ratio of inspiratory to expiratory time, and which also includes increasing the inspiratory flow rate. And one of the other important factors is application of external PEEP. So patient already has an auto PEEP. So isn't application of an external PEEP to an already occurring intrinsic PEEP supposed to be harmful? So this was a question that had come up way back in the 1980s. So that was when they had done a study and then they had postulated this waterfall analogy, whereby they had shown that use of this external PEEP to an extent is supposed to be beneficial in these subset of patients. Specifically, this airflow limitation in relation with COPD and asthma, application of external PEEP helps to reduce the intrinsic PEEP effect to an extent. So coming to the waterfall analogy, here the important thing, if at all it is being asked, first diagram that we need to put is this diagram. So here you can see that there is a alveolus, that is the distal alveoli, which is the upstream segment, and the proximal airway, which is the downstream segment. So because of a bronchoconstriction, there is a airflow limitation whereby there is a narrowing of your airways. This area will be the waterfall. And this pressure which causes this collapsibility of the airway is called the critical pressure. So it is nothing but the transmural pressure of the airway where flow is limited during forced expiration. So this is the site of the waterfall. So I'll just explain this diagram once again. With regard to the waterfall analogy, the distal alveoli is the upstream segment, and the proximal airway is the distal or the downstream segment. The area where the alveoli get collapsed is the area of flow limitation, and the pressure which causes this flow limitation is called the critical pressure, which is the transmural pressure of the airway where flow is limited during forced expiration. So the important take home is where the upstream segment starts and where the downstream segment starts. The upstream segment starts at the level of the alveoli, and the downstream segment starts at the proximal airway. So if this initial diagram is clear, then we can go into the second part of it. So because of the development of an auto PEEP, the alveolar pressure will be higher, that will be positive. So because of this flow limitation, it will cause an increase in pressure needed to push the gases from the distal, that is from the upstream segment to the downstream segment. So that can be compared to a hydrostatic pressure in the stream. So as you can see here, this area is like the distal alveoli, and this area is the proximal alveoli. So because of the intrinsic creep that is present, the pressure is high and the height of the waterfall, that is the stream, is also high because of the intrinsic pressure. So as it passes through the narrowed airway, that is the flow limited airway, it causes an increase in hydrostatic pressure. So once that it passes through that flow limitation and then comes to the proximal airway, then this waterfall effect is created. So this is the second part of it. So as you can see, this is the flow limitation, as I said, that in relation to the critical pressure at the area where there is a narrowing of the bronchioles. And this is in relation to the waterfall picture that is seen over here. So I hope this part is clear. So the higher area that is seen over here is the distal alveoli, where the intrinsic PEEP is predominantly present. And this area which is present over here is the proximal airway, where once the uh, gases have passed through the flow limitation, it has entered into the low pressure area. So the first analogy is you have an intrinsic PEEP of 10, but the extrinsic PEEP is 0. That is similar to the previous diagram that we had seen. When no extrinsic PEEP is applied, there is greater hydrostatic pressure at the waterfall, meaning more energy is required for the flow of gases from the distal to the proximal airways, with flow limitation being present. I hope this is clear. Now, this is the second analogy. That is, we have tried to increase the external PEEP to 10 with an intrinsic PEEP of 10 already being present. So what they say is, now suppose the tide comes in, that is the external PEEP is applied, raising the height of the stream below the waterfall to almost the level of the waterfall. This helps to reduce the flow limitation to an extent, allowing the exit of gases from the alveoli to the proximal airway to be easier. So, when this airflow limitation was so significant, it was unable to release the gases that are present in the alveoli towards the proximal airway. But when you create a external PEEP, that helps to push up the tide, that helps to push the tide up, thereby somewhat neutralizing the pressures, allowing the exchange of gases from the distal to the proximal airways. So This is the area where the benefit of external PEEP was found. But sometimes when you go with an overzealous management of external PEEP, when there is already an intrinsic PEEP of 10 and you go with an external PEEP of 12 or more than that, the upstream pressure is increased and that hyperinflation is exacerbated. What it means to say is that you are actually increasing the risk of barotrauma. So they say for auto PEEP of 10 that is present, the extrinsic PEEP should be almost at the same level. Now, in our modern day ventilators, we go with an expiratory pause of around 10 seconds. We assess the PEEP and then accordingly adjust it to the two-thirds of it. Now, why do we go with two-thirds? There is a reason. Thing is, there is no accurate measurement for exactly identifying how much is the auto PEEP. So if the patient's showing and if you have found, if you have calculated the auto PEEP to be 10 and we go directly place the external PEEP at 10, there is a potential risk of a barotrauma that is likely to occur. So to avoid that risk, we go with two-thirds. That is, to be more precise, they say to go with 60 to 70% of your external PEEP. So that is the main rationale for going with your external PEEP of 60 to 70% to counteract the auto PEEP. So I hope this concept is clear. If you have any queries in relation to this, let me know. I will again try to explain it in a easier way. Thank you.
That was great, Srihari. I think so. It was very well received. I think so. Most of them have, which shows the optimal setting of PEEP when you identify auto PEEP. That actually is the bedside clinics that they might ask even in your practicals, if not here in theory.
Exactly.
So
That's why actually this topic was one thing we wanted to put up because if at all doesn't come in the theory for the practicals, if at all there is an acute exacerbation of COPD case that is kept, invariably they're likely to go into this area. So it is
correct.
always important, better to have an idea of this.
Correct, correct. Also, keep a watch on your hemodynamics, especially while setting all of these. So that is one more important thing. So great. I think so. Without wasting much time, we'll go to the next topic. Thank you, Srihari.
Thank you, Darshan.
So there were questions asked about hypoxic pulmonary vasoconstriction, etc., in the chat box. I have answered a few. So you guys can log into the chat box and look at the answers as well. It's for the want of time. Okay. So the next question that we are trying to deal is another thing which is routinely used. Just a minute. Sherry, I think so. You're still sharing the screen? Or? No, right?
No, Darshan, I came out to
Okay.
them.
Okay, great. Okay, is my screen visible?
Yeah, Darshan, it's visible.
Okay, so great. So good evening, everyone. So we'll go into the next topic today. I think so. For the people who have attended top classes regularly, we had this covered during the regular respiratory session classes. But prone ventilation can come in as both your systemic paper as well as some ethics can be asked in your basic sciences as well, and this can come even in your practical. So there is no actual delineation for such topics. So that's one of the reasons we took this topic as well. Firstly, I would like to convey my condolences to Gattinoni. I think so. You all know that he passed away in the previous week, and he was one of the doyens in critical care who have actually strived a lot in the field of both fluid management and mechanical ventilation. And he was one of the people who also had a lot of trials on prone ventilation in ARDS. So the outline of the present talk would be under basics and introduction. Physiology is the main thing that I'm focusing, but I'll also be looking into indications, contraindications, and evidences as we go on. So the main focus is physiology. The question has been asked previously in the 2018 DM paper, wherein they have asked about evidence for ventilating a patient in prone for improving oxygenation. This can be asked in any other ways as well. So physiology, if they ask, probably like how they ask about west zones, etc., they can ask about prone ventilation as well. So we all know that it is one of the only evidence-based technique that has shown some mortality benefit in patients with ARDS. It has shown to improve lung compliances along with ventilation perfusion matching. Usually, because we are recruiting the posterior atelectatic lung, which is usually left without better ventilation with perfusion being intact. So that is one of the important physiological considerations that showed better outcomes with patients being prone with ARDS. We all know that heart and the anterior wheels are placed down, and instead of acting with gravity in prone position, the contrary happens, because of which the recruitment helps in better VQ matching. Okay, so the mismatch is lost. There have been a lot of trials showing that inadvertent increasing of PEEP, etc., has caused a lot of VQ mismatch. In certain cases, also has led to barotrauma. Those things can be, averted if we actually do proning at the earliest. So, looking at a person with a normal lung, so we'll leave alone a patient with ARDS. We'll take a patient with normal lungs. So, this is what usually the lungs and the anatomy looks like, right? In a supine position, the heart is placed anteriorly. Majority of the lung, which is aeratable, is present in the posterior part. Correct. Usually, the gravitational force by the anterior mediastinum falls onto the recruitable part of the posterior part of the lung, which probably offsets the ventilation perfusion, leading to a poor oxygenation in the long run. Similarly, we see that the same effect can happen as well in the abdominal contents. If you take liver as well, this A here stands for anterior and posterior. Liver as well puts a major, gravitational force on the posterior part of the lung, which decreases its recruitability, thereby worsening the VQ matching. Okay, so that has been offset in a prone ventilation. As you can see, this part of the lung is better aeratable. The whole thing about proning is about knowing the recruitability of the posterior part of the lung along with certain other hemodynamic changes. Okay, so the other most important part along with the gravitational force that we need to know is about the elastic recoil of the lung and the chest wall. Okay, the chest wall usually is more rigid. If you see the third image here, the posterior part, which usually comprises of the rib cage as well as the vertebra, is said to be very rigid. That is, the distensibility of this part of the thoracic cage is very poor. So when you're ventilating this patient in a supine position, the most this gas exchange that can happen is mostly anteriorly, because the anterior part of the chest is more compliant. Okay, and that can help in better gas exchange. But unfortunately, what happens is a pendulum phenomenon wherein the alveoli, which are already distant, will get more ventilation as compared to the ones which have been collapsed. So that is one of the other things which have been offset by prone ventilation, wherein if you put the patient in prone position, the better compliant part of the chest wall, that is the chest wall, which can come into the recruitment, or it can expand as we do ventilation, that is placed in the prone position, and that is in the dependent position, that can still expand and better recruit more alveoli. Okay, so by this what happens is there will be a homogenized ventilation that can be set in. The whole part of this would be to help recruit more and more alveoli, which in turn, with the presence of better perfusion, will improve oxygenation. So coming again, we need to know firstly, it's the gravitational changes that we need to consider. Okay, that is the anterior mediastinum having its effect on the posterior part of the lung. Then the abdominal contents similarly having the compression effect on the posterior part of the lung, and then the chest wall mechanics that we need to consider. That is, the anterior part of the chest wall is more compliant, which can help in better gas exchange and movement when it is placed in a prone position. So I hope you are with me till now. So coming to the core concept of today's class, that is physiology. How does it help in gas exchange? How does it help in carbon dioxide clearance? What is the improved lung mechanics that we see? What are the better hemodynamics, or what are the hemodynamic considerations that we need to have in prone position? So a question can come as, what are the physiological consequences of prone ventilation? So you might have to answer them under these headings. Okay, so firstly, gas exchange is what we need to consider. We all know gas exchange is usually both oxygenation as well as carbon dioxide clearance. So oxygenation, quite clear. We have already mentioned about dorsal recruitment and preservation of perfusion. I'll be talking about preservation of perfusion when I speak to you about hemodynamics. Okay, coming to the concept of carbon dioxide clearance. So when you have carbon dioxide clearance, you can consider two scenarios where the carbon dioxide clearance is present, wherein it leads to decreased alveolar improved alveolar ventilation, and the CO2 level will be released. That is, it is decreased. Whereas if you see that there is no carbon dioxide clearance, it can be as similar to which is seen in the supine position, or in fact, sometimes it can be more than that. Okay, so sometimes what can happen is if the patient has a lot of secretions, or if there is a dense consolidation which is being present in prone position, the carbon dioxide can get retained and it can cause hypercapnia. Okay, so this is what we see. So in case there is better recruitment, there is better alveolar ventilation, the CO2 level will decrease. So how does that happen? Both oxygenation and carbon dioxide clearance will happen when there has been recruitment, better ventilation, and that leads to better CO2 clearance. Okay, so this is about the concept of gas exchange in prone ventilation. Okay, remember about oxygenation, remember about carbon dioxide clearance, also mention about perfusion. Okay, so coming to lung mechanics. Lung mechanics, the most important thing that we need to know under these three headings, that is homogenization of the transpulmonary pressure, thorax and the lung shape mismatch, and the lung mass distribution. Okay, I think so. Thorax, lung shape, and the lung mass distribution you might have understood in the initial slide, which I showed about the effect of the anterior mediastinum as well as the thoracic cage. So we are speaking about transpulmonary pressure. So what do we mean by transpulmonary pressure? It is nothing but the alveolar pressure minus the pleural pressure, the difference which causes the air to enter into the alveoli. That is what is important. So consider the particular scenario. You have a patient who has an isolated lung. Okay, so this is outside the rib cage. Okay, the triangle. So when you have an isolated lung which is being studied in supine position, you see there is homogenization of the alveoli. The red color here refers to the perfusion. The blue circles here refer to the uh, alveoli. Okay, so in an isolated lung, the effect of gravity on the alveoli is very less. Okay, but there comes a position when you have the thoracic cage here. Okay, so when the thoracic cage is acting on the pulmonary anatomy, that is the alveoli, you see that is there is a mismatch, or else there is a disparity in the oxygenation or the alveolar distension. As you can see, the anterior alveoli are better distensible as compared to the posterior alveoli, which is under the effect of gravity. Okay, so there will be some amount of shape mismatching. Along with this, we also have to understand the concept of perfusion. Here, blue refers to less amount of circulation. As it becomes more red, it is better perfusion. So this is something that you need to understand by this legend which is present in the corner here. Okay, so as we all know, when there is better perfusion in the posterior part of the lung as compared to anterior part of the lung. So, what happens in prone position? So, we all know in supine position, there is inhomogeneity in the alveoli which is present. Okay, and the effect of gravity causes increased VQ mismatch. Okay, if this is understood till here, we'll go to prone positioning. The first and most important thing that we need to know about is the blood flow remains the same. It doesn't get changed. That is, the local perfusion remains intact despite it being anterior or posterior. Okay, even in prone position, the better perfusion is seen in the posterior part of the lung, that is more recruited in the prone position. What surprisingly happens here is something called as shape matching. As you can see, as the time progresses, you have better shape matching which sets in, and it is almost like a homogenized picture, which is similar to that of an isolated lung. So, this is one of the most important things that happens in prone positioning. Because of homogenization and shape matching, there will be easier ventilation because the transpulmonary pressure or the pressure required for ventilation would come down. Okay. So coming to the next two things, that is the thorax lung shape mismatch and the lung mass distribution. As I've already told you earlier, the effect of the lung uh, because of the abdominal contents like the liver or the anterior mediastinum structures like the heart falling onto the posterior part of the lung would be offset in prone position, wherein better compliance is achieved. The most important thing here you need to remember is about the anterior part of the thoracic cage, which is more distensible, because of which the posterior part of the lung gets better aerated. Similarly, the anterior part of the lung also gets, uh, you know, better aerated, not like the posterior part of the lung. What happens previously here is this is a rigid structure here, correct, in the supine position. Because of the rigidity, also the expansion of the alveoli would be lost. But what happens in prone position? Because the anterior part of the chest wall is compliant, this rigidity is lost, and better distension of the alveoli can happen, wherein it decreases the ventilation perfusion mismatch. Is it clear? Okay. So, in general, this is what you need to understand. There is imbalance between shape matching gravity and the superimposed pressure, which usually happens in supine position, which is offset in prone position. Okay. The most important thing is the shape matching, which happens, because of which there's better recruitability and better oxygenation, which is seen in prone position. Coming to the last part of this physiology of prone ventilation, that is hemodynamics, we all must remember the first and foremost thing is there is no change in the regional circulation. That is, the posterior part of the lung, which is more recruitable in prone ventilation, is better perfused even on pronation. Okay, there will be better perfusion in the posterior part even in supine position. Okay. Coming to the systemic circulation, what usually happens in systemic circulation is, because when you prone the patient, there will be a shift from the splanchnic circulation. When you change the position, there will be increased pulmonary artery occlusion pressure, and there will be decrease in the physiological dead space, which converts the West Zone 2 to West Zone 3. We'll be discussing about West Zones in later sessions today, so you'll be able to understand. What usually this part you need to understand is uh, the alveolar pressure is more than the venous pressure. Okay, so this helps in better oxygenation, which actually sets in and changes the West Zone 2 to West Zone 3. Okay, and because of this, there will be increased CO2 clearance. Okay, decreased hypoxic pulmonary ventilation, as mentioned earlier in the session, and because of which there will be homogenization of the ventilation perfusion. Okay, so remember there will be increased circulation into the systemic part, especially towards the lungs, because of which the conversion of West Zone to West Zone 2 to West Zone 3 will be present, because of which there will be better ventilation that happens, that actually increases the CO2 clearance. And because of homogenization of the ventilation and perfusion, it leads to increase in ventilation and perfusion. That is, the mismatch is lost. Okay. So this was actually studied by Gattinoni way earlier. Okay, probably this was one of the earlier monographs that had come in. Okay, and 20 years later, he actually published another study. This is in 2021, quite recently, and this gave us an evidence beyond any doubt. Okay, understanding all the physiology. That time, probably it was just a theory, probably just a hypothesis. But over the span of the last 2 decades, all of this has been quite established. So, in summary, if any question is asked about physiology, in supine position, there is lower PaO2 to FiO2, elevated presence of partial pressure of carbon dioxide, low lung compliance, and heterogeneous lung aeration. But prone, what happens is there will be better, you know, ventilation perfusion that increases the PaO2 by FiO2. That is, your Caricos index will be usually improving if the prone is effective. Lung compliance will be better, and there will be a larger amount of homogenized lung. Okay, so this is what has been established even after 20 years. So this is the reason probably Proseva was one of the earlier trials to give mortality benefits with patients with ARDS. So what they did in the Proseva trial was this: they looked into certain parameters in supine position and prone position. Okay, so they checked the thing both in supine position itself, but this the second part which you see here is after 18 hours of proning. So the PF ratio before proning was roughly around 74. The carbon dioxide was around 54. The plateau pressures was around 27, and driving pressures was 21. Okay, so this, if you look at this picture, after 18 hours of proning in the Proseva trial, what they looked at was there was significantly improved oxygenation, okay, thereby also reducing the plateau and the driving pressure. So this is something that was achievable by prone ventilation, and probably this combined effect had the mortality benefit which was seen. So indications when and in whom to initiate prone ventilation. I know you guys cannot unmute, so that's the reason I'm just going to make it a little fast. Okay, so the indications for prone ventilation, we all know. Whenever there is a PF ratio of less than 150, probably you might have to think about proning the patient. 16 hours of proning is usually recommended, and it can be increased up to 24 hours, but you also need to know there will be a lot of nursing issues, or there will be a lot of other pressure related issues that can happen for prolonged proning. Okay, one thing that need to understand is uh, whenever this patient is planned for proning, always make sure that you oxygenate the patient with 100% oxygen, and then you can start titrating based on the response. Okay, so in the Proseva trial, what criteria they used is if the PaO2 FiO2 ratio is less than 150 millimeters of mercury, especially after 4 hours of supinating, with a PEEP and FiO2 cutoff of 10 centimeters and 60% respectively, they probably thought that the prone position can be discontinued. Okay, so this is one of the cutoffs that we thought for discontinuing prone, but the by and large criteria for initiation is the PF ratio less than 150. Okay, so uh, longer hours can be considered only if you have adequate people to help you monitor these patients on prone ventilation. Okay, so okay, so always make sure there is no inadvertent compression of the abdomen, and especially the eyes and the cheeks. These are prone to have some pressure sores. Okay, some amount of reverse Trendeling position has shown to have a better ventilation perfusion matching. Okay, nursing care, you need to remember always, the pressure points have to be padded perfectly. So you can use one of these checklists that have been given. Most of the NHS hospitals do have this. Okay, so you can use this for the bedside checklist, so that you can prevent any inadvertent issues that can happen during proning. Okay, so always remember, the person who is starting the prone has to mark in a few things. That is the time of proning, what are the ventilatory parameters prior to proning. Okay, this can help the person coming after you to understand whether there is an improvement in oxygenation or not. Also keep and check about the ventilatory parameters like the driving pressure, plateau pressure, etc. Okay, so that can help in understanding whether prone was beneficial or it wasn't. Okay, what are the contraindications? Broadly, it is divided into two. That is absolute contraindications and relative contraindications. The absolute ones are unstable spine fracture, open chest. Okay, uh, ECMO. Mostly, if you have people around, you can still do prone ECMO. But yeah, if you have a central cannula, if that is occluding, then probably it might not be a good idea to do proning. Relative ones are hemodynamic instability, abdominal wounds, long bone fractures, okay, morbid obesity, late-term pregnancy, recent tracheostomy for the early issue that it might get dislodged, and it would be catastrophic if the patient's airway is lost in prone position. Raised ICP or anything associated with brain, like a recent trauma with a large traumatic brain injury, is also a relative contraindication. But always remember, in prone position, if there's a head low position, which is usually offset by the reversed tendon limber, there is a risk of raised ICP that can be seen. Most of the times, I think so. People who have been doing proning quite often will see, right? We usually have a swollen face, swollen eyes, if not, looked into all of this. Okay, so these are the contraindications for proning. As I've told you, ECMO, there have been a lot of evidence. Recent 90-day, mortality has been established by meta-analysis by Coombs et al. Only thing is there needs to be a perfusionist always round the clock present. Like in any case of ECMO, probably you need more staffing. These are the things that we need to consider. But there has been definite indications of better outcomes with ECMO and proning, which are done together. Okay. How do you check for improvement? What is the cutoff? Usually, what they say is any 20% improvement in oxygenation should be a good enough indicator for established better outcomes or a successful prone ventilation. That other thing that you can use is a tool like oxygenation index. If you see that the patient's oxygen index is more than 20, probably it indicates a severe oxygenation index, or that is, this patient might worsen and might need a ECMO. So if it's more than 25, consider ECMO in such cases. If the oxygenation index has reduced by roughly around 20% after proning, it gives you an idea that this patient can be prone successively. Unfortunately, ProSeva or subsequent trials do not give the number of attempts that you need to prone. If the first attempt at proning has failed, can we do the next proning quite early? Or how many sessions of pronings are required? These questions are a little clinical oriented, probably has to be taken in a case to case scenario, and then can help us understand better. Awake proning, we have all seen the effects of awake proning in the recent pandemic of COVID. This is one of the protocols that have been used, that is the SPANK protocol. Whenever the PF ratio is more than 200, if the patient is on a high flow nasal oxygen, use the ROX index. If the ROX index is showing better outcomes, especially after a 3 to 8 hour period of prone intermittently in the day. You can continue doing prone ventilation for patients on HFNO as well. Whenever you see that the ROX index is less than 3.85, or the PF ratio is less than 200, or the saturation drops below 90%, as which is seen here, it indicates failure of self-proning. So these patients might have to be initiated on invasive mechanical ventilation, and thereby optimizing ventilator parameters on a supine position, and then probably, if that is also failing, can be considered for prone ventilation. Always remember, the SPANK protocol all starts with uh, measurement of ROX index, okay, and then go with the measurement of the subsequent ROX index at 2, 4, and 6 hours. If it is showing an improvement, continue and encourage the patient to do proning. If not, then you need to consider invasive ventilation. Always remember, in SPANK protocol, like in any case of severe hypoxia or moderate hypoxia, there will be no bathroom privileges. So the patients have to be cared at bedside. Coming to the evidence, this is just to complete because we have spoken a lot about this. There have been a lot of trials in ERDS prior to this. The earliest evidence for prone ventilation was in 1940s and 50s by Bryant. Okay. After that, in the 80s and 90s, there were multiple trials that was done. What they focused basically on was mortality benefits. But unfortunately, in 2001, the ARMA trial didn't still come in, and the tidal volume concept was not up to the mark. So they were still ventilating with 10, roughly here 10 to 13 ml per kg of tidal volumes. So that, along with the duration of prone ventilation being around 7 hours, did not give a mortality benefit. So that is one of the things or limitations, I would say, by the study by Gattinoni and Guerin himself in way back in 2001 and 2004. Here, I would like you guys to have a look at these two parameters. Okay, so the average tidal volume in both these studies, if you can see, is roughly around 12 to 13 ml, and the duration was also quite low. That is around 7 to 8 hours per day. So that is one of the reasons that probably they have not got any mortality benefit if you see in the earlier two trials. Okay, but this trial actually gave us the understanding that there can be mortality benefit with prone ventilation. What the major thing that we can see here is the tidal volume was reduced along with the stabilization criteria. Okay, so along with this, the duration of pruning was also important. So here they used a tidal volume lesser than that done by their predecessors, that is Guerin and Gattinoni. Along with that, the duration of pruning was roughly around 17 hours. So probably because of this, there was a significant improvement in mortality, that is 43% as compared to 58%. Okay, a similar things was seen in Tacon, but what they saw was it was not significant at that particular time. But we all know the landmark trial, that is the Proseva done by Guerin in 2013. It was stopped intermittently, I mean, in between itself because it gave us a good result, correct? So here we see the best tidal volume they could take in was roughly around 6 to 7 ml per kg. They had a 17 hours of proning which was given. Okay, so this showed us great mortality benefit. The number needed to treat was very low as well. If I'm not wrong, probably roughly around 7 to 10 was the number needed to treat. So this is about the evidence in prone positioning. So recently, Munshi et al. Actually came in with another question. There are a lot of issues which we see, in the recent pandemic and prior to that as well. Whenever patients were prone, there were issues related to nursing, issues related to bed sores or pressure sores. Okay, so they wanted to look at to a condition wherein lesser number of hours would have a better effect, similar to seen in the Proseva trial. And they came with the conclusion that even 12 hours of proning would be sufficient for reducing the mortality rate in patients with severe ARDS. Thank you. So the next talk I would like to do. There are two things. Okay, so there is SGLT2 inhibitors, which I feel is one of the questions which can come in your recent advances paper, or else there is AMR. Uh, I think so. We'll go with. Are you guys a little tired with this thing? You can answer in the chat box. You want me to do AMR or SGLT2 inhibitors? Either one is okay. Okay. This there's a question one of you have asked. Why does the blood flow not change in prone position? It's the anatomical mechanism. So even I tried to search for it. Unfortunately, I didn't get the answer. If you can get that answer, it would be helpful. But what we need to understand, it's the physiological principle. It does not change. Probably it's like a dictum. So that is one thing. Even I could not find the answer, Dr. Arun. Okay, so going on to the next session on antimicrobial is my slide visible? Okay. So this was another thing that we thought might be asked in your exams for people who have already attended this class in the top sessions. It's a revision like the prone ventilation again. Coming to the basic understanding of antimicrobial resistance, we all know there have been a lot of antibiotics that are present, which we are using day in and day out, right? So there will be drugs which are acting on the cell wall, cell membrane, or probably the protein synthesis like the 30S and the 50S subunit, or the nucleic acid pathways like the fluoroquinones acting on the DNA topoisomerase, so on and so forth. Probably 20, 30 years ago, this was not much of a nuisance, but currently in the scenario wherein the number of antibiotics available in the pipeline are going lower and lower and it's getting drier, we need to consider, the effects of antimicrobial resistance. So first thing, how can bacteria resist antibiotics? Mainly, there will be two ways that the bacteria resist the antibiotics. That can be the first way. It can prevent the antibiotic reaching its target site, like I've mentioned earlier, right? It can be the cell wall, the cell membrane, or the target sites, or the protein synthesis pathway. It can prevent the antibiotic from reaching the target site. Okay. The other way it can resist antibiotics is it can modify or bypass the target itself. Okay. So this is the two things majorly by which bacteria can resist an antibiotic. So when do we call an organism as a resistant strain? A bacterial isolate is considered as non-susceptible or antimicrobial agent to a particular antimicrobial agent when it does not meet the particular breakpoint which has been given to us by the UCAST or the CLSI. So there will be certain inhibitory concentrations and bactericidal concentrations which the UCAST would release quite frequently. Okay, the recent one being in 21-22, and in that, whatever is the cutoff which is mentioned, that if the bacteria is unable to be lysed at that particular concentration for that agent, then we call that agent as resistant to that particular bacteria. Okay, so I'll repeat myself. Whenever you have a particular bacteria which is not susceptible to an agent at a particular concentration as defined by clinical breakpoints given to us by UCAST or CLSI, then we call that organism as a resistant strain. Okay. So the susceptibility and resistance is usually measured as a function of the minimum inhibitory concentration. Okay, so the bactericidal concentration is something that we see, wherein 99% of the bacteria should be lysed. So inhibition is usually the other function that we look into. Okay, so what you need to understand by minimum inhibitory concentration is it's the lowest concentration of an antimicrobial agent that inhibits the visible growth of the microorganism in vitro. Okay, it can be held. Usually, this is what is used to understand the susceptibility testing. Okay, so whenever you use a Molotov, etc., that takes into the MIC as the criteria to give you a susceptible, resistant, or an intermediate report. Okay, are you guys with me till here? Okay, so going on to the definitions of what are MDR, XDR, and PDR. MDR, also known as multi-drug resistant. It can be either a gram-positive or a gram-negative bacteria, which is resistant to three or more antimicrobial classes. Like it can be cephalosporins, it can be carbapenems, it can be any other glycopeptides, etc. So one of these antibiotics or aminoglycosides, if it is three or more antibiotic classes the bacteria is resistant to, then they get classified as MDR. Okay, if what is extended resistant bacteria, wherein they will have susceptibility only to one or two. Here you need to remember it is resistant to three or more. Here in extended resistance, it is susceptible to one or two categories only. Okay, so probably one or two drugs are only present for the action of these particular bacteria. What are pan drug resistance? These is something that most of us are facing quite often. So here, no agent tested would come as susceptible for that particular organism. Okay, MDR, three or more resistant microbial classes. XDR, susceptible to one or two categories or classes of drugs. Pan drug, no agent which has been tested is susceptible. Okay. Coming to the types of resistance. So we need to know there are two types majorly, that is natural and acquired. In natural type of resistance, it is innate or it can be mediated or induced. In acquired, it is defined by multiple ways like translation, conjugation, transposition, and mutation of chromosomal DNA. So, what usually happens is natural is something that can be given to the daughter progeny of the bacteria by the mother bacteria. Okay, that can be innately given or it can be induced to the bacteria. This is usually by the vertical transmission. Acquired can be both vertical or horizontal, which can be by these methods, that is translation, conjugation, transposition, and mutation of the chromosomal DNA. Okay, we'll be discussing a little further as well on this. Okay, coming to the mechanism of antibiotic resistance, usually it is by drug uptake limitation, drug efflux. Okay, what do you mean by drug uptake limitation? Usually you give an antibiotic to a patient, okay, that has to act on the target site. If it has to act on the target site, say suppose it is the aminoglycosides, it has to go to the protein binding, that is the 30s ribosomes or the 50s subsegment. Okay, so if it has to go to that particular ribosomal unit, that can be broken down or it can be inhibited by the resistance pattern. So that is called as drug uptake limitation. Sometimes it can also be drug efflux. What happens is there will be efflux mechanisms that the bacteria would have taken in. What is the understanding of efflux? Just understand it like bacterial vomiting. Okay, the drug goes into the bacteria and the bacteria vomits out that particular drug. The drug was intended to kill the bacteria, but the bacteria outsmarted that and it starts throwing out that particular drug. What is the other way that it can develop? It is drug inactivation. The bacteria here outsmarts it again. The drug is taken in, okay, but it will develop some types of enzymes, or it would alter the target site or do other resistance patterns, and it inactivates that drug. So that is another type of antibiotic resistance that sets in. The last thing is the target site modification. It becomes oversmart in that position wherein the drug was supposed to act at a particular site, and that requires certain areas of matching, right? So, for example, if you take in a cell wall, you need a DLNN, DLNN type of a pathway for a particular type of a, say, suppose a cephalosporin or a penicillin to go and act on, right? Or the peptidoglycan layer. So that layer would get modified. Okay. So because that gets modified, the antibiotic just gets confused. It doesn't get a target site to act on, wherein the bacteria becomes immune to that particular antibiotic. Okay. So as the mechanism of antibiotic resistance clear, you have drug uptake limitation, drug efflux, drug inactivation, and target site modification. So this is what you need to write about mechanism of antibiotic resistance. Okay, so this is a pictorial depiction for whatever I have said earlier. Okay, so from the time it comes in, it can be blocked here itself. That is the decreased uptake. So say suppose there is a bacteria in which the drug outsmarts this and it gets inside. What happens? It can throw the drug out by vomiting. That is your efflux pump mechanism. Okay, so if at all this is come in and there is no active efflux, what can happen? There will be enzymes which can break this drug which is present here. Okay, that is the drug inactivation part. The last thing is the target site alteration. It can be either the genetic material which is present, or it can be anywhere in the cell wall or the cell membrane as well. Okay, I hope it's clear till now. Okay, the next thing is, what is the genetic basis of AMR? I told you earlier about mother and daughter cells, about horizontal transfer, about vertical transfer, so on and so forth, right? So before understanding that, we'll come on to understanding what are the genetic basis of antimicrobial resistance. You have two things which are important. One is the gene mutations, other one is the acquisition of the foreign DNA via the horizontal gene transfer, or that is the HGT. Okay, so before understanding all of this, if you have understood whatever I've spoken to, just imagine that you have a bacteria, which is a very smart bacteria. It's probably of an MDR or a PDR variant, okay, or even XDR variant. It is a resistant bacteria. What are the mechanisms by which it can resist antibiotics? Firstly, by phenotypic resistance. That is the physical way, okay? That is the phenotype. It can develop some biofilms, etc. It can form something called as persisters, or it can cause something as swarming. Okay, these are the mechanisms by which it can phenotypically prevent the antibiotic from reaching the particular bacteria. Intrinsic resistome is what we are talking about in the present class, along with acquired resistance, which is mutations in gene transfer. Okay, so genetic basis, we spoke about chromosomal gene transfer. What usually happens is there are three different types of genes that we need to consider. That is for the target site of the antibiotic, genes encoding for the transporter of the antibiotic, or the regulator or the expression of efflux pumps, porin channels, etc. Okay, so it can be any genetic modification in the target site, transporter of antibiotic, or the regulator of expression molecules. That is the efflux pump or porin channels. Okay, this is the chromosomal gene mutations. What is about the horizontal gene transfer? That is the HGT. It is through the transfer or acquisition of foreign DNA through the transfer, that is usually a horizontal transfer between the bacteria of the same generation. Okay, that is another way of genetic basis of antimicrobial resistance. Okay, remember genetic basis, two things, chromosomal and horizontal gene transfer. And chromosomal, usually chromosomes have genes, right? So the genes can code for target site antibiotic mutations, transporter mutations, regulator mutations. Okay, coming to gene mutations per se, that can be either intrinsic, acquired, or adaptive. Okay, so we all know there will be a lot of things that have been spoken quite in time in and time out, right? There are certain antibiotics are intrinsically resistant to certain organisms. So what do I mean by intrinsic resistance? It is the inherent natural capacity of a bacteria to show resistance to a certain class of antibiotics without having any mutations. Okay, it is inherently present for that bacteria. Okay, so what will happen is it will show inevitable resistance to a certain group of antibiotics. If at all there is an efflux pump or reduced permeability, which is usually involved for intrinsic mechanisms, this is the pathway by which it can show intrinsic resistance. The meaning of what I said is the intrinsic resistance can be because of reduced permeability or efflux pump mechanisms. I hope it is clear. Okay. Sometimes multiple drugs can show intrinsic resistance to a particular bacteria, and that can be explained by multiple efflux pumps. For example, you can have an efflux pump for cephalosporins, you can have an efflux pump for carbapenems, or you can have efflux pump for aminoglycosides. So sometimes certain bacteria can have multiple intrinsic resistance patterns. I will be showing you a slide for which you can understand. Okay. So here you can see that anaerobes are resistant to having a resistance to aminoglycosides. Okay, here the mechanism is by uptake inhibition. Similarly, enterococci also have resistance to aminoglycoside. Here, the problem here is oxidative mechanism is lacking in such places, wherein the uptake of aminoglycosides would be blocked by the enterococci. Okay. Similarly, you can think about gram-positive bacteria like probably streptococcus, etc., wherein the mechanism would be alteration of the penicillin binding protein, that is the target site for that particular type of bacteria. Vancomycin is usually resistant to gram positives, gram negatives, wherein the inability of uptake itself is present. Okay, the vancomycin will not be taken into the gram negative bacteria. So that is the reason why gram negative bacteria are resistant to vancomycin. Okay. Similarly, metronidazole can be resistant to aerobic bacteria, and we know that metronidazole is used for anaerobic bacteria, right? So why is it resistant to aerobic bacteria? It is because the ability to aerobically reduce the drug is lost in the aerobic bacteria. Okay, so usually there should be an anaerobic mechanism which is present. So that is not there in aerobes, right? So that is the reason why metronidazole becomes resistant to aerobic bacteria. Okay, I hope I have not confused you. Okay, just remember target site modifications would be there inherently present in that particular type of bacteria to a certain group of drugs. These are not something that they have acquired over time, or these are not genes that have been mutated. Okay, so we are talking about antimicrobial resistance, but this is something about natural resistance, that is the intrinsic resistance. Okay. Coming to acquired resistance. So till now we spoke about natural resistance. Coming to acquired resistance, we told about the acquisition of chromosomal gene mutation transfer that can happen by a horizontal gene transfer. Okay, that can happen in multiple ways like transformation, transposition, or conjugation. Sometimes, most commonly, what is usually seen as the plasmid acquired conjugation that happens, developing acquired resistance, which is usually seen in the escape group of organisms. So if at all there is a question they ask you about what is the type of resistance pattern which is seen in escape group of organisms, it is the acquired type of resistance, and the way it acquires it is probably a plasmid mediated mechanism which can be via conjugation. Okay, so understanding the types transfer of resistance in acquired it can be either vertical or horizontal. Okay, vertical is usually from a parent bacterial DNA to the subsequent progeny, that is the daughter cells. It can be plasmid mediated replication. Okay, so usually transfers the plasmid into the next particular daughter cells. Coming to horizontal transmission, it can be by multiple mechanisms. Here again, the vehicle would be a plasmid. Okay, so you need to know that there is a vehicle also which happens from the first progeny to the second progeny. In horizontal transmission, it is between the same generation of bacteria. So in this, what usually happens is multiple mechanisms like transformation, transduction, and conjugation. So what do I mean by all these things? So you see, these are bacteria of probably the same generation. So there have been multiple ways that the genetic material, here you see the plasmid, based on which that is being given to the subsequent progeny of bacteria, right? So what is conjugation? You see that two bacteria here, bacteria A and B probably, connect through the structures, okay? That is the cell membrane, and then transfer the genetic material. Here, this particular genetic material is transferred. This is called as conjugation. You need to have two bacteria. You need to have a connection between the two bacteria, especially at the cell membrane, and by which directly the genetic material is transferred to the next bacteria. Okay, remember this is in the same generation of bacteria. The next thing is the transduction. Transduction, the vehicle changes here. Okay, we saw that transduction can happen through plasmids also, but sometimes majorly what we see is conjugation. Conjugation, transduction is usually by the bacteriophage. I'm extremely sorry for that. The vehicle we were talking about was plasmids, right? Previously in vertical transmission as well as horizontal transmission. Here in transduction, the vehicle is the bacteriophage. What is a bacteriophage? It is a modified virus that can sometimes take in some genetic material from one bacteria to the other bacteria. So it usually takes into this from one particular resistant mechanism. It can be transferred into a bacteriophage, and that goes on to another bacteria and delivers this particular mutated gene into the other bacteria, wherein this new bacteria also develops the resistance pattern. So this is transduction. So transduction is by a vehicle, that is bacteriophages. The genetic material is transferred from one bacteria to the other by bacteriophage. Coming to transformation. So sometimes after a particular time, a bacterial cell would die, right? If the bacterial cell dies, but the genetic material is still present in the milieu, that genetic material can be taken up by the bacteria in the surrounding, and they can develop certain antimicrobial resistance. So that is called as transformation. Okay, so the bacteria take up pieces of DNA directly from the environment around the cell and they develop resistance. So that is called as transformation. Conjugation, you need to have two bacteria attached to each other, direct transfer of DNA material. Transduction, you have a vehicle, that is a bacteriophage, takes in the DNA from one bacteria, goes to the other bacteria, delivers the DNA material for resistance. Transformation, probably free lying resistance patterns like the DNA which is present by probably lice bacteria will be taken up by the surrounding bacteria and they develop resistance pattern, that is transformation. Along with this, there is another mechanism called as the integrons. They are site-specific open reading frames in the form of a mobile gene cassette. Okay, so this is also a part of transformation. So if they are present itself, they can be transferred into a particular bacteria. And they also can develop resistance. Okay, so these are the ways of acquired resistance that can happen. So summarizing, acquired resistance can happen in vertical, horizontal. Vertical most commonly via plasmid transmission. Uh, Horizontal gene transmission usually follows these three or four principles, that is conjugation, transduction, and transformation. Okay. Coming to the next part of resistance, that is adaptive resistance. Phenotypically, we all saw about biofilms, persisters, etc. Right? So it can happen because of large amount of bacteria being exposed to antibiotics in the environment, that is the livestock, poultry, etc. Okay, so what usually happens is we will also invariably get exposed to these antibiotics in a sub-inhibitory concentration. Okay, because of which there will be growth factor inhibitions which happens for the particular type of bacteria. and they would develop some amount of resistance for that particular time period. Okay, one great thing about adaptive resistance is it is usually reversible because the inhibitory concentrations for such drugs would be on the lower side, but there is no cutoff totally. Sometimes if the amount of antibiotics which is present in the environment is greater, we might be exposed to multi-drug resistant uh, bacteria. This usually what happens is if it's greater concentrations are present, it can develop the mutations because of which we will be exposed to resistance bacteria. So there will be instances. There have been instances right now. There have been multiple reports which have come in, especially with the use of colistin, etc., wherein you're seeing colistin resistant to totally colistin naive patient. Okay, in such cases, the only probable explanation that we would have is a adaptive type of resistance. Coming to the resistance patterns which is seen in the type of bacteria, we all know there are broadly classified types of bacteria into gram positive or the gram negative. So the resistance mechanisms which are primarily seen in gram negative bacteria are decreased antibiotic entry, which can be because of porins. It can cause spitting or vomiting of antibiotics, that is the efflux. It can cause target site modifications, or it can cause degradation of the enzymes. I mean, antibiotics by enzymatic action, that is the resistome. So, if there is a question asked about what are resistomes, give few examples. Probably you might have to talk about penicillinases, carbaphenemases, or any other enzymatic machinery that is present for inactivation of antibiotics. So, gram negative, you have firstly, there's blockage of the entry of the antibiotic into the cell. Next, you have removal of the antibiotic by efflux, target site modifications, and inactivation by enzymes. In gram positive, majorly what is seen as the enzymatic degradation and alteration of the target site of the antibiotics. Okay, this is by and large differentiating the mechanisms between gram positive and gram negative. In gram positive, also there have been many instances wherein efflux pumps, plasmid mediated resistance have also been mentioned. By and large, this is the larger understanding. Okay, so we need to understand that gram negative bacteria are inherently stronger bacteria as compared to gram positive in view of or in consideration with defense mechanisms. Okay, so we need to understand that gram negative cell wall, it usually has an outer membrane and a plasma membrane, which gives it an extra layer of protection, which is usually not seen in the gram positive cell wall. Okay, so that is one of the reasons that we see that gram negative organisms have a better uh, antibiotic resistance or fighting capacity as compared to gram positive organisms, wherein there might be a combination of drugs which can be still used for gram positive sepsis, and that can work. Okay, so this is in a large about what are the resistance patterns which I've already mentioned earlier. Okay, so that can be prevention of entry, efflux, inactivation, and target site modifications. Okay, so coming to the understanding of modification of antibiotic molecule. So it can be either by chemical ways or it can be certain enzymes which can happen. Okay, what happens in chemical modification of an antibiotic molecule? It can undergo any structural changes of the antibiotic molecule. So when I'm talking about modification by chemical methods, it is the structural change that happens to the antibiotic molecule. Okay, the molecule here means antibiotic molecule. The next part of modification is it's by the breakdown by certain bacterial enzymes. Okay, like cephalosporinases, beta lactamases, etc. So chemical degradation happens by these three processes, that is acetylation, phosphorylation, or adenylation. Okay, so majorly it happens in aminoglycoside type of antibiotics, which inhibits the protein synthesis. Okay, so addition of one of these groups by the bacteria, like an acetyl group or a phosphate group or an adenyl group, into the antibiotics makes it inactive. Okay, so bacteria are smart, wherein it induces these type of changes in the antibiotics, thereby making it ineffective. Okay, so this is called as chemical degradation of the antibiotic. Okay, so chemical degradation is done by the bacteria. It can be under these three processes, either by acetylation, phosphorylation, or adenylation. resistant group, usually making it inactive. Common drugs that you need to remember are aminoglycosides, chloramphenicol, and lincosamides. So these are the type of bacteria which usually puts in certain resistant mechanisms. You need to remember that acetylation is usually by the Enterobacteriaceae. Phosphorylation is usually seen in gram-positive bacteria. It is by the Staph aureus. Adenylation is usually seen in the gram-negative bacteria. That is the Pseudomonas type of bacteria. Okay. So this is what you need to understand. So chemical degradation is done by most of the bacteria belonging to gram-negative group. The gram-positive that you need to remember is the uh, Staph aureus type of bacteria. Okay. Enzymatic degradation, there are a lot of ways that we can classify enzymatic degradation into. By and large, they have defined it as hydrolysis, transferases, and redox enzymes. Okay, we all know beta lactamases, carbapenemases, etc. And we spoke about chemical destruction as well. So by and large, beta lactamases, we all know about Ambler's classification. In Ambler's classification, the major difference which we have, or the classification way, is by the type of the resistance molecule that has been considered. Okay, majorly the beta lactamases have been classified under serine as well as metalloproteinases. Serine metalloproteinases are class A, class C, and class D. Class B comes under metalloproteinases, that is the NDM types. Okay, usually what happens is here zinc is the metal which is present. Okay, so serine proteases are anything between penicillinases to carbapennemases. So what you can see here is carbapennemases, they can be present in all the classes from class A to class D. Okay, narrow spectrum of enzymes, that is the beta lactamases, are usually present in class A, to a certain extent, probably in class D. Okay, so this is by and large understanding the beta lactamases. Okay, so why we need to understand this, I'll be speaking about this in the later slides. Okay. So the other way that you can talk about is the functional group analysis. Okay, the functional classification was given by Bush, Jacobi, Medeiros. Okay, so he classified things into group one, group two, and group three. Group one was basically uh, AMC beta lactamases. Okay, that come under class C of the Ambler's classification. Group two consists of class A and class D. I told you basically wherever penicillinases came into picture, Bush Jacobi Medeiros put them into class the group 2. Group 3 usually consists of the metallo beta lactamases, that usually consists of zinc, that I told you. Majorly what you need to remember is the resistance pattern of NDM. Okay, so this is what we need to remember. Why we need to remember the classifications is probably to choose the type of antibiotics in the longer run. Okay, I will be just giving a brief update about this. Okay, coming to spice group of antibiotics. So we were talking about Bush-Medeiros classification here, and we talked about AMC beta lactamases being the functional group 1. Okay, so we all know there is something called as the spice group of organisms, and they are intrinsically resistant to chloramphenicol, ampicillin, penicillin. Okay, spice usually is an abbreviation for Serratia, Pseudomonas, Acinetobacter, Providentia, Proteus or Morganella, Citrobacter, and Enterobacter. The I there stands for the indole production or indole producers. Okay, so these bacteria usually have the intrinsic resistance to the above antibiotics. Whenever these bacteria have been exposed to probably the first or the second generation cephalosporins. Okay, so they probably develop AMC induction mechanism, that is usually chromosomal or plasmid mediated. Okay, so because of which they develops antimicrobial resistance in the long run. So you have to be very careful about these group of organisms. Whenever you have resistance which is seen for most of the organisms, if they are falling under this spice or the space group of organisms, the most common resistance pattern would be AMC induction. In that case, you can just, for understanding purposes, you can ask for history of exposure. In this day and era, most likely they would be exposed to oral cephalosporins for some or the other reason, and probably that might have been the point in which they have developed antibiotic resistance, probably by one of these mechanisms I mentioned, that is either chromosomal or plasmid mediated. So remember, spice group of organisms, AMC induction is the thing that we need to worry about. Okay, in such cases, we need to know that they will be intrinsically resistant to chloramphenicol, ampicillin, and penicillins. Okay, based on this, you need to choose your antibiotics as per your antibiogram which is available. Okay. So coming to the next part, so we spoke about permeability, degradation, and about beta lactamases in general. Now we are going to penetration problem and issues, that is the efflux pumps problem. So you know that efflux pumps are the ones which can usually vomit out the antibiotics, correct? So you have seen the diagram about the gram negative and the gram positive organisms. Usually efflux pumps are located as a transmembrane protein. Okay. Before that, before the efflux pump, first thing we need to consider is about entry of the antibiotic into the bacteria itself. That is the first line of defense. So what usually happens is in gram-negative bacteria, certain cytoplasmic membrane changes itself would be present. Okay, so that will make the bacteria stronger, and it would be like a protective layer preventing the antibiotic from entering into the uh, bacteria. Okay, so this penetration effect, which has been offset by the alteration in the membrane effect, gives it an additional defense mechanism. Okay, so that can happen either in the outer membrane and the periplasmic space, or the cytoplasmic membrane or the cell membrane. Okay, so this is majorly seen in the gram-negative bacteria. Okay, so because of which it can usually prevent the antibiotics totally from entering into the periplasmic space or the cytoplasm. Okay, so this is the first line of defense. Okay, so this is penetration. Okay, so firstly it prevents the entry itself, so it prevents the penetration of the antibiotic into the bacteria. Okay, the next thing that we need to understand is about porins and efflux pumps. Okay, porins, they are transmembrane proteins, which you have seen here, right? So they are present here in the outer membrane. Okay, so they usually selectively allow the movement of certain molecules. Chemicals which have a molecular weight of more than 600 daltons usually are prevented from entering into the cell itself. Okay, mostly that is one of the reasons why gram negatives are inherently, resistant to vancomycin, that is a glycopeptide, or a daptomycin, that's a lipopeptide. Okay, usually both of these drugs have a higher molecular weight, and because of which it cannot be passed on. Okay, so that is the mechanism by which porin channels can act. Okay, porins can be two types, that is specific and non-specific. The specific type can be either based on specificity to the bacteria or the specificity to the function. Example being outer membrane protein porin, that is D. Okay, non-specific, they are common to all gram-negative bacteria. There can be OMP-A, OMP-F1, OMP-C. Okay, so these can be present in most of the gram-negative bacteria, and based on which they would develop antimicrobial resistance. Okay, so purine mutations have significant impact on the development of carbapenemase-resistant Enterobacteriaceae, usually combined with other resistant mechanisms. Usually, you don't see just the purine mutation. Probably you might see a purine mutation with a target site modification or penetration modifications, etc. Okay. One important thing that we need to remember about porins is what is antibiotic trapping. Okay, what usually happens is, uh, if the porin expression is low, okay, the drug can still enter. For example, you have a gram-negative bacteria which is sensitive to carbapenems. What happens here is the carbapenems pass through the porin channel, enter into the periplasmic space. But because there is a higher expression of an other resistance pattern, in this case, probably an enzyme, that is the beta lactamase or a carbapenemase, this gets stuck between the outer membrane and the inner cytoplasmic membrane, and this gets collected in the periplasmic space. Okay, so this is called as antibiotic trapping. The antibiotic is trapped between the two layers of the bacterial cell wall, that is the cell outer cell wall and the inner cell membrane. Okay, so this is something which happens when the porin expression is low. whereas the antibiotic resistance of beta lactamases or carbapenemase is very high. Okay, this is one of the other ways by which antibiotic, even though sensitive, can be turned as resistant. Okay, so it can be ineffective. Okay, there will be one thing that we all notice, right? So sometimes pseudomonas, if you have seen, you get this report. Okay, you get a report telling that the patient's you know, resistant to imipenem but meropenem sensitive. Can this happen? We have seen this majorly. How do we explain this? Okay, this can be explained by the porins and the channel. So usually what happens, there will be a specific protein for pseudomonas, that is the OMPD, that is the outer membrane protein D. Okay, so it just gets transferred horizontally by horizontal gene transfer, and this sporin transfer of resistance mechanism prevents the inactivation of imipenem. Okay, so this is something that has, it is specific only to imipenem. So what happens is this specificity of imipenem makes it sensitive to meropenem, which is of the same antibiotic class, that is the carbapenem. Okay, so since it is specific porin, which is the OMPD, it can only prevent imipenem from entering, but carbapenem can pass. Sorry, meropenem can enter this. Okay, so this way of resistance pattern can be explained by the porin specificity. Okay, I'll repeat it again. Whenever you have a report of imipenem resistant, meropenem sensitive, how is it that is possible? It is usually due to specific porin channels. In this case, it is the specific porin channel to imipenem, which is seen in Pseudomonas, in which the porin channel OMPD blocks imipenem but allows meropenem to enter. Okay, because of which it is seen as imipenem resistant and meropenem sensitive. Okay, and this type of gene transfer can be given to other bacteria of the same generation by horizontal gene transfer. Okay, coming to the next part, efflux pump. Production of bacterial machineries that are usually excluding compounds out of the bacterial cell wall. Okay, usually they vomit it out. Okay, there have been 5 major varieties of efflux pumps. Okay, the major facilitator superfamily. Okay, the small multi-drug resistance family, the resistance nodulation cell division family, or the ATP binding acids, and the multi-drugs toxic compound extrusion family. So they are different types of efflux pumps for the gram positives as well as gram negatives. Okay, so you need to remember that this is something that is really difficult to remember which forms for what. Just remember that whenever there is an efflux pump present, depending on the type of family, that particular type of antibiotic would be extruded or sent out of the bacterial cell, making it ineffective. Okay. So the next part of resistance pattern is the target site. It can be mutational changes of the target genes, enzymatic alterations, or target protection mechanisms. Mutational changes, like which is seen in fluoroquinolones. Okay, the gene encoding for a particular topoisomerase or DNA gyrase would be altered, making the fluoroquinolone inactive. Okay, so the next subsequent generation of the bacteria would develop this resistance pattern. Okay. Similarly, the mutational changes are also seen in linezolid, majorly in the ribosomal protein, and for rifampicin also a mutational change which is seen in the target site, usually the POP gene. Okay, which acts for the beta subunit of the RNA polymerase. Okay, so remember mutational changes, target site. The drugs usually are fluoroquinolones, linezolid, and rifampicin. So if someone asks you what is the mechanism by which resistance to fluoroquinolones or linezolid or rifampicin is seen, it is usually due to target site modification. The target site modification type is the mutational change in the enzyme, that is the enzyme machinery. It is DNA gyrase for fluoroquinolones, it is the ribosomal protein for linezolid, and it is the beta subunit of the RNA polymerase for rifampicin. Okay. Enzymatic alterations that can happen for target site antibiotics. It prevents the effective drug binding and action. I was talking to you earlier about the cephalosporins, penicillins, etc. Right, the DLN pathway, etc. So there will be some amount of conjugation or a Lego-like effect which happens. Okay, so that has to sit in. The antibiotic has to go in and set in a particular type of enzyme to make that machinery inactive. But that can be mutated by the bacteria, making that particular antibiotic ineffective. So this is also seen in fluoroquinolones, tetracyclines, and fusidic acid. Okay. There have been multiple mechanisms, especially seen in gram-positive organisms, wherein they bypass the target site and completely replace the target site itself. Okay, so what usually they do is, this is seen whenever you have trimethoprim resistance. Okay, the MRSA usually change the dihydrofolate reductase variants, and because of which it makes the trimethoprim resistant to MRSA at that particular type. So whole target site itself gets changed. So that is also a very smart way by the bacteria. Okay. So coming to the overview, aminoglycosides, there are multiple mechanisms: plasmid mediated, or even drug resistance by target site modification. Quinolones, you see plasmid mediated modified enzymes or the target site. Okay. Coming to beta lactams, you know beta lactamases, which are acquired types probably, and plasmid mediated, that is the horizontal, vertical transfer. Okay. Coming to polymyxins also have a lot of mutations that can be seen. Remember, plasmid mediated can happen in most of them except tigecycline. Okay, tigecycline, still there is no evidence for a plasmid mediation, but if things have changed, please excuse me. Okay, but when I read about it, the mechanisms by which it can do is efflux pump mechanisms and mutations in the target site. Okay. So in carbaphenemases, it can be multiple. Okay, it can be by modification in the penicillin binding site, efflux pump, enzymatic inactivation, and decreased penetrations, like we saw in the imipenem resistance, that is the porin channel, right? So that can be also seen in carbapenem types of resistance. So this is in just about the types of resistance which are seen in gram-positive and gram-negative bacteria. So coming to the management of MDR in ICU, I would be looking at a few drugs. Okay, the major point of this talk was to make you guys primed for what is antimicrobial resistance, and if at all a question about a certain drugs is given, how to go about. Coming to ceftazidime, if at all they ask you write a short note on ceftazidime, mention the class, antibiotic class, like it's a third generation cephalosporin. Tell what is its specificity of a certain antibiotic killing. That is usually whether it covers pseudomonals or not. Okay, usually they ask you another question. That another way of asking would be anti-pseudomonal antibiotics. Mention about its dose, mention about its mechanism of action. Okay, the dose of ceftazidime, we all know it is between 1 to 2 grams. Mechanism of action is inhibition of cell wall synthesis. That is, it binds to the penicillin binding protein. Okay, so if you know the adverse effects, please mention the adverse effects, especially for the development of C. diff diarrhea. It has been associated with neurotoxicity and renal toxicity. And by and large, if you're writing all of this, you would get some passing mark. If you want to get better marks, probably you have to include your pharmacodynamics, that is your ADME. Okay, absorption, distribution, metabolism, and elimination. In this particular thing, you can also talk about the PKPD principles. Okay, in this, most of the times it's ceftazidime, it's a cephalosporin, correct? So it acts over by time over MIC concept. Okay, so this is something that if you can add on, you would get better marks. You can probably draw in a chart as well. Okay. Coming to zavicefta, that is ceftazidime avibactam. We all know it's a beta lactamase inhibitor, usually used for MDR organisms. Okay, it can be included even for Pseudomonas. Typical dose is 2.5 grams eight-hourly. Mechanism, again, cell wall inhibition. Avibactam is the compound which is necessary for making ceftazidime work. Okay, avibactam also has an intrinsic capability of killing bacteria. Okay, that is one thing that we need to remember. Adverse effects, like most of the things, remember C. diff pneumonia is associated, C. diff diarrhea is associated with a lot of neuroantibiotics. Okay, you can write that. Nephrotoxicity depends on the type of metabolism this drug undergoes. Okay, and this also follows the T over MIC principle. So frequent dosing is necessary. Probably you have to maintain a target site concentration of more than 60 to 70%. Okay, for which you need to give frequent dosing. Ceftaroline is another type of antibiotic that comes under the fifth generation of cephalosporins. active against MRSA. That is the most important thing about ceftaroline, correct? So we need to write these particular nuances when they ask you about a particular type of drug. To go on about each drug would be difficult. That's why I picked up few newer ones. Okay, in this particularly, you need to mention about the action of this drug in on the PBP2A, which is specific to MRSA. That is why it becomes the killing bacteria, antibiotic for MRSA organisms. So mention the drug effects. In this, you need to remember it causes effect on the bone marrow, probably can cause neutropenia, thrombocytopenia, and in extreme cases can also be associated with hemolytic anemia. I am rushing a little because there's another talk that I need to cover. Okay, eravacycline. We all know this has been used for a lot of resistant strains like carbapenemase resistant Enterobacteriaceae and probably even Acinetobacter. But there have been recent evidences where it can actually show decreased effect and probably increase the mortality. I'll be discussing about the crab in the next few slides. Okay, it is a bacteriostatic drug. Remember this particular point about eravacycline. Okay, coming to Astrianum, it's a monobactam antibiotics usually used in MDR organisms whenever you have NDM positivity along with probably OXA48 or anything associated with this, carbapenemase resistant Enterobacteriaceae. So usually it inhibits the penicillin binding protein 3. Okay, that is, it further prevents the bacterial cell wall synthesis. Sulbactam, usually this drug is used for in combination, sometimes for the carbapenemase resistant Acinetobacter baumannii, correct? So that is one of the things that have been mentioned off lately, the dose being up to 3 grams every 6 to 8 hours. Okay, it inhibits the beta lactamase activity by certain bacteria, and then it makes the bacteria susceptible to the other compound. Probably you can use carbapenem or probably minocycline, etc., by which the bacterial lysis can be achieved. Okay, so cefiderocol is a siderophore cephalosporin. It is a cephalosporin. It doesn't come under any of the classifications as mentioned, like up to the fifth generation. It usually gets collected in the periplasmic space. Okay, so this is one of the game-changing antibiotics which is present in the current armamentarium. Probably this use has to be thought about before we, consider the use of cefiderocol. It has to be under the antimicrobial stewardship program before anyone can use it inadvertently. The dose is 2 grams TID. Mechanism of action is usually it's transported into the periplasmic space in which it binds to the penicillin binding protein and inhibits the peptidoglycan synthesis. Okay, it can also cause passive diffusion through porin channels. The adverse reaction which have been seen is pancytopenia and drug-induced liver injury. Okay, daptomycin, we all know it's a cyclic lipopeptide, which is usually used for VRA and MRSA. The dose being 4 to 6 milligrams per kg. The mechanism of action is rapid depolarization, causing the calcium-dependent manner. It causes bacterial cell membrane to get inactivated. Okay, that depends mainly on the calcium. Because of the membrane depolarization, it causes disruption of protein synthesis, which includes both the DNA and RNA synthesis. Okay, it is bactericidal but not effective in treating lung infection because it gets rapidly inactivated by the lung surfactant. Okay, so remember, daptomycin is not a drug of choice for any pneumonias. Okay, adverse effects, it can cause severe rhabdomyolysis and myopathy. Coming to management of MDR organisms, this is something which is from the latest 2024 IDSA guidelines. Okay, I just wanted to include this majorly in this talk. Okay, how do you treat Acinetobacter crab organisms? What is the current guidelines? The preferred drug they have told us any sulbactam containing agent. Sulbactam, durlobactam, if it is available, can be used, or else you can use imipenem cilastatin along with a sulbactam combination or a meropenem sulbactam combination. High dose minocycline over tigecycline has reported better outcomes with crab organisms. Eravacycline, which was shown to have sensitivity for crab, has been downgraded. Okay, there have been multiple trials which have been done, which has shown increased mortality with the use of eravacycline, for which currently the IDSA does not recommend the use of eravacycline for crab organisms. Okay, cefiderocol usually is considered as a last resort drug. Always use it as a combination therapy. Okay. Coming to carbapenemase resistant organisms, IDSA usually divides it into these headings like uncomplicated cystitis, pyelonephritis, urinary infection, okay, or else the resistance pattern in CRE, that is NDM positive or NDM plus OXA48. Okay, so usually uncomplicated cystitis, it's a usual go away, but whatever antibiotics that you have based on your local antimicrobial. But if you come to the resistance patterns, okay, that is your KPC, NDM, and OXA48. If you have a KPC type of organism, it's probably Zavicepta or Meropenem weberibactam or Imipenem cilastatin or Relebactam can be the drug of choice. Coming to NDM, I told you it is a combination of Zavicepta with Astrionum. Whenever you have OXA48 positive, Zavicepta alone would be sufficient. There is no need to add the monobactam, that is Astrionum. But if you have an NDM positive, that is your metalloproteinase, metallobeta lactamase, correct? If that is present, you need to make a combination of Zavicepta plus Astrionum. Okay. Usually, if you have only NDM positive, Avibactam Astrionum combination would be sufficient, but the availability of Avibactam Astrionum is quite rare. So that is the reason we have to add a combination of ceftazidime Avibactam plus Astrionum. In both these cases where NDM and OXA48 are present, the alternative drug which is present is cefiderocol. That is your siderophore cephalosporin. Remember, whenever you are considering tigecycline or avacycline, majorly it acts on lung soft tissue. Okay. Never consider the use of avacycline or tigecycline for bloodstream infection or urinary infection. Okay. So any solid organ, use tetracyclines. Okay. But if it is a septicemia or kind of an infection or urinary infection, probably these two drugs are inefficient. Okay. Majorly because it gets rapidly eliminated from these two sites. Role of polymyxin in CRE. Colistin is an excellent choice for urosepsis, but no role for combination antibiotics for carbapenemase resistance organism. Okay, so this is what has been said. Again, use of colistin alone or else with a combination has been a debate since long. Okay, depends on the MIC, depends on the antimicrobial pattern which is present. It's always better to use combination. Okay, but the combination when I'm mentioning it is about colistin with a meropenem, colistin with a carbapenem. Okay, that is what we are telling about. It's not for other combinations. The other combination, what we are trying to tell here is probably a tetracycline, like I mentioned earlier, or a cephalosporin. Okay. Coming to MDR Pseudomonas, coming to IDSA 2024 guidelines, they usually say that uncomplicated cystitis or pyelonephritis, it's one of these drugs. That is your combination of usually your BLBLI or carbapenem with a BLI. Okay, so that is one thing. But if you have a resistant strain like NDM, you have to go ahead with use of Zavicepta with Astrionum and cefiderocol. It is similar to what is seen in CRAB, okay, or CRE. What usually is said is a high dose infusion therapy of 3 hours is better. Okay, so usually cefepime, etc. When you're using, probably a longer dose would be better. Okay, um, there are multiple newer drugs like cefepime, enmetazobactam, etc. coming in. So whenever you're talking about such cephalosporins, they depend on time dependent killing, time over MIC. So giving an infusion therapy would be better. Okay. Stenotrophomonas, always remember here in these kind of drugs, your carbapenems are ineffective. So meropenem does not act on stenotrophomonas. The drug of choice would be trimethoprim or fluoroquinolone. Cefiderocol and minocycline have also been, effective against these bacteria. The other thing would be a combination of Zavicepta with Astrionum. But in this case, always save in your Zavicepta Astrionum. Okay. ESBLs, we know that the drug of choice would be carbapenems. Okay, there have been newer drugs which are coming into picture, that is ceftolozane, tazobactam, etc. They can be tried under such drugs. Remember your Merino trial for such things. Merino trial did give a non-inferiority, picture for piptas compared to meropenem. So that is something that I want you guys to still remember. Okay, thank you. I know I've exceeded my time, so without first making wasting some more time, I'll just go into the next topic. Okay, so SGLT2 inhibitors, I think so. People who are exposed to a large number of cardiac patients You might have seen your cardiologist prescribing these drugs. Along with this, you might have also seen these drugs with patient with diabetes, especially type 2. I'd be dealing it under these headings, that is mechanism, enrolling critical care with evidence. SGLT2 inhibitors act on the kidneys, that is the proximal convoluted tubule, especially the S1 segment. Okay, so what does it do? We all know that it acts on the proximal convoluted tubule of the nephron. Usually, the renal threshold for glucose is 180, right? And what do I mean by that? Until the threshold is reaching 180 milligrams per deciliter, the glucose will be still taken in and it will not be excreted. But what these SGLT2 receptor inhibitors do is they filter out 90% of the glucose at the proximal convoluted tubule. Okay, so this thereby prevents glucose reabsorption and results in glycosuria. What you need to understand is the renal threshold for glucose is lowered by SGLT2 inhibitors. Next important thing, because glucose is excreted, sodium reabsorption is also inhibited. Okay, so what usually happens is it inhibits the sodium reabsorption, thereby increasing the overall sodium load, because it causes natriuresis as well. Okay, so it causes glycosuria and natriuresis. Okay, because it does these two things, it has an effect on the energy expenditure. Because there is a loss of glucose in the urine, it can cause a calorie deficit, because of which it induces osmotic diuresis. Okay, and because of osmotic diuresis, what happens is the effective circulating volume is reduced, causing a drop in blood pressure. Okay, this is not a drop in blood pressure causing hypotension, but overall the preload is reduced in such patients. Okay, what are the physiological effects? In the glucose metabolism, it causes reduced blood glucose levels. It has caused decreased HbA1c levels. It improved the insulin sensitivity. Coming to the metabolic effects, it causes weight loss, reduced visceral adiposity, improved lipid profile. The cardiovascular impact, it causes reduced cardiovascular events by decreasing preload, better utilization of byproducts or the substrates. Okay, I'll be mentioning about them in the later slides. And improved heart failure outcomes. And it also caused decrease in the occurrence of atherogenic events, that is probably a long-standing nephropathy, retinopathy, etc. Renal protection has also been attributed to the use of SGLT2 inhibitors, that is reduced albuminuria. It preserves the glomerular filtration and slows the development of chronic kidney disease in diabetics and non-diabetics alike, both. Okay. So pharmacokinetic principles, it is usually oral administration. It has a rapid absorption. It is usually metabolized in the hepatic, it is in the liver, but it is a non-cytochrome P450 type of a metabolism. So there is no inducing action which has been attributed to SGLT2 inhibitors. The elimination is by the kidney, and the half life is roughly around 12 to 24 hours, depending on the type of SGLT2 inhibitors. The inhibitors are dapagliflozin, empagliflozin, canagliflozin, and tugliflozin. So there have been two generations. The common ones that have been extensively studied are in the first generation, that is the dapagliflozin and the empagliflozin. The second generation, it inhibits both SGLT1 and 2, that is your tugliflozin and the sotagliflozin. The dosage adjustments usually has to be considered in severe kidney diseases, especially when the GFR drops below 60. Okay, so most commonly what is used is dapagliflozin and empagliflozin. Once daily dose can be sufficient, usually starts with 5 to 10 mg. Okay, that is what we can start off with. For empagliflozin is 10 mg, we can go up to 25 mg. Dapagliflozin starts with 5 mg and we can go up to 10 mg. Canagliflozin is routinely not used, but in India, what is commonly used are these two, that is your DAPA and empagliflozin. Potential adverse effects which have been seen are the common ones are mycotic infections, probably urinary. It has been also associated with Fournier's gangrene. Urosepsis, it's a strict contraindication as well. If the patient has this, we cannot initiate them. Volume depletion, as I've already mentioned, it causes natriuresis and glycosuria, because of which there will be effective drop in circulating blood volume. So very rarely it has been associated with hypotension. So rarely there have been case reports of euglycemic diabetic ketoacidosis, acute kidney injury, and bone fracture. The American Diabetic Association has given a clean sheet to SGLT2 inhibitors. It said that the benefits outweigh the risk with the use of SGLT2 inhibitors. So, euglycemic ketoacidosis should not be one of the things that we keep in mind and prevent the use of SGLT2 inhibitors. Okay, so this is the risk and benefits that have been seen with SGLT2 inhibitors. A role in critical care. Okay, we all know the hemodynamic effects is because of the natriuresis and the diuresis. By causing glycosuria or uricosuriya, it decreases the insulin resistance, decreases body weight, increases in ketosis, which is actually a substrate for cardiac metabolism. And these two things combined, that is the hemodynamic effects and the metabolic effects, reduces the risk of heart failure. Okay, so usually it's a bidirectional thing which happens. It is both renoprotective and cardioprotective. Okay. In heart failure, what usually happens is we know that the effective circulating volume is reduced. It also, inhibits the sympathetic nervous system activation, wherein the cardiac afterload is reduced, okay, and the arterial stiffness which is seen, that's also reduced. Because of the initiation of SGLT2 inhibitors, the substrate utilization is shifted from glucose to ketones. Okay, ketosis would be set in these patients, and this ketones is a more efficient fuel for the cardiac myocytes, thereby increasing the efficiency of the utilization of substrate and decreasing the demand for oxygen. And this is one of the reasons wherein there have been mortality benefits associated with the use of SGLT2 inhibitor. Okay. Also has been attributed to have anti-inflammatory and anti-fibrotic effects. And because of all of this, it has an overall reduction in hospitalization, mortality, and prevention of disease progression. Okay. So initiation criteria depends on prevention criteria, active management, or in cases of advanced heart failure. In Whenever you have a patient with diabetes and IHD, probably it would be wise to start this patient earlier on SGLT2 inhibitors like dapagliflozin, because long term the development of heart failure in such patients has been shown to have reduced. So what happens if the patient is already a case of heart failure? It has been shown that multiple trials with the patient having an EF of less than 40% with a symptomatic heart failure, the use of SGLT2 inhibitors have prevented further worsening and have reduced the length of hospitalization and development of other organ failures. Okay. Coming to comorbidity assessment and risk stratification, it has been used in most of the patients, be it obese patients, patients with CKD, patients with renal dysfunction or metabolic derangements, even in elderly age group or patients with poor reserve. There have been good outcomes with the use of SGLT2 inhibitor. Okay, so whenever you have an EGFR more than 30 with a moderate renal impairment, you can keep a watch on these patients. No need to stop it. But if it goes to end-stage renal disease, probably you might have to stop the use of uh, dapagliflozin or empagliflozin. Okay, it can be used in both diabetics and non-diabetics. Okay, so it prevents further worsening of the cardiovascular events. Okay, so there have been multiple trials which have been shown. That is the DAPA trial and the Emperor trial. Okay, in the DAPA trial, heart failure trial was done in patients with reduced ejection fraction. The Emperor and Deliver trial were done in preserved ejection fraction. Both of this showed significant outcomes. Okay, so remember that it's a class one recommendation, or sorry, for the use of SGLT2 inhibitors in patients who have been diagnosed with heart failure. Okay, current recommendation is one of the things that has to be used in the first line therapy along with your other drugs. Okay, your four pillars of heart failure, that is your beta blockers, mineralocorticoid antagonists, okay, your ARNIs, which will be discussed later on, and diuretics. Mechanism in CKD, you know that it restores tubuloglomerular feedback. Along with that, it reduces the glucose threshold on the kidney, wherein it prevents the oxidative stress which is present on the kidney. And because of the metabolic effects, that is improved glycemic control, the small vessel damage, which usually leads to worsening of the kidney function, that will be prevented by the use of SGLT2 inhibitors. Okay. multiple trials like the DAPA CKD trial and the Credence trial has shown benefits with the use of SGLT2 inhibitors even in the patients with CKD. Okay, metabolic pathways. I have already mentioned insulin sensitivity is increased, glucotoxicity will be decreased, ketogenesis is decreased because ketones get utilized by the cardiac myocytes. Okay, there will be potential risk of decay, but there have been a subset of patients wherein it can also reduce the incidence of diabetic ketoacidosis if the hydration and adherence to other OHAs or insulin is proper. Okay, we all need to know whenever there's a patient on ESRD, stop SGLT2 inhibitors. Always look for development of UTIs in these patients. If there is UTI, please discontinue. There have been case reports of Fournier's gangrene in such patients. Probably we have to stop this, treat the infection. Thereby, after this, probably need to consider whether to continue or not. These subset of patients, probably it would be counterintuitive to continue SGLT2 inhibitor. Okay. So heart failure, AKI prevention, sepsis, hyperglycemia management are the core areas in critical care. Okay. Always be aware of volume depletion. In case of severe sepsis with septic shock, probably don't initiate SGLT2 inhibitors at that time. Once the patient is stable, probably before discharge, you can think about it. Uh, DK, if the patient has developed DK, stop dapagliflozin. Instant renal disease, developing the need for renal replacement therapy, stop it. Okay. So this is basically from this journal. There are multiple trials and multiple review articles that have been present. Okay. I know I was a bit fast. If there's anything that you guys have not understood, please feel free to leave your message in the chat box. I'll be able to help you. Okay. Okay. I think so. Tapasar is waiting. Okay, there have been a lot of things.
Can anybody tell me what is ODC? Can you post in this your chat box? What is ODC? Lactate physiology, tracheal anatomy, and in that I would be also discussing about tracheostomy. Before that, a very honest question to all of you, because I always start with a little bit of bang. How is the Joes at this point of time, 1 month before your exam? Your 3 years of hard work is right now getting tested, and this is the last month of the your 3 months of extensive training. Your the perseverance, resilience, your all hard work, struggle that is getting tested, and we are here to witness that magnificent journey of your last 3 years, and we will be definitely helping you to cross this hurdle with flying colors. So the first topic that I am going to discuss is decoding oxyhemoglobin dissociation curve. And as you know, this is one of the favorite question from the physiology point of view, critical care physiology point of view. And this is not only significant, if I will be very honest, related to exam, but also as intensivist when we are dealing with oxygen, carbon dioxide, mechanical ventilation, hemoglobin, ABG. So it is something expected naturally from intensivists like us to know in detail about oxyhemoglobin dissociation curve. Now, so what is oxygen hemoglobin dissociation curve? If that will be asked in your exam next month on 17th of January, what you are going to write? It's a graph showing the relationship between PaO2 and hemoglobin saturation, which is SaO2. So it is a relationship curve or graph between PaO2 and SaO2. As simple as that. It's sigmoidal shape. The graph is of sigmoidal shape. I will be discussing in detail why it is sigmoidal. That reflects oxygen loading and unloading dynamics. So you just try to understand the words, because in your exam you cannot write maybe 3 pages, 4 pages about this type of, I would say, a very practical, very basic question. So there are sentences that you can remember, and I will be helping you with the art of writing in short, a very extensive discussion that would be summarized in one maybe paragraph. Now, this graph is of sigmoidal shape that reflects oxygen loading and unloading dynamics. In this graph, there are two axes, x-axis and y-axis. I will be showing you the picture also, the graph also. The x-axis is having PaO2 in millimeter mercury and y-axis is having saturation with this hemoglobin saturation SaO2 in percentage. Now, why you want to learn about oxygen hemoglobin dissociation curve? Because this is essential for understanding oxygen transport and tissue oxygenation. So there are three things which is right now of concern to me. One is this graph, this sigmoidal shape reflects oxygen loading and unloading, and this curve or graph is also like essential for understanding oxygen transport and tissue oxygenation. Now, this is the oxygen hemoglobin dissociation curve. Very easy to draw in your exam. So try to remember there are two axes, x-axis, y-axis. In x-axis, as I have told, PaO2 is in the x-axis, and this is all in the millimeter mercury. While in the y-axis, it is hemoglobin saturation in the percentage, 0 to 100, and here 0 to 100. And what this is the graph or curve, oxyhemoglobin dissociation curve. And you can see here, this is sigmoidal shape. Now, this red color coming from here and intersecting here. Can anybody tell me what does it signify? Anyone who wants to like post in the chat box? Because this is all like about the oxygen hemoglobin dissociation curve. Anyone? Yeah. Darshan must be knowing because I am unable to share, like, check the chat box. But if you are still not very sure what is this, definitely this needs introspection because critical care is all about oxygen hemoglobin dissociation curve. This is all about PaO2, SaO2, or like carbon dioxide, carboxy methemoglobin, whatever like no forms of hemoglobin, the ABG. So all related to this PaO2, SaO2 is critical care. Now, this is P50. What is P50? You can see here, it is already mentioned here P50, that P50 is the partial pressure of oxygen at which hemoglobin is 50% saturated. Clear? Now we are taking this is from 0 to 100% saturation related to hemoglobin. So this is SaO2. So we are taking the 50% value and we have to correspond it with the PaO2. So it falls or it joins in the sigmoidal curve at the 25 millimeter mercury around. So it would be 25 or 27 millimeter mercury. So PO2 is around 25 millimeter mercury. At this point, your hemoglobin oxygen saturation is 50%, or the you can say the saturation is 50%. Now, there is a the correlation PaO2 and SaO2, and you can see here 25 or 27 is 50% oxygen saturation, and after that you see 30 would be 60, 40 would be 75. So each 10 is right now going up, 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 and almost PaO2 of 100 millimeter mercury is 100% oxygen saturation. SaO2 of 100% or 98%. So this is the relationship between PaO2 and SaO2. But the P50 is the partial pressure of oxygen at which hemoglobin is 50% saturated. Now, the sigmoidal shape. Why it is sigmoidal shape? Why it is not linear? Because it reflects hemoglobin's affinity that will change for the oxygen. Now, the key feature of this curve, because the question is oxygen hemoglobin dissociation curve. So you have to describe the curve in detail. So the curve has two portions. I will be again and again in 2 to 3 slides try to explain to you. It has two portions. One is steep portion. If you see, there is a steep portion and there is a flat portion. This is the flat portion and this is the steep portion. Now, if you will be trying to understand what is the meaning of the steep portion and flat portion, the steep portion is from the PaO to 0 almost to 40 millimeter mercury. And you can see here, there is rapid increase in the hemoglobin saturation as oxygen binds. And the principle behind this affinity of oxygen towards hemoglobin is, what is the terminology used? Can anybody mention in the chat box? Okay, I will be explaining that. Now, this also will indicate efficient oxygen loading in tissues during metabolic demand. Now, this more of oxygen loading in the tissues to help for the perfusion for the metabolic demand of the end organs. Now, low affinity oxygen unloading, and this time there would be low affinity oxygen unloading happening in the tissues, but in the lungs there would be oxygen loading that would be continuing. Now, the mechanism that I was mentioning is positive cooperative. You all have to write at least in this curve. If that would be a question about the curve, you have to draw that. You have to mention the relationship between PaO2 and SaO2. Now you have to also mention that this is a sigmoidal curve or sigmoidal shape. This would be having two persons, one is steep person, one is flat person, and the mechanism behind this curve is positive cooperative. What do you mean by positive cooperative? That there would be binding of oxygen molecule with the hemoglobin. Now, binding of one oxygen molecule enhances affinity for the next. That means first oxygen binding to the hemoglobin, affinity will increase little bit. Now the second oxygen will bind. Now there would be also more affinity to bind with the third oxygen molecule. Now this will happen till it will bind with four molecules of oxygen. One hemoglobin will normally bind with four molecules of oxygen. So this is called as positive cooperative. That means one will be following or cooperating for the binding of the second one. Now, highest affinity occurs at PaO2 of 60 to 100 millimeter mercury. That will be allowing nearly SaO2 oxygen saturation of 100%. Now, what is the clinical relevance? That would be maintaining oxygen delivery to the tissues under varying conditions, and that also will explain the efficient oxygen unloading in the tissues and loading in the lungs. This is quite clear. Oxygen will be first loaded in the lungs, and that would be transferred through the hemoglobin binding to the distant organs, and in the tissues it would be unloaded. So this is all about sigmoidal shape, but I will be again explaining in little bit detail about the flat portion and the steep portion. Now, the flat portion represents high oxygen saturation because already the PaO2 has crossed 50 or 60 millimeter mercury. Now, this occurs at higher PaO2 typically found in the lungs, 60 to 100 millimeter mercury. Now, at this point of time, when it is almost reaching to 90 to 100 millimeter mercury, your hemoglobin saturation is almost touching 90%. That means ensuring maximal lung oxygen loading. So the loading is now good. Now, what is the significance of this, the loading in the lungs? Now, this would be acting as a buffer against oxygen drop. That means there is enough oxygen right now in our body, in the lungs, that has been already bound to the hemoglobin, that if the PaO2 decreases slightly, in case opioid anesthesia, if in case you are actually exposed to a high altitude, or there is mild hypoventilation happening, that means your body is right now not getting that amount of oxygen that was previously getting. So there won't be any problem with the oxygen delivery to the tissues, because already there is enough oxygen that has been loaded in the lungs, because you are already in the flatter portion of the curve. Clear? Now, this would be also you can take it as a reserve capacity. What do you mean by reserve capacity? That means your hemoglobin is right now maintaining a reservoir of oxygen under normal physiology conditions. Clear? So this is the significance about the flat person. Now come to the steep person where your PaO2 is around 50 or less than that. Now that would be representing rapid oxygen release, and that occurs at lower PaO2 level, maybe around 50 or 60 PaO2, typically seen in systemic capillaries where oxygen is unloaded to the tissues, where your the capillary oxygen level is around 20 to 40 millimeter mercury. You can take it as a venous blood. Arterial blood would be, which would be, the saturation would be more than 90%. But if you are going for your mixed venous oxygen saturation, or your the systemic venous oxygen saturation, SCBO2 or SBO2 person, where your PaO2 is already low. Now, what is the significance of that? A small decrease in PaO2 cause a significant drop in the oxygen saturation that would be facilitating oxygen release to the tissues, because now the tissues demand oxygen more. So you cannot keep or bind the oxygen to a great extent. The body, the tissue, then require the oxygen, that would be helpful for their metabolic demand. That way, this would be the steep portion would be helping to release the oxygen with less affinity. Now the significance, as we have already discussed, efficient oxygen delivery to tissues with high metabolic demand, point number one, and that also would be more sensitive to the local changes. That local changes would be, maybe there would be pH will be high in case of metabolic acidosis, maybe in case of hyperthermia, in case of the less of 2-3 dpg. So that would be making your oxygen delivery to the tissues in a better way, like you are during the exercise or hypoxia. That would be also, I will be discussing that part in the next slide. Now in summary, if I will be dissecting, analyzing the oxygen hemoglobin distribution curve, so the flat person ensures that there is a stable oxygen loading in the lungs, providing a safety margin to our whole body. Now the steep person ensures efficient oxygen unloading in the tissues, especially during increased metabolic activity. Now I hope that I have tried to explain you in detail. Now there is a situation I have already discussed. This is the arterial blood where your oxygen hemoglobin saturation is 100 and your PaO2 is almost touching 100. And there is another blood which is mixed venous pressure, or SBO2, where your PaO2 would be around 40 to 50 and your oxygen saturation, what we normally observe, is around 75%. And that's why our target during EGDT trial was also to reach around at least 70%, 65 to 70%, because of this principle only, oxygen hemoglobin dissociation curve. Now, the sigmoidal shape of the oxyhemoglobin dissociation curve helps to explain why oxygen is loaded into the pulmonary capillary blood from alveolar gas and unloaded from the systemic capillaries into the tissues. Clear? Now, at the highest value of the arterial blood oxygen, that is the systemic arterial blood, the affinity of the hemoglobin for oxygen is highest, which is the yellow color here. And at lower value of PaO2, that is mixed venous oxygen blood, affinity for oxygen is lower. That why the oxygen unloading to the tissues would be better. So the end organs will be getting more oxygen. Now, in other words, if I will be again explaining the same thing, what happens in the lungs and in the tissues, already I have explained, but you can write in this way also. What happens in the lungs? PaO2 is 100 millimeter mercury. Saturation is around 100%. Affinity is highest due to positive cooperative. Oxygen is tightly bound to the hemoglobin. The significance is maximal oxygen loading to the arterial blood from the alveolar gas. And that would be having the flat portion of your oxygen hemoglobin distribution curve with PaO2 60 to 100 millimeter mercury. Clear? Now in the tissues, what happens? PaO2 would be around 40 to 50. Saturation I have already explained, around 75%. Affinity would be lower. Oxygen would be readily unloaded to the tissues, to the end organs. The significance would be to facilitate oxygen delivery to meet tissue metabolic demand, and that would be for better consuming the oxygen in the tissues. Now, there would be the third part that you have to write in your exam. What causes your oxygen hemoglobin dissociation curve to shift to right? What causes oxygen hemoglobin dissociation curve to shift to left? Because that is something which we need to understand also to like utilize our clinical acumen in correcting the problem in the ICU. Now, to the right, try to remember these four things. PCO2 if it will be high, pH if it would be low, that means acidosis, then hypercarbia or hypercapnia, increased temperature, that means hyperthermia, and increased 2,3 DPG. These are the four things that we have already read like during our Ganang days in our physiology, like no MBBS days. Now, what causes ODC to shift to the left? If it will be like no alkalosis, or like alkalosis may be respiratory, may be metabolic. Now, hypothermia and decrease in the 2,3 DPG. Also, the another factor which you also remember is the fetal hemoglobin. So this would be causing your oxygen hemoglobin dissociation curve to the left. And you can draw in your exam also. This would be right now making your oxygen hemoglobin dissociation curve to the right, little bit to the right here. Now, here it would be left. That means your P25, P50 here would be, your PaO2 would be less or the same level of your P50. That means the shifts to the right are associated with increase in the P50 here. Before, like in the normal oxygen hemoglobin dissociation curve, it will be remaining around 25 to 27 millimeter mercury. But if you are actually shifting your ODC to the right, you are actually increasing your P50. Maybe it would be around 40 and decrease affinity because it would be releasing the oxygen at the tissue level. Now, shift to the left are associated with decreased P50. Now it would be almost, you can say 12.5 or 15, the P50, and there would be increased affinity for the your oxygen. So this is something you have to also write or draw in your answer sheet. Now, what is the significance of the right shift? I have already explained. That would be facilitating oxygen delivery during physiological like implications would be in the exercise, during your exercise, in your gym, fever, metabolic stress like sepsis, shock. Now, left shift, the challenges would be there will not be oxygen delivery as easy like before. So that would be impairing oxygen delivery to the tissues because your affinity is right now more. And that can be seen in clinical scenarios for us, carbon monoxide poisoning, hypothermia, and alkalosis. So you remember what are the factors that shift ODC to the right, what are the factors that would be shifting your ODC to the left. Now, I will be giving one clinical example of oxygen hemoglobin dissociation curve in presence of carbon monoxide poisoning. Now, what will happen if you will be having a patient with carbon monoxide poisoning? There would be decreased oxygen binding with the hemoglobin. Why? Because carbon monoxide will take its place. That would be binding hemoglobin with 250 times higher affinity than oxygen, forming carboxyhemoglobin. Now, what will happen if your carboxyhemoglobin will be the predominant hemoglobin bound to the the carbon monoxide? That would be reducing the available oxygen binding sites on the hemoglobin because already all the the receptors, the sites are actually filled with carbon monoxide. Now, if carbon monoxide occupies 50% of the binding sites, oxygen content and delivery to tissues decrease by 50%. So that is a real concern for the clinicians. Now, that would be causing left shift of the curve because the remaining heme groups have increased affinity for oxygen. P50 decreases, making oxygen unloading into tissues more difficult. And as a result, what will happen? There would be reduced oxygen delivery due to decreased oxygen carrying capacity, and there would be impaired tissue oxygenation as the tightly bound oxygen is now not very easy to release or harder to release. So this is the significance of the oxygen hemoglobin dissociation curve. And you can see here, in presence of carbon monoxide, your oxygen hemoglobin dissociation curve is looking like this. It is not looking like the previous sigmoidal shape. Rather, it would be only showing your saturation level, you can see your like no the hemoglobin saturation is almost 50% because the rest are occupied with carbon monoxide, and you can see your PaO2 would be more, but your hemoglobin saturation would be only around 50%. Clear? So carbon monoxide reduces the number of sites available for oxygen binding to hemoglobin, and that would be causing your oxygen hemoglobin dissociation curve to the left. Now, I am not going into this is a clinical case, but yes, you can get this type of question scenario in your like no examination, maybe in your theory, maybe in your practical, that a 55-year-old man warmed his like car in a garage and inhaled exhaust fumes. He was confused and breathing rapidly. Now, the arterial blood gas value, what you have like no done in your emergency department, the PaO2 is 660, PaCO2 is 36. pH is 7.43, but the saturation is showing 60%. I think all of you are getting what I am trying to convey here. Here, the carbon monoxide poisoning has caused all these things. You will be getting PaO2 to be very high, 660, but your saturation would be only remaining at the level of 60%. The reason I have already explained, because of the left shift of the oxyhemoglobin dissociation curve, P50 is decreased and there would be left shift of the oxyhemoglobin dissociation curve. Now, the treatment would be administer 100% oxygen to displace carbon monoxide from the hemoglobin rapidly, so that the hemoglobin will be now like the added to the or combined with the your oxygen. Now, in summary, if you will be getting a question on the oxygen hemoglobin dissociation curve, you have to mention all the things what I have already mentioned, but you have to definitely remember to mention about the sigmoidal curve. The shape of the ODC is sigmoidal curve. The right and left shift about P50 value and how it would be helping to integrate this curve knowledge into critical care decision making. Now, I am now sharing with you three clinical scenario questions. I'm not mentioning or I am not expecting answer from you, but a question can come in this way rather than writing or mentioning oxygen hemoglobin dissociation curve for 10 marks. They would be expecting a question in a clinical format. A patient in hypothermia, core temperature of 30 degrees centigrade, is admitted to the ICU. Now, how does hypothermia alter the oxygen hemoglobin dissociation curve, and what strategies would you employ to optimize oxygen delivery? This can be the question format number one. Now, the second one, you are managing a critically ill patient with metabolic alkalosis, pH of 7.6. How does alkalosis affect the oxygen hemoglobin dissociation curve? And what are the risks of impaired tissue oxygenation? The same thing. Now, the third one is quite interesting. During a code blue, a patient has a PaO2 of 150 millimeter, but SpO2 is very low. The peripheral oxygen saturation is hardly 35 to 40%. Now, what could explain this discrepancy, and how would be the oxygen hemoglobin dissociation curve help you interpret this situation? Now, if you understand the concept of oxygen hemoglobin dissociation curve, you can easily get, I bet, 9 out of 10 if this will be a question in your upcoming exam. Now, I am not mentioning these are the answers in short one-liners that I have already explained. This would be hypothermia question number one, reducing oxygen unloading to the tissues. The strategies would be to rewarming, ensure adequate tissue perfusion, monitor oxygen delivery closely. The second one would be again the same effect on the curve, shifting the curve to the left, impairing oxygen release at the tissue level. And what will be the risk? Despite your normal oxygen saturation, you will be continuously getting tissue hypoxia. So you have to correct the underlying cause of the alkalosis to restore the balance. Now the third one, it is due to carbon monoxide poisoning or methemoglobinemia or alkalosis that would be causing the left shift of the oxygen hemoglobin dissociation curve, and you are getting PaO2 to be high, but SpO2 is low. So you have to find out the hemoglobin abnormalities and also consider therapies like hyperbaric oxygen for optimal oxygen delivery. Now, something I have tried to explain the ODC in very detailed fashion. If at this point of time any question is there, you can like post in the chat box, or I will be going to the second question. Okay. Now, the second question is very practical, and we do regular basis. We analyze lactate like no analysis the values in our critical care perspectives. So the question from the basic science, they will not be expecting that you would be writing only clinical, rather the physiology. So lactate physiology in critical care perspective, the overview will be related to the pathophysiology, clinical utility, and management. Now, before going to the detail about the lactate, the in detail, lactate is actually a byproduct of glycolysis, and primarily it is produced under the anaerobic conditions. In aerobic conditions, the byproduct would be pyruvate. Now, this is cleared by the liver, almost 60%, and kidney, 30%, via gluconeogenesis or oxidation. Normal blood lactate is around 0.5 to 1 millimole per liter. But if it would be more than 2 millimole per liter, we normally label as hyperlactatemia. Now, there would be something you need to remember about the kinetics of lactate. The daily production normally is around 20 millimole per kg per day, and it enters the circulation, undergoes hepatic and renal metabolism. And the cycle, you remember, Cori cycle. In the examination, in the practical, some of the examiners would be very keen on guessing how depth is your knowledge related to the physiology part. So Cori cycle. Now the conditions, all tissues can produce lactate on under anaerobic conditions. Now there is a relationship between lactate and pyruvate. What is that relation? The reaction that if you are smart in chemistry, so you can write also in your examination, pyruvate plus NADH, reversibly lactate plus NAD plus H plus, and it is catalyzed by LDH, lactate dehydrogenase. So pyruvate and lactate are in equilibrium state normally, and lactic acid with the pK of around 4 is fully dissociated into lactate and H plus at body pH, classifying it as a strong ion. So lactic acidosis is a strong ion that you should remember. Now, what are the tissues that can produce excess lactate at rest? Can you guess? Skin is the organ of our body that produces lactate to the maximum. But normally we feel maybe some or other muscles or gut or the other RBCs or heart that would be producing more lactate. No, it is the skin, 25% of the lactate production. Red cell 20%, brain 20%, muscle 25%, gut 10%. Now during heavy exercise, it would be shifting to the skeletal muscles. They would be the predominant source of increased lactate. During pregnancy, placenta contributes significantly and may transfer lactate to the fetus. So you have to avoid transfer of that lactate from the mother to the fetus, because that would be interfering with the fetal perfusion or fetal physiology. Now, in critical illness, like in the ARDS or sepsis, lungs become a major source of lactate production in sepsis and ARDS. Now, lactate metabolism and elimination already explained. Liver 60%, kidney 30%, and heart maybe around 10%. Metabolic pathway, I have already explained. Gluconeogenesis is 50% converted to the glucose, 50% oxidized to the carbon dioxide and water via the citric acid. And this would be, these pathways do not result in net acid accumulation but require aerobic conditions. Now, renal handling, almost 180 millimole per day of lactate is filtered by the kidneys, and nearly all filtered lactate is reabsorbed. So you don't feel that lactate is not produced in our normal physiology conditions, but our liver and kidney are so efficient, they actually metabolize the lactate to a great extent. That's why we do not get hyperlactatemia in our clinical state. Now, this is the Cori cycle. If somebody is interested to know, this happens in the liver, and this is the gluconeogenesis. This is the glucose, and you can see here the pyruvate, 6 ATPs, gluconeogenesis enzymes, lactate dehydrogenase is the catalyst here, the enzyme which is responsible for the change in the pyruvate and lactate cycle. And you can see this glycolysis dependent tissues, skeletal muscle, blood cells, bone marrow, renal, medulla, peripheral nerves, and hypoxic tissues. There would be glycolysis dependent tissues. They need glucose. And if they don't get it, so they will be trying to go into the more of lactate production and less of the ATP production. Clear? And the lactate per hour, you can see 0.8 millimole per kilogram per hour. So this is something which you can draw. Liver is one side and other organs of our body, glycolysis dependent tissues like this, they would be in the other side. And you can see what happens through the gluconeogenesis and how LDH is helping to change from the pyruvate to lactate. Now, hyperlactatemia in critical illness. How does it actually having clinical perspectives in ICU? Hypoxia-induced anaerobic glycolysis is common in shock states. All types of shock. It is not only septic shock, cardiogenic shock, maybe neurogenic shock, anaphylactic shock. Now, impaired clearance will be normally associated with hepatic and renal dysfunction because these are the two organs that metabolize lactate to a great extent in the normal physiology conditions. Now, increased aerobic glycolysis will be also leading to hyperlactatemia because of the stress-induced catecholamine surge. It is not only anaerobic, also sometimes the aerobic glycolysis will be also resulting in increase in the lactate level. Now, there would be some medications that would be also resulting in hyperlactatemia in our clinical perspectives, like beta agonists, metformin, propofol. Now, the pathophysiology, already we know why we'll be getting hyperlactatemia or lactic acidosis because of mainly three mechanisms. Excessive tissue lactate production that would be common in anaerobic conditions due to either inadequate oxygen delivery or utilization. There would be two positions or two states that would be resulting in excessive tissue lactate production. Now, the second one would be impaired hepatic metabolism in case of acute liver failure or chronic liver disease, where actually there is decreased clearance capacity, and that would be resulting in or leading to the lactate accumulation. Now, often a combination of many mechanisms would be contributing to the persistent lactic acidosis in critically ill patients. Now, again, what are the types of the lactate, hyperlactatemia or lactic acidosis? So you can see here the causes of lactic acidosis, Cohen and Woods classification that you need to remember. What is Cohen and Woods classification? That would be including two types, type A and type B lactic acidosis. Type A is mainly primarily due to inadequate oxygen delivery, and that occurs due to hypoxia or tissue perfusion deficit, and that would be due to anaerobic muscular activity, sprinting, or generalized tonic-clonic convulsions, tissue hypoperfusion like shock, that could be due to septic, cardiogenic, hypovolemic, post-cardiac arrest, during cardiac arrest, regional hypoperfusion like mesenteric ischemia, and the third one would be reduced oxygen delivery or utilization due to hypoxemia, anemia, carbon monoxide poisoning. So this is type A lactic acidosis, which is inadequate oxygen delivery. Now, there is another form of lactic acidosis, which is type B, where there is no evidence of inadequate tissue oxygen delivery, and that would be mainly due to resulting from the metabolic or toxic factors. And that would be again divided the type B into B1, B2, B3. And just remember, associated with underlying diseases would be B1, like leukemia, lymphoma, Luke. Tips. Remember, easy to remember: thiamine deficiency, infections, pancreatitis, short bowel syndrome. And third one would be all types of failures: hepatic failure, renal failure, diabetic failure. Diabetic failure, it would be diabetic ketoacidosis or HONC. So these are the three types of the underlying diseases that would be resulting in type B lactic acidosis. Now, B2 would be associated with drugs and toxins. Remember the drugs that normally causes increase in the lactate level. In the exam, you should be writing beta agonist, metformin, salbutamol, isoniazid. Isoniazid is one of the anti-COX treatment that will be causing your lactate to be high. Toxins, in toxins, cyanide should be the first answer, methanol, ethanol in chronic use, and other substances like fructose, sorbitol, xylitol, and lactate-based dialysate in the RRT, in the dialysis. So these would be the drugs and toxins that would be causing type B lactic acidosis. Now B3 would be the inborn errors of metabolism, like the enzyme defects, pyruvate carboxylase deficiency, glucose 6 phosphatase deficiency, or other oxidative phosphorylation defects. So this would be in short the Cohen and Woods classification for the lactic acidosis. Now the more significant for our critical care, like no, the practice would be lactic acidosis in sepsis. In examination, they would expect that explain the mechanisms by which there would be lactic acidosis in sepsis. So it would be a combination of mechanisms. One would be endogenous catecholamine release that would be contributing to increased aerobic glycolysis and lactate production. That would be point number one. Circulatory failure because of the hypoxia and hypotension that would be now diverting the metabolism to the anaerobic pathway rather than the aerobic pathway. Cytopathic hypoxia because of microvasculature problem, the microvascular shunting, mitochondrial failure that would be impairing the oxygen utilization at the end tissue level. Clear? Now, there would be also endotoxin effects because of the cytokines and endotoxins, like the surge that is happening in the septic saw, that would be inhibiting the PDH, pyruvate dehydrogenase. That would be again one of the the pivotal the enzyme that is responsible for your the conversion from pyruvate glucose to pyruvate. Now, also in the sepsis or septic shock, there would be definitely coexistent liver dysfunction. So there would be also to substantial amount of reduced lactate clearance that would be again aggravating the lactic acidosis in these situations. So these would be the 5 causes of lactic acidosis in sepsis. Now, there would be something you need to remember how you are actually monitoring or measuring the lactate level. So through one plasma lactate level primary test, and if you are getting your elevated lactate is documented from the lab, so it would be crucial to now to identify and address the underlying cause. Now, for all of you, you should remember there is another form isomer of D-lactate. What is D-lactate? This would be an isomer of lactate produced by intestinal bacteria, not by human cells. And the clinical relevance, you need to remember that this is not detected by the standard lactate assays that we do in our the bedside test. And this would be one of the potential bedside tests that are for diagnosing conditions like mesenteric ischemia. The mesenteric ischemia, it would be the intestinal bacteria that are actually right now releasing this form of lactate, that is D-lactate. So this would be more significant if you are getting D-lactate form. It would be signifying more towards the intestinal problem or mesenteric ischemia. Now, how would you be collecting the lactate sample? Venous versus arterial sample. Is there any difference between venous or arterial sample lactate level? No. Venous samples are clinically equivalent to the arterial samples in most of the cases. So you don't need to always order for the arterial blood like lactate level. So if you are getting the venous lactate also, you will be also pretty sure that yes, it is elevated means elevated. And you have to measure the trend of lactate levels through the venous or arterial. That is more important. Now, handling and tourniquet use. Do you really need to remove the tourniquet during sample collection for getting a good lactate level in your body or in your blood? No. But if you are actually trying to get the sample but you are not able to find a good vein and you are using the tourniquet for a long time, maybe you have to release the tourniquet for 20 seconds before collecting the sample. Now, the stability of the sample, the samples normally remain stable for 15 minutes at room temperature. And in on ice, if you are actually sending your blood sample for lactate determination or assay, and you are expecting delay in your analysis, so definitely on ice, you can send your the blood sample. Monitoring and follow-up is very important, and you have to repeat the lactate measurement rather than only depending upon a single value of lactate. Now, what is the clinical utility in critical care? It is a marker of hypoperfusion, indicates inadequate tissue oxygen delivery. Risk stratification, persistent high level of lactate in your ICU patient, that would be correlating with poor outcome. And also it would be a prognostic significance associated with mortality in sepsis, trauma, and cardiac arrest. So these are the three clinical scenarios where lactate is one of the the most important monitoring modality that would be giving you a clue that you are actually doing your resuscitation to a great extent successfully or not, and that would be also prognosticate your patients the clinical future or whatever outcome. Now the management strategy, resuscitation goal, it should be targeting lactate clearance more than 10% within 6 hours would be the first management strategy. Treat the underlying cause, whether it is sepsis, hypovolemia, cardiogenic shock, and adjunctive interventions like optimizing the oxygen delivery, put the patient on ventilator, give anti-epileptics if the patient is having the seizures, support the liver if it is liver failure, correct the metabolic acidosis, go for dialysis. Now the management of lactic acidosis, again the core steps I have already explained. You have to put the patient on ventilator, utilize fluids, inotrophs, vasopressors, identify and treat the cause of lactic acidosis. Now the evidence for lactate level and lactate clearance, there have been multiple the trials that have been analyzed or conducted to prognosticate the value of lactate level. So if your lactate levels are high, so that would be directly proportional to the mortality risk, except salbutamol toxicity or seizures. Now, if you are getting lactate to be high, but your patient is having normal blood pressure and mental status, what will be the outcome? So lactate is an effective tool for identifying occult sepsis also. That means if your patient is perfectly fine, normal blood pressure, good GCS, but your lactate continues to be remaining high, just as in the reverse trial. 1 in 5 patients had MAP of more than 100 millimeter mercury, but with high lactate level. Now, lactate clearance, as I have already told, there have been a lot of studies that have been actually correlated with poor lactate clearance is linked to worse outcomes, especially in trauma. Then lactate clearance is non-inferior to your mixed venous oxygen saturation or your central venous oxygen therapy for guiding therapy, and EGDT, beneficial in patients with hyperlactatemia. But only targeting to treat lactate concentration in your body is not at all recommended as per all the major trials. And there is another terminology that you need to remember is lactate gap. What do you mean by lactate gap? This is the difference between lactate that is measured by oxidase method, which is the normal standard method, and the dehydrogenase method. So lactate gap is actually the difference between oxidase lactate minus lab lactate dehydrogenase. So we are doing the FBG sample that is actually utilizing the oxidase method to monitor or measure the lactate. And in the lab, when we are sending the arterial sample, that is right now determining the lactate level by lactate dehydrogenase method. So the difference you have to actually monitor. And in the situations like ethylene glycol toxicity, glycolate is actually accumulating, and that would be leading to the false interpretation. That means you will not get the correct lactate level by doing the ABG. So you have to send it to the lab for determining the lactate level by the lactate dehydrogenase method, where you will be also getting to know about the presence of glycolate that accumulates in the ethylene glycol toxicity. Then there are certain treatment methods like use of sodium bicarbonate, but as per all the randomized control studies in lactic acidosis and shock, they didn't have any significant benefit on the cardiac function or overall pH correction. But you can always target sodium bicarbonate to decrease the lactate level. And the alternatives to sodium bicarbonate are carbicarb, dichloroacetate, or tris or tham. So these are the buffers. Carbicarb is the buffer without generating carbon dioxide. The side effect or disadvantage of using more of sodium bicarbonate is it would be generating carbon dioxide more. That we don't want. So carbicarb is actually one buffer without generating carbon dioxide. Dichloroacetate will be enhancing the pyruvate dehydrogenate activity, which is one of the problem area for going into the anaerobic pathway, and that would be actually going into release of more lactate level. Now tris or tham is non-carbonic acid buffer. Now, indication of bicarbonate therapy, where you are actually trying to reduce the lactic acidosis for better cardiac contractility. So, severe ischemic heart disease, severe pulmonary hypertension. Now, at the end, if you are still not able to treat the high lactate level, you can subject your patient to dialysis or hemofiltration. Though hemofiltration can be a useful intervention, but the lactate production has to be stopped. The dialysis cannot stop the production of the lactate level. It will be removing the excess lactates, but in case of severe sepsis, septic shock, you are unable to actually control the ongoing sepsis or inflammation that is happening in the body. Now, the emerging insights at the end, the future directions, lactate as a therapeutic targets, use trends rather than a single value to guide your intervention. It would also put some light on mitochondrial dysfunction, like it would be contributing to sepsis related hyperlactatemia, and also sometimes lactate to pyruvate ratio will be helpful to differentiating between aerobic versus anaerobic production, whether your lactate is produced from the anaerobic pathway more or it is due to aerobic glycolysis pathway more. So you have to go for lactate to pyruvate ratio. Now there are certain challenges and limitations of our lactate physiology. It would be highly non-specific. Elevated level can be due to multiple causes. You need to go for a trained dynamic monitoring, and lactate fluctuations influenced by the sampling, timing, and the patient factors. And this is a one pager. I think everybody knows about. You can always go for all the the main headings to write in in 2 pages in your answer. What is type A, what is type B, then what is type D. This bacterial overgrowth that I have explained to you in short bowel syndrome or mesenteric ischemia, you due to type D of lactic acidosis. And the lactate clearance I have already explained. This is the Cori cycle. Then this is something related to the definition as well as what is lactate, what is lactic acidosis. So all these things you have to remember, so that in case you are getting a very usual and very easy question in your exam, you should not be getting less than 10 out of 10. That is my expectation at the end of this. Maybe I have taken 20 minutes to discuss about a topic which everybody every day is using, but they need to clearly understand the concept rather than just using it superficially. So, lactate is a cornerstone of critical care, reflecting tissue perfusion and metabolic stress, and its interpretation should be context specific, guided by underlying pathophysiology and clinical trends. I'm not going into again detail, but I have kept questions at the end of each the scenario, that this is a clinical scenario. In case the lactate physiology will not be a direct question, the examiner may ask in a different format, like a 65-year-old patient with septic shock has a serum lactate of 5 millimole per liter. Despite fluid resuscitation, lactate remains elevated. Now the question would be, what are the key mechanisms leading to elevated lactate in septic shock, which I have explained nicely. 5 mechanisms I have shown you in my slide. And how does this guide your management strategy? That also I have explained. Now, a conceptual question would be, in a critically ill patient, a lactate level of 3 millimole per liter is detected. Now, the patient is hemodynamically stable but has a low PaO2. Now explain how lactate production can occur in both aerobic and anaerobic conditions, and why elevated lactate might not always indicate hypoxia. I hope all of you understand this question, which is little bit twisted, to know the in-depth understanding of yourself to this lactate physiology. So I'm just sharing with you this. I have already explained to you the elevated lactate level in septic shock. The second one I'm trying to show you, that the lactate production in different states like anaerobic condition and aerobic conditions. Aerobic condition I have already shown you: hypermetabolic states, exercise, fever, beta adrenergic stimulation, mitochondrial dysfunction. But the key insight for the second part of the question would be that elevated lactate doesn't always imply hypoxia. Rather, it can reflect systemic stress or metabolic adaptation. And elevated lactate in the context of clinical findings like perfusion status or oxygen delivery or acid balance is more important. Now, this is all about lactate. Now, the last part of my assignment is tracheal anatomy and tracheostomy. This is again a very favorite question, because we go for airway management on and off every day. We do bronchoscopy, we do tracheostomy. So this is imperative that any clinician who is working in ICU should be knowing in detail about trachea as well as tracheostomy. Now, trachea, commonly known as windpipe, which is a crucial component of the respiratory system, and this is one main conduit for air passage between larynx and lungs. To L, you are getting T. Now, understanding its anatomy is essential for effective airway management in critical care settings. Now, it is if the question would be coming as tracheal anatomy, so definitely you have to write minimum 1 page about the anatomy. So it is a fibrocartilaginous tube about 10 to 11 centimeter long, and it begins just under the L and runs down behind the sternum to meet again L, that is lungs. So larynx and lungs in between trachea. Now the trachea divides into two small tubes called as bronchus, and one bronchus for each lung, right bronchus, left bronchus. Now the main function of the trachea is to transport air in and out of the lungs during the act of breathing. It protects the respiratory tract by warming and moistening the air and propels foreign particles upward towards the pharynx for expulsion by coughing out. Clear? Now, mucus in the trachea also helps capturing the microorganisms such as viruses and harmful bacteria before they enter the lungs. This is the first few lines about the trachea. Now, this is a picture. You need to draw at least 2 to 3 pictures related to trachea if you are getting the anatomy question. And the physiology question would be the airway passage, or tracheostomy would be the procedure. So, I am not going into detail. This is the hyoid bone. Then this would be thyroid membrane. This is the superior thyroid notch, anterior thyroid lamina. There is cricoid cartilage, cricothyroid membrane. The cricothyrotomy again is a question, potential question. This is the thyroid cartilage as a whole. The thyroid cartilage, cricothyroid membrane, thyroid membrane, and hyoid bone. It easy to draw. And then you have to draw the trachea here, and then it divides into right main bronchus and left bronchus at the carina level. Clear? So this diagram has to be there on your first page. And then what are the relationship of trachea and bronchi to the other organs, other structures surrounding the trachea? So tracheal anatomy, because that is again important for your tracheostomy, intubation, bronchoscopy. Now cricoid is at the level of C6, and the trachea again divided into cervical trachea, thoracic trachea. Cervical trachea is 5 centimeter, thoracic trachea is 5 centimeter. Just remember 10 centimeter divided into cervical trachea 5 centimeter, thoracic trachea 5 centimeter. Now this is the thyroid isthmus, suprasternal notch, manubrium, and the bifurcation occurs at the level of T4-5. Again, you have to remember these labels in the examination. They would be very keen on asking you T4 or 5. Now, the right bronchus, there are certain specification about right bronchus: wider, shorter, steeper, around 2 centimeter. Now, the left bronchus would be narrower, longer, more horizontal, and 5 centimeter. Now, this trachea is around 10 centimeter, but the peculiarity of the trachea is it can elongate to 15 centimeter during inspiration. So if you take a deep inspiration, your trachea can elongate to 15 centimeter around. And the histologic layers, mucosa is ciliated, pseudostratified, columnar, hyaline, and cartilage rings are there. I will be explaining that. Now, the specification about the trachea ending in the bronchus is inhaled foreign body are more likely to enter the right bronchus and then pass into the apical bronchus of the right lower lobe, the first one that points posteriorly. So that's why the pulmonary cox you will get the apical portion will be the first, right side apical. The bronchus would be the first part to be you will get the hedginess there. Now relationship of the trachea here: anteriorly sternum, sternothyroid muscle, arc of aorta, brachiocephalic trunk, left common carotid artery. Just remember trachea is here, and you are getting all the vascular structures: arc of aorta, brachiocephalic trunk, common carotid artery, and right main bronchus, left main bronchus. Clear? Now, Posteriorly, esophagus, vertebral column, easy to remember. Right side, right lung, right pleura, right vagus nerve, and azygous vein. Left side, arc of aorta, left common carotid, left subclavian. So there would be vessels on the left side, there would be vessels as well as the right lung and pleura on the right side. And posteriorly, there would be esophagus and vertebral column. And that's why the relationship you need to remember, because you have to be cautious during intubation. If you will be doing wrong intubation, it will go for the esophageal intubation. During the central line, if you are actually going into a wrong direction, you will be hitting the right lung and pleura, resulting in the pneumothorax. And tracheostomy, everybody knows the complications or the challenges that we normally encounter if you are actually getting the anatomy not very clear or to our the clinical examination. Now the structure of trachea, you have to also remember that there is a D-shaped fibrocartilaginous respiratory organ. So it would be D. The backside would be a straight line, consist of 16 to 20 tracheal cartilages anterolaterally, and a fibromuscular wall posteriorly. And that muscle name is, can anybody mention in the chat box? What will be the muscle that is fibromuscular in nature and that remains at the posterior side of the trachea? Yeah, I think people are getting, I'm not checking. That is trachealis muscle. Okay. Now, tracheal cartilages are composed of hyaline cartilage and interconnected by fibroelastic tissue. So it would be all cartilages would be hyaline and that would be interconnected by fibroelastic. And what is the significance of that? They support the trachea and keep it open during pressure changes that accompany air ventilation. Otherwise, it would be also collapsing during your expiration, that we don't want in the normal anatomy or physiology. Now, the posterior wall of the trachea, as I have already mentioned, is formed by trachealis muscle, making cartilages appear as incomplete C-shaped, C, or whatever we are mentioning as D, because D would be the stem, would be the fibrocartilaginous, the trachealis muscle. And the structure of its wall makes the trachea sufficiently flexible and elastic to permit transient expansion of the esophagus also during swallowing. That is the beauty of trachea, the anatomy. Backside, if it would be again a very tough structure, then esophagus won't get that the peristalsis movement during the swallowing. So that's why the backside would be trachealis muscle, and that would be very flexible. So you can actually swallow water or food without any impingement on the tracheal wall. And this is the structure diagram. Again, you have to remember in this class, it would be difficult to mention, but again, you have to remember the most important, all the cartilages and the trachea. And the trachea, how does it look like? The lumen of the trachea is this. Backside is the esophagus. This is the trachealis muscle, which I was mentioning. And this is very soft and expansile. And the mucosa, the hyaline cartilage, the structure is made of hyaline cartilage. And there would be glands also that would be secreting mucus, submucosa, mucosa. Histologic layers I have already mentioned: mucosa, mucous membrane, and that would be pseudostratified ciliated columnar epithelium, goblet cells that would be producing mucus, which warms, moistens, and removes the foreign particles from the air as it flows through the trachea. That would be a defense, first defense mechanism. Now, the submucosal layer is the second histologic layer of the trachea. That would be consisting of loose areolar connective tissue that contains also mucous glands, smooth muscle, vessel, and nerves. The submucosa contains the vessels and nerves. Musculocartilaginous layer, which is the third layer of the trachea. Again, that would be the C-shaped cartilaginous ring, and there is just intervening smooth muscle. And this would be narrowing the tracheal lumen and increases the velocity of the airflow. If there would be any dislodgement of the mucus and foreign particles would be entering, it would be actually trying to remove it, and that would be like taking it out with the velocity of the airflow. And the last one would be adventitial layer. This is a band of connective tissue, and that loosely bind the trachea to the esophagus and other nearby organs. So mucosa is the inside, then submucosa, then the muscle or muscle cartilaginous, and finally adventitia. This is the nerve supply and arterial supply. You have to remember, look, this looks little bit that I am going into the anatomy or physiology class, but in your examination, you will remember me if you will get the tracheal anatomy and tracheostomy for sure. The first thing you will remember is me. Okay. Nerve supply of the trachea, sensory nerve supply from vagus and recurrent laryngeal nerve. Just remember, you don't need to again go into detail, till what extent there would be vagus, then what extent would be recurrent laryngeal nerve. No. Blood supply, again, there is a peculiarity of blood supply of the trachea. Upper 2/3 is inferior thyroid and lower 1/3 is by bronchial artery. Clear? And about the lymph drainage of the trachea, pretracheal and paratracheal and deep cervical nodes. Clear? So these are the three things that you need to remember if you are getting a tracheal anatomy question. The functions, I hope everybody can write about 4 to 5 lines, but you have to remember to mention about the goblet cells, the mucus, then the physical and immunologic methods, then the transport of the oxygenated air from the upper respiratory tract towards the alveoli, then again the temperature regulation by making the air dry, air moistened. So all these things you need to remember. And also finally the cough reflex, that would be also one of the protective mechanism. And on cold days, again the trachea helps warming also and providing humidity of the to the air before it reaches the lungs. Now the clinical significance of the tracheal anatomy. First is airway anatomy. You need to be very clear about tracheal anatomy for procedures such as endotracheal intubation, tracheostomy, bronchoscopy, proper tube placement, avoiding injury to the adjacent structures. Pathology conditions like tracheal stenosis, tracheomalacia, tracheoesophageal fistula, that would be definitely requiring proper anatomy understanding for effective diagnosis and management. And finally, emergency situations, life-saving situations in case of acute airway obstruction. If you know the tracheal anatomy properly, so you can go for cricothyrotomy, which is putting the needle through the cricothyroid membrane located just below the thyroid cartilage I have shown. So that also is very important. If you know the tracheal anatomy properly, you can do the cricothyrotomy procedure effectively. Now, the last part of my assignment is the procedure itself, tracheostomy. That can be a question from the intervention or procedure domain. Now, tracheostomy, as the name suggests, tracheostomy is a surgical procedure that creates an opening in the anterior wall of the trachea to facilitate airway access and ventilation. Clear? Tracheostomy, anterior wall opening, facilitating airway access and ventilation. Now, there is always interchangeable terminology like tracheotomy. What is tracheotomy and what is the difference between tracheotomy and tracheostomy? Tracheotomy is a procedure, just simple remember, directly connect the trachea with the skin of the neck. Always tomy or stomy is to connect with the outside skin. So if the trachea is directly connected with the skin of the neck, it is tracheotomy. Like laryngectomy, following laryngectomy, what is happening? The larynx is actually completely taken out. Now the transected trachea is directly anastomosed with the skin of the neck. So that is tracheotomy. Now, in that tracheotomy track, a tracheostomy tube also can be placed. So it is not, tracheostomy is the procedure. Tracheotomy when you are actually directly connecting the trachea to the skin. Now, what are the indications of tracheostomy? The first thing that you have to write in your question, if it would be coming, 3 indications normally. One is to bypass the obstruction of the upper airway. So you are actually not going through this route. You are actually directly entering through the trachea. Second one, to provide an avenue for removal of secretions retained in the airways or your the neuromuscular weaknesses or when you are thinking that the airway protection is not good. So that would be also one of the indication. And the third and the most important from the critical care perspective is to provide means for prolonged ventilatory support, where you are actually expecting that by doing tracheostomy, you will be going to do better for the patient's recovery. Now, the indication can again be divided into multiple ways. I am trying to summarize in 3 methods. One is emergency indication, one is elective indication. This is the first method by which I am trying to explain. Now, emergency indication where you are getting acute upper airway obstruction due to multiple causes like angioedema, anaphylaxis, when endotracheal intubation is actually failed and you don't have any other thing to do. infections like submandibular space infections, Ludwig angina, retropharyngeal abscess, or any obstructive mass like tumors or foreign body is actually lost in the upper airway and you are unable to enter through the upper airway. So you have to go for emergency tracheostomy. Now the second one would be post-emergency cricothyrotomy. You have already done cricothyrotomy. Now you have to change it to tracheostomy. Definitely, you cannot continue with cricothyrotomy for a long time. Now, severe facial or neck trauma, where you are unable to put any endotracheal tube, like lay for 3 fractures or more. Now, fourth one would be penetrating laryngeal trauma, where there is a trauma directly to the larynx. So you cannot go into the larynx part. You will be going into the trachea part, straightforward. Now, the elective indications, what we normally do. So prolonged mechanical ventilation, impaired airway protection, refractory OSA is again one of the indication for going for elective tracheostomy. Severe subglottic stenosis, severe vocal cord paralysis, where all other treatments have failed. This is the first method of classifying the indication. Now the second method is where the traditional method, upper airway obstruction, impaired clearance of secretions, and third one is prolonged ventilatory support. Now, just remember the structure, the format. You can write n number of things. I am not going into detail. Upper airway obstruction, just remember what can be the upper airway obstruction pictures. Then impaired clearance of secretions. Again, I have already mentioned when you are unable to clear the secretion, neuromuscular diseases, and prolonged ventilatory support, which is our day in and day out tracheostomy indication, extended mechanical ventilation when you are expecting long-term ventilatory support. Now coming to the contraindications, the contraindication again absolute and relative. Now the absolute contraindication, when there is no cervical trachea itself, how will you go for tracheostomy? When there is no diathesis, when you are getting very high INR with platelet count low and you are expecting that would be torrential bleeding during the procedure. Now relative contraindication will be the hemodynamic instable. Patient is requiring very high FiO2 and PEEP more than 12 or so. Severe hypoxemia. So you cannot do the procedure within maybe 1 minute, 2 minutes. And there would be many relative contraindications for percutaneous tracheostomy. That also you need to remember, because the next part would be the types of tracheostomy. In that, we'll be discussing about the open tracheostomy and percutaneous tracheostomy. Now, relative contraindication for percutaneous tracheostomy is morbid obesity, short neck with inability to identify and palpate the trachea. This is relative. I'm not saying absolute. Vascular structures such as high riding innominate or thyroid internal mammary artery, and you are doing ultrasound and you are getting a big vessel just in front of the trachea. Gross distortion of the neck from hematoma, tumor, thyroid, big thyroid, scare is there. You are not getting the anatomy properly. Severe tracheomalacia, and all the cartilages have been destroyed. So you will not be able to get the proper the insertion site. Inability to safely extend the neck, like cervical fusion, rheumatoid arthritis, or other causes of cervical spine instability. Prior complex tracheal surgery have been done, and the surgeon is not very keen to go for tracheostomy in this patient, where you will be going for percutaneous without knowing the proper anatomy of the the tracheal surgical patient, like tracheoplasty, tracheal resection, reconstruction. Previous tracheostomy is not a contraindication though. Children less than 15 years. Can anybody tell me what is the reason why children are not supposed to go for percutaneous tracheostomy? Because it is so flexible. The trachea has not been grown to the proper extent. So you will be trying to actually hinder the growth of the tracheal cartilages. So that's why if it is indicated, again, that has to be done in proper open surgical method. And patients requiring emergency airway. Emergency airways, doing a percutaneous tracheostomy, sometimes you will be losing the airway completely. Clear? Now, what are the advantages of tracheostomy? What are the disadvantages of tracheostomy? That can be again another part or the stem of the answer. So avoid would be avoid direct injury to the larynx, because you are bypassing the larynx. Facilitates nursing care. You know everything, but you have to make it in a very structured way in your answer sheet. Enhances patient mobility, more secure airway, improved patient comfort, permits speech. In intubation, you cannot talk. The patient cannot talk. provides psychological benefit, more rapid weaning from the mechanical ventilation, better oral hygiene, decreased risk of nosocomial pneumonia, more significantly BAP, ventilator associated pneumonia or hospital acquired pneumonia. Disadvantages, definitely complication would be one of the risk factor. Bacterial airway colonization, cost would be a factor. Surgical scare maybe sometime will be there, and tracheal and stomal stenosis and other complications of the tracheal stomy. Now, what is the timing of tracheostomy? There is actually a bit of controversy about the timing of tracheostomy. So the examiner may wish to check or assess whether you are clear about the timing of tracheostomy. General recommendation: early tracheostomy within 7 days of intubation, late tracheostomy after 7 days. Now there have been multiple studies that have been conducted. One meta-analysis in 2005, then 2011 meta-analysis, then the UK study, that is the TrackMan trial published in the JAMA. So all these studies, they have tried to find out what should be the ideal timing for the tracheostomy. And all these studies, the clear verdict is not there. So the first meta-analysis that suggested that if you're going for earliest tracheostomy, the complication will be less. Now, contradictory evidence was in the 2011 meta-analysis, where they have included 7 RCTs. Almost 1,000 plus patients were there, but they didn't find any significant difference in mortality rate or mechanical ventilator days or ICU length of stay. Now, the third one, which is one of the favorite question from the examiners, if you are getting a tracheostomy case in your practical, the examiner would be expecting to just utter the word TrackMan trial. Okay, I will be showing you the screenshot of the TrackMan trial also. This is UK study, 909 patients. They compared early tracheostomy, but the early tracheostomy here is 4 days, not 7 days. Try to remember this. First 4 days, if you are doing tracheostomy, it is early. Late tracheostomy would be after 10 days, or if indicated. And they didn't find any difference in the 30-day, 1 year, 2 year mortality, similar ICU stay, and antibiotic use between the groups. But significant thing is median sedation days were lower in the early group. P less than 0.001, 5 days versus 8 days. That is quite significant. And tracheostomy was avoided in 53.7% of the late group. That is again one of the criticism for this study, that if you are going for so early tracheostomy, almost if you are waiting for the late tracheostomy, you are avoiding in almost more than 50% of the group. So that is definitely something which would be antagonizing the idea of going for early tracheostomy. So the conclusion from the recent evidence that benefits of early tracheostomy are not strong enough to recommend performing the procedure before 7 to 10 days of intubation. Now, delaying tracheostomy often avoids unnecessary this type of procedure and their associated complication. And this is the TrackMan trial. So I have just shown you this picture published in JAMA in 2013, and this is related almost 1,000 plus patients were recruited. Now these are some of the current evidence of all the trials, RCTs and meta-analysis about the tracheostomy timing. This is the mixed ICU RCT, all the RCTs. Again, just remember the 2-3 names that would be something which would be helpful to you. Now, what are the types of procedure of tracheostomy? Surgical tracheostomy, the first and foremost, where you will be shifting the patient to OR under sterile condition. You will be doing. Now, percutaneous tracheostomy, bedside in ICU using minimal invasive techniques. The major difference: surgical will be preferred for complex anatomy or emergency airway. Percutaneous, it would be faster, less invasive, and fewer complications in stable patients. Now, what are the techniques of percutaneous tracheostomy? That again be one of the part of your question. So it can be Saglia method. Key feature is sequential dilatation. Standard ICU patients, we do blue rhino, single step, curved dilator, faster, less tissue trauma. Griggs method, forceps based blunt dilatation, quick but requires more skill. PRDT is rotational dilatational motion. Now this is complex and or delicate trachea. You have to do it rotating and dilating rather than single step curve dilator. Balloon dilatation, where you are using balloon catheter for dilatation. Fragile tracheal structures. Pantoni method, which is by translaryngeal approach. Contraindicated anterior neck puncture, where you are not supposed to go for the anterior neck punctures. And finally, ultrasound guided. Ultrasound precision, high risk patients like obese or abnormal anatomy, where the vasculatures you are not sure to go blindly. So definitely, and you can combine ultrasound with your bronchoscopy for every procedure. Before going for the procedure, you can do the ultrasound, assess the vascular structures around the anatomy the neck, and then go for the procedure. Now the complications, again, that will be again divided into immediate, early, late, long term. In immediate, bleeding, pneumothorax, tube displacement. Early, infection, subcutaneous emphysema, you have done the procedure. Next day when you are coming for the round, there is no subcutaneous emphysema, tracheitis, infections, inflammation. Late would be tracheomalacia, fistula, stenosis. Long term, definitely there would be some person of patients where you will be getting voice change, or there would be some cosmetic concerns that will be also there. Now, again, another way of answering: immediate complications, intermediate complications, late complications. Immediate complications, common, all the things that you can think about when you are doing the procedure, what can happen. Immediate complication, when it would be day 2 onwards, day 1 to day 7. Persistent bleeding, tube obstruction, displacement, atelectasis, something like that. Late complication, when you are getting it more than day 7, like fistulas, malacia, or stenosis, necrosis, fistula, again, all tracheoesophageal fistula also sometimes happen. And functional and quality of life issues like major aspiration, speech deficit, swallowing deficit, tracheocutaneous fistula, that would be something which is coming more than 7 days. This is again one pager related to this percutaneous dilation, dilatational tracheostomy. So this is something just to you can how you are actually mentioning in your answer sheet, but you don't need to write the procedure itself. No examiner expects you to put the pictures of the procedure. Rather, it would be indication, contraindication, complications, types, then the specialties, how you will be doing the post procedure care. So that would be something every examiner expects you to know. Now the last one, as usual, it would be clinical case. Rather than giving you a direct question about, write down about 2 pages about tracheostomy, I would be expecting my examiner to get this type of question. A 55-year-old mechanically ventilated patient with ARDS has been intubated for 10 days. Now, the intensivist recommends a tracheostomy, but the patient's family expresses concern about potential long-term complication. Now, the question is, how would you explain the benefits of tracheostomy compared to the prolonged endotracheal intubation in terms of patient comfort, ventilator winning, and complications while addressing the family's concerns? This is a format of question that you may get if the examiner, the question setter would be asked maybe this is something like they would be keen to know your clinical acumen, so they would be framing this type of question. So you have to mention about the improved comfort, facilitates winning, reduced complications. This would be the benefits. Long-term concerns also, you have to explain to the family about the complication risk, the reversibility nature of the tracheostomy, that it's a very temporary method and it can be removed once the patient recovers, and also showing the communication skills for a difficult patient like this, where nothing is very much as per your own the estimation. So you can show empathy and share decision making by reassuring the family that the decision is tailored to the best of the patient's interest, balancing the current need, the risk benefit ratio with long term outcome, and involve a multidisciplinary team like respiratory therapist and ENT to provide comprehensive care and support. Thank you very much. And just at the end, maybe instead of tracheostomy, you may get a question like cricothyrotomy, simple cricothyrotomy. So just one page about cricothyrotomy. The advantages we all know: technically simpler, faster, low complication rate, bedside procedure, doesn't require hyperextension of the neck, minimal encroachment on the mediastinum, the vasculatures, the esophageal injury will be less. Application would be in the trauma management, cervical spine injury, where you don't have the expertise, as well as the patient is not giving you that field where you can go for extension of the neck to do the tracheostomy. Emergency settings, when you are unable to go for oral or nasotracheal intubation and you do not have the the expertise to go for tracheostomy. Contraindications, definitely airway obstruction below the larynx, you cannot go for the cricothyrotomy in those patients. Primarily the patient is having laryngeal trauma and or tumors and infection, you cannot do. And children less than 10 to 12 years, because there is a high chance of going for subglottic stenosis or transection, and better rather than you should go for percutaneous needle catheter ventilation, jet ventilation, something like that. And the cricothyroid membrane, everybody should be aware. You should go tomorrow if you are still not clear where is cricothyroid membrane. This is life-saving emergency procedure located 2 to 3 centimeter below the laryngeal prominence, that is the thyroid cartilage. It is easier to access due to superficial position. Complications are there would be complication, but it is very less. And the procedure has to be transition from the cricothyroidotomy to the standard tracheostomy within 2 to 3 days to reduce the complications. Thank you very much for your patient listening. I know I have been a little bit maybe more than 1 hour, but this is
Many hours, probably more than 4 hours now. I will try to be short and discuss few practical relevant things. So first of all, I was asked to talk
Sanand.
about some. Yeah,
Sanand, just if I'll be taking 1 minute time because maybe the candidates will start leaving. Maybe as we go ahead, there is some announcement that I need to do before I am leaving it to Dr. Sanand. That on December 22, please remember there is a grand mock test that we are conducting for the first time. Sanand, can you just allow me for 30 seconds to share my screen?
yes, go ahead.
Yeah. Just 1 second. Okay. Okay, can you see my screen? So this is something which we are doing for the first time. National mock exam for DRNB and DM exit exam, that is for theory. And the question would be released to you on 22nd December. You will be
Suppose the
given
screen is
time.
not there.
Okay, just 1 second. Is it visible now, Sanand?
Yes.
Yeah. So this would be the format of this national mock exam. This is first time we are conducting in national level, and the questions would be released on 22nd December. We are expecting to start the exam at 10 a.m. to 1 p.m., but you can take your own time. We know that some of you must be in the hospital in ICU in your duty hours, so you will take 3 hours time as per your own convenience, but we strongly recommend that you should write 3 hours exam before your real theory exam. You don't take it lightly. As per our previous batches, people will find difficulty in writing all those ideas that are in their mind, and they will be no missing or no losing the important questions also due to lack of time or due to lack of practice of writing on the theory paper. Now, the best part about this is that we will be doing the debrief about all those 10 questions with real handwritten answers in 2 pages only, just like you will be writing in your theory paper. It will not be like in the presentation format, PowerPoint. Rather, it would be page wise, 1 page, 2 page, front page, back page for each question. And it will be with very short answer that would be guiding you how to write it in your real theory exam. So it would be starting at 4 p.m. 22nd December. There will be 10 questions only. So don't worry, we will not go for 3 papers. Rather, it would be only 10 questions from different domains. Most common and expected questions that may come in your real exam. So you who knows that you will get 2 to 3 questions from that 10 questions. And along with that, we will be also highlighting 10 questions from that single question domain from where we have actually selected that question. So if it would be a cardiology question, we will be also giving you 10 more questions most expected for your theory exam. So there would be 11 questions from each domain. So you will be definitely getting 15 to 20 questions as per our understanding and expectation. So something which we thought about, and this would be comprehensively covering your theory part completely. Recent trend of questions that would coming in last 5 years, real-time simulation, so that you can have your answer sheets. You can share all your written answers also to us, and definitely we will be de-identifying your the names and all the details. It would be all the marks, the answer sheets would be kept confidential, but we can take it, assess your answers, and we can give you marks also, how you will be doing in your real exam. So this is something which we strongly recommend you to register immediately. My team member will be posting in the WhatsApp group to register immediately, and this is again free. We are not having any registration charge for this. So this is something I thought about sharing right now, and please share with your own colleagues and groups. People should take advantage of this before the real battle that is coming on January 17, 18, and 19. And one more thing, we are happy to inform you or announce that all the videos about biostatistics have been uploaded in YouTube in our channel 360 Critical Care, and in again segment wise. The first part by me, second part by Dr. Sanant, Dr. Darshan, Dr. Niharika, Dr. Srihari, and Dr. Bhuvneshwari. So all the things right now is available, and you can go through multiple times before your exam. And this will be also be shared to you maybe in couple of days. Thank you very much for your patient listening. I'm stopping it.
Thank you, Tapas.
Sorry,
That's
Zanath, please
good.
go ahead.
All right.
Stop.
All right. Hopefully, my screen is visible to you guys.
Yes,
Okay.
it's visible, Sanant. Yeah.
Okay. The first topic was about cerebral blood flow. So this can be a question like an anatomical representation of the cerebral blood flow or determinants of cerebral blood flow. Questions were asked about the arterial side of that, venous drainage of the brain, and venous complications of the brain that can happen is a question also. We have discussed about venous sinus thrombosis in our neurology domain. So that's an important question that can be asked as a part question, like describe the venous drainage of brain or central nervous system and pathophysiology of venous sinus thrombosis, clinical features and treatment. So that can be a question. So just going briefly about the arterial supply of the brain and spinal cord. As a medical student, as a specialty student, you guys need to know the anatomy of the circle of Willis. Relevance of it is they can ask you about the questions such as aneurysm or aneurysmal bleed, and they can ask you about describe the anatomical distribution of the major arteries of the brain, and then they can put the second part of the question as a subarachnoid hemorrhage and berry aneurysm or something like that. So basically, the circle of Willis is constituting all the major arteries of the brain, um, which constitutes the anterior, middle, and posterior cerebral arteries and its branches. And it should be a easy thing for you guys who should be able to draw the circle of Willis. This can be a question in the exam. Cerebral blood flow. Carotid system supplies 70% of the blood flow to the brain, and vertebral system supplies 30% of the blood flow, which accounts for around 15 ml per 100 gram of brain matter per minute, or it accounts about 14 to 15% of the cardiac output. So these numbers are better to remember and write it down on the paper when there is a question around it, because they will carry some mark. As exam going people, basic physiology and anatomy is important, so you may need to know the arterial supply and the display in the medial and lateral aspect of the brain with the corresponding arteries. So I would request you guys to at least practice these two diagram before the exam, because that can be a question like arterial supply to the brain. We talked about this question in the neurology domain earlier in the top course, but I'll go briefly about it. So there was a previous question about neuroanatomy of cerebral venous drainage and give etiology, clinical features, and features of cavernous sinus thrombosis and ICU. So a potential question that has been asked already. Venous supply of the brain is simple when you classify them into a superficial venous system and a deep venous system. The superficial venous system again constitutes the cortical vein, which is again classified into superior, middle, and inferior based on their location in the brain. And all these three major vein or venous channel drain into the superior sagittal sinus. Again, importance of superior sagittal sinus is they have the arachnoid granulation or arachnoid plexus there, which is responsible for CSF circulation in the brain. So that is again important part. The deep system again constitutes venous drainage from the subependymal and medullary region or medullary vein and subependymal veins, which again combine together to drain into the sinuses, which is the transverse sinus, sigmoid sinus, and a straight sinus. So there are four major sinus in the brain: superior sagittal, transverse, sigmoid, and straight sinus. Ultimately, the superior sagittal sinus joins at the confluence of the sinuses along with all these three sinuses and finally drain to the ipsilateral internal jugular vein. So that's the basic venous drainage of the brain. Now, how do you put your cerebral venous sinus thrombosis into the anatomical context is the next part of it. So cerebral venous sinuses are very peculiar structures. So the dural venous sinus layer lie between the outer or the periosteal and the inner or the meningeal layer of the dura mater. So all the venous channel lie between the dura mater, between the two layers of the dura mater, outer meningeal and the outer periosteal and the inner meningeal layer. Now, these sinuses do not have valves in them, unlike other veins, which allows free flow of blood in both direction. It should ideally flow out of the brain into the heart, but if the pressure changes are reversed, then it can flow other way around. When the brain pressure increases, the blood can flow from the brain into the so usually the venous drainage is gravity related and it directly drains into the heart. But if the pressure or if there is an occlusion, there can be reversal of flow. We'll talk about that in the pathophysiology of this. There is increased back pressure due to any cause can lead to cerebral edema due to elevated capillary pressure. So the venous side of the brain, pressure in the venous side of the brain can increase due to increased backflow, which can cause edema of the brain, can cause ischemic infarction because of blood stasis in the brain. So usually this happens with the raised ICP in a traumatic brain injury where you have diffuse axonal injury or you have a severe traumatic brain injury where because of the edema there is raised ICP and the venous drainage is compromised. Sinus thrombosis can lead to communicating hydrocephalus. So because you cannot drain the venous system of the brain, there will be communicating hydrocephalus. The CSF outflow is not obstructed within the ventricular system, but still the venous pressure is high, so it can lead to communicating hydrocephalus. Again, a little bit of arachnoid granulation, so which secretes the CSF back to the venous sinuses are primarily sagittal sinus. So any thrombus of the can cause impairment of the drainage of CSF from the brain, which can directly cause higher pressure in the ventricular system, causing communicating hydrocephalus. Now, a little bit of pathophysiology. Basically, there are four major things that happen with a obstructed dural sinuses. So what happens once you have a obstructed dural sinus? Again, not a single sinus obstruction can cause the symptoms. It has to be a bit patchy and diffuse to cause symptoms. So you'll have, with the obstruction of dural sinus, you'll have increased venous pressure, which can ultimately lead to increased intracranial pressure. We talked about back pressure in that. Because of the back pressure, there will be disruption of the blood-brain barrier, or destruction of the blood-brain barrier, which can cause vasogenic edema. Because of venous and capillary rupture, because of back pressure, again, smaller veins can rupture. This can lead to parenchymal hemorrhage, which usually is the presentation with a venous sinus thrombosis. And also it can cause decreased capillary perfusion, decreased cerebral perfusion, leading to failure of energy or energetic metabolism in the brain, thereby causing cytotoxic edema. So basically, any venous obstruction in the brain can lead to these four pathology, which includes vasogenic edema, parenchymal hemorrhage, cytotoxic edema. All these three things combinedly or individually can lead to increased intracranial pressure. Etiology-wise, for the cerebral venous sinus thrombosis, just going quickly through that. So it is usually an inherited thrombophilia or an acquired. So it should be inherited on the right side, and it should be the acquired thrombophilia. I have wrongly written as inherited. Apologies for that. So the acquired ones can be oral contraceptive, pregnancy, antiphospholipid antibody syndrome, sickle cell disorder, autoimmune disorders such as lupus or any vasculitis, nephrotic syndrome, which is again a hyperviscous trait, can cause increased thrombosis, dehydration, malignancy, direct invasion of the venous channel. Even hits can cause that, or any intracranial hypotension like a trauma or a severe bleeding that can cause hypoperfusion to the brain, can later on causes stasis of the blood in the venous channel, causing venous sinus thrombosis. Again, we saw a increased rate of venous sinus thrombosis in the COVID epidemic, up to 0.1% incidence of cerebral venous sinus thrombosis. And of course, mechanical causes, they are very important, like traumatic brain injury with a base of skull fracture, which or the fracture line going through the venous channel, then they are very prone for causing venous sinus thrombosis. Inherited thrombophilia, which has antithrombin deficiency, protein C and S deficiency, factor V Leiden, or hyperhomocystinemia. All this predisposes the patient to have a thrombosis in the venous channel. Clinical features, again, they vary based on where they are located, but usually the patient presents with headache. It is the major symptoms, 80% chances, with associated nausea, vomiting, diplopia, inability to abduct the eye, which is a cranial nerve 6 deficit. Patient can have presentations such as the subarachnoid hemorrhage, such as occipital or neck pain. Or if the lateral sinus thrombosis is there, then it can resemble an ear infection. Sometimes the ear infection can coexist with the venous sinus thrombosis because of spread of infection through the petrous bone into the sinuses. Second common presentation can be seizure, which can be secondarily due to venous infarct. Usually it is focal, but can later be generalized. The patient can have encephalopathy, such as due to communicating hydrocephalus. We talked about that, intracranial hemorrhage or edema or herniation. Now, specific to certain venous sinuses, if they are isolatedly thrombosed, very subtle finding, very difficult to find, but you can have oculomotor palsies, you can have facial numbness, periorbital pain and headache, proptosis with ocular erythema, and if it is a septic cause to that, or septic thrombophlebitis, then patient can present with sepsis and fever. This table show a gist of possible symptoms when particular sinuses are involved, but there are a very high degree of overlap. For example, sagittal sinus, 60% cases are because of the thrombus in the sagittal sinus isolatedly. They can present with elevated intracranial pressure, such as headache and papilloedema will be the symptoms. Patient can have seizures. Also, you can have symptoms which are very focal, such as aphasia or hemianopsia or hemisensory losses. So similarly, there are diffuse or there are various presentation with particular sinus involvement, but very rare or very difficult to find such presentation saying that isolatedly the sagittal sinus is involved. So you'll have these type of presentation. It is very rare because usually it comes as a constellation of symptoms. Multiple sinuses are involved. Patient usually present with a headache or fever and encephalopathy, which is unexplained, and it doesn't go with their age, because you can see in the previous slide that we discussed, the causes can be very specific, like acquired and inherited causes. So more common in the female compared to male, almost twice. Diagnostic workup, again, laboratory studies are rarely helpful. You need to rule out other causes such as CSF examination to rule out a meningitis. Imaging, there are few CT scan findings that is pathognomic of this NTD, where you can see a what you call as a dense triangle sign or a empty delta sign, where you can see there is filling defect in the suprasagittal sinus. So this is called as the empty delta sign. Then MR venography is most sensitive and gold standard. In addition to that, it can show you some edema or infarction there, which is not delineated by the CT. And DSA can be used if you cannot find a thrombus in MRI, but you are very, very suspicious of that. So in that case, DSA will be the best test to see whether if there is anything that is being missed in the CT or MRI. Quickly through treatment. So immediate therapeutic anticoagulation is life-saving, irrespective of whether the patient has venous infarct or intracranial hemorrhage or isolated subarachnoid hemorrhage. The patient needs to be anticoagulated, and that's the only therapy that works well, has been studied extensively. Endovascular thrombolysis or mechanical thrombectomy, very complicated process, usually not done in most centers, but very varied outcome benefit with it. So not widely studied, but anticoagulation is the mainstay of treatment, and long-term anticoagulation this patient will require, usually with a DOAC. But if the patient has pregnancy or malignancy, in that case warfarin may be the drug of choice. Also in case of APLA or sorry, not in pregnancy, low molecular weight heparin will be the drug of choice for pregnancy and malignancy, and warfarin for APLA and CKD patients. Going to the next aspect of that. So define how do you define cerebral blood flow? Enumerate the factors affecting cerebral blood flow and discuss the mechanism of cerebral autoregulation. So this is a very important question. And there's a pattern to remember the answer for this. So we'll go about it. So cerebral blood flow values, again, we talked about that already. Carotid 70%, vertebral arteries 30%, and overall it's 15% of the cardiac output. Cerebral blood flow, the determinant is your cerebral perfusion pressure, CPP, and the cerebral vascular resistance. Again, the CPP is the difference between the mean arterial pressure or the ICP or the CVP, whichever is greater, divided by the cerebral vascular resistance. So as you can see in this formula itself, you can tell the factors that determine the cerebral blood flow. So the most important thing to answer this question is to remember this formula. If you remember this formula, you can easily write on this question. So apart from the contributing factor, other things that can hamper or that can influence the cerebral blood flow is a CVP, which gets elevated in case of coughing, straining, vomiting, or in head down tilt position, particularly the anesthetic complication. So if the patient stays head down for a longer period of time, there is increased congestion of the brain because of increased cerebral blood flow. That can happen. Again, CVP is raised, so your CPP minus the CVP number will be less. In that case, your cerebral blood flow can be less. So either way, if the CVP gets higher up, then your blood supply to the brain decreases. If there is more head tilt position for a longer period of time, in that case, your cerebral blood flow may increase indirectly. Again, if the patient has a raised ICPs due to a space-occupying lesion or a edema, again, the cerebral blood flow decreases, because the difference between the going back to the formula. So if any number which is ICP or CVP increases, then this subtraction from MAP to this pressure will have a lower value, thereby decrease in the cerebral blood flow. So CVP and your ICP are inversely proportional to the cerebral blood flow. Mean arterial pressure, not rocket science. So if the patient is hypotensive, there will be low cerebral blood flow. Now, the other factors that govern is something called as the neurogenic factors. So neurogenic factors are important. So you know that there is, or we know that there is regional variation of blood supply to the brain. Some of the cortical region are better blood supplied compared to the inner non-cortical region, which is there is less blood supply. Thereby, they are more amenable to hypoxia and hypotension. Anterior circulation has more dense sympathetic innervation compared to the posterior circulation. Anterior circulation is controlled by the supracervical ganglion sympathetic innervation, and posterior circulation is innervated by the sympathetic chain by the vertebrobasilar artery. That's why in case of a in case of a hypertensive emergency, there is selective blood supply to the brain, because the autoregulation is impaired at particular places compared to the whole of the brain. That's why we get the posterior reversible encephalopathy syndrome, in particularly in a hypertensive patient, where particular region of the brain is affected compared to the whole of the brain. The posterior circulation is more prone for such insult, because the autoregulation is not that great in that region of the brain. So again, other factors that can be governed by the neurogenic factors are neurons and other cells secrete specific mediators such as acetylcholine, nitric oxide, who are potent vasodilators, and serotonin and neuropeptide Y are vasoconstrictors. So this factor comes into account if either the neurons are directly damaged or indirectly damaged because of secondary injury. So any injury to the brain can cause disruption of those neurons, and then they can secrete these metabolic substances that can cause direct or indirect effect on the blood flow to the brain. So that's the neurogenic factors that they govern the cerebral blood flow. Endothelial factors. So endothelium is an active organ that we know. So it produces vasodilators such as nitric oxide, and also has a vasoconstrictor potency, which can be mediated through thromboxane 80 and endothelin 1. Again, based on what sort of substance is secreted from the endothelium, your response will be similar. It can be vasodilatory or vasoconstrictor based on the amount of neuromediator which are secreted, or inflammatory mediator that are secreted. Statins increase the nitric oxide synthase activity, and in experimental cases, they have to be found to have increased cerebral blood flow because they can cause cerebral vasodilatation. This hasn't been translated into practical application. We are talking about vasospasm in subarachnoid hemorrhage, where subarachnoid hemorrhage can cause vasospasm, and experimental evidence are there that statin can help. Statin can produce nitric oxide, thereby causes vasodilatation. But that hasn't been seen in larger clinical trial. This is only, you can say, at the experimental level, where statin can cause vasodilatation. Most important is the metabolic factor, which are rapidly acting compared to any other factor. So the metabolic factors include carbon dioxide, pH, oxygen, temperature, and glucose. So with raised PaCO2 or carbon dioxide in the blood, it can cause increase in cerebral blood flow. So every 10 rise of PaCO2 can cause a 4% increase in cerebral blood flow, which is pretty significant because of vasodilatation. Again, pH regulated by carbonic anhydrase activity in case of acidemia can lead to vasodilatation and increased cerebral blood flow. Oxygen, cerebral blood flow only increases when there is a significant hypoxemia. Because of autoregulation, There is a wide range of PaO2 where the cerebral blood flow is not affected by the change in PaO2. But if it is below less than 50, the PaO2 in brain, then it can cause cerebral vasodilatation. So this is another metabolic factor. Glucose, again, severe hypoglycemia can cause vasodilatation, thereby increase cerebral blood flow. Every decrease, 1 degree decrease in the brain temperature can cause 8% or 10% decrease in the central metabolic rate, and thereby it decreases the cerebral blood flow. That's why cooling was thought to be neuroprotective, because it decreases the cerebral blood flow. So these are the major metabolic factor that determine the cerebral blood flow. So we have talked about neurogenic, endothelial, and metabolic factor, along with few general factors yet. Now the last one is the myogenic factor, where the arterioles and small arteries contract in response to increased intraluminal pressure and vice versa. So what happens is a phenomena called as a recruitment, and also a phenomena called as a like a response to the increased pressure. So if there is increased pressure detected inside the lumen of the artery, then it can cause vasoconstriction by thereby decreasing the blood going through that artery. This is a myogenic factor, so governed by the muscles and the localized neuronal connection. So mediated through the transmission of intramural pressure, activates the mechanically sensitive ion channels and protein in the vessel wall. Cerebral or autosomal dominant arteriopathy, there is something called as a CADASIL, which is a disease entity itself, in which case you lack that myogenic factor or myogenic response. So the patient will not have autoregulatory mechanism due to the mutation, which increases the chances of stroke, hemorrhagic stroke, and dementia in this patient. So it is a known entity. This you don't need to remember, but you need to know about the myogenic factors. So there are 4 major factors that are responsible for the cerebral blood flow, which is again majorly governed by the mean arterial pressure, CVP, and the cerebral vascular resistance. So you know the mean arterial pressure, the factors that governs blood pressure is an important part. CVP is an important part. We talked about that already. This is, and major thing is a cerebral vascular resistance. Cerebral vascular resistance is governed by these 4 factors, that is neurogenic, endothelial, metabolic, and myogenic factor. Now this diagram on the corner, left hand upper corner, summarizes the whole question. So if you put this diagram in your exam, you will get half of the mark. So you don't have to remember all these things. Even if you just put this diagram in the exam, if you don't have time to write all these things, this will suffice, this diagram. Very, very important. So what it shows is the pressure on the bottom, like the x-axis, and the cerebral blood flow in the y-axis. So this pressure can be different parameter. It can talk about ICP. The pressure may represent a PaO2, may represent mean arterial pressure, or a PSU2. As you can see, there are 4 curves going through the picture. So this is the autoregulatory range from 50 to 150 for the mean arterial pressure. As you can see, 50 to 150. That means within that range, there is no increase in cerebral blood flow. But if the blood pressure is lower than that, there will be increase in cerebral blood flow. If it is if there is lower than that, there will be decrease in cerebral blood flow, and if there is increase in that mean arterial pressure beyond 150, there will be increase in the cerebral blood flow, and the rise is pretty exponential. Similarly, for PaO2 we talked about, so there will be no change till 50. But if the PaO2 is less than 50, there will be a serious rise of cerebral blood flow, causing cerebral vasodilatation and then increase in cerebral blood flow. So this is again a very abrupt or steep rise. Higher the PaO2 beyond 200, there is some evidence that it can cause vasoconstriction of the cerebral blood vessels and thereby decreases the cerebral blood flow. That's why hyperoxia can be harmful and can predispose to strokes. PCO2, again, with the rise, there's a linear relationship. As the PCO2 increases, your cerebral blood flow linearly increases. And the last one is the ICP. We'll talk about that in a different slide. So what you see is for a constant up to a level of ICP, the blood flow remains same with the autoregulation. But if it goes beyond a certain point, then the blood flow also relatively decreases gradually, because the blood flow is the formula in the blood flow. The numerator is MAP minus ICP. So if the ICP increases beyond this number, the blood flow decreases. So this is the most important curve to remember to talk about cerebral blood flow. But I will also recommend to remember the 4 factors that is important. Now discuss the mechanism responsible for autoregulation. Very important question. So basically, if it comes as a question in the exam, you need to write what do you mean by autoregulation. So autoregulation is a homeostatic process that regulates and maintains cerebral blood flow constant across a range of blood pressure. We talked about that already. Now the range is a mean arterial pressure of 50 to 150 or 60 to 160, you can say, and a CPP of 50 to 150. So this is the range where the autoregulation is maintained for the blood pressure. Now mechanism, we talked about that: myogenic, neurogenic, metabolic, endothelial. So if this question comes, this is the pattern how you answer. Now assessment of autoregulation. So this can be a question. It is a complicated physiological understanding there. So there are 2 measures. We call it as a static measure and a dynamic measure. So the static measures is that drug administration to change in MAP without affecting the metabolism. So what happens is we give a drug to the patient to increase the MAP, and thereby we look at the change in cerebral blood flow. Thereby, if the cerebral blood flow is maintained within a range of the mean arterial pressure or systolic blood pressure or the cerebral perfusion pressure, any pressure within a range, then you know that the cerebral autoregulation is intact. But if it is not, then it is not intact. So you get a baseline map of the patient and you infuse a drug to increase the blood pressure. Then after some time you measure another blood pressure. So corresponding 2 values of cerebral blood flow at the same time is measured, and the change in cerebral blood flow in relation to the map is indicative of the cerebral autoregulation. So we call it as a autoregulatory index, or ARI. ARI is representative of percentage change in cerebral vascular resistance to percentage change in cerebral perfusion pressure. The value stays between 0 to 1. There is the equivalent resistance as cerebral perfusion pressure ratio changes are equivalent, and the ratio is 1. That means the autoregulation is maintained. But if it is 0, then there is no autoregulation, and between 0 to 1 means there is somewhere impaired autoregulation. So again, this is a theoretical experimental number that we look for. Clinically, it is not used, at least where I have worked. Hardly we use it looking at these numbers. But the question in the exam can be like, if you're talking about the physiology, then they can ask you about how do you measure the cerebral autoregulation. In that case, you need to know a little bit of this. Now, the dynamic measures the dynamic changes in cerebral blood flow in response to dynamic changes to MAP. So cerebral blood flow should return back to original value within a specific time, even if the cerebral blood flow changes with abrupt changes in the mean arterial pressure. That should change on its own to its baseline. Even if, suppose for example, you increase your MAP to 150 to 180, there will be a transient rise in the cerebral blood flow for some time, but again the body will accommodate that and it will come back to the same level of cerebral blood flow within a short period of time. So that's why there is a dynamic change. If the dynamic change is intact, that means your cerebral autoregulation is intact. But if it is not intact, then with an increase in the MAP, you will have a higher blood flow into the brain. So those are the dynamic measures. Usually we call it, or we do it through a high cuff method, where cerebral blood flow is measured by the transcranial Doppler. So they will inflate the cuff in the thigh and initially see if there is an increase in the blood flow into the brain. If the blood flow into the brain stays increased for a length of time, that means there is no autoregulation, or there is lack of autoregulation or impaired autoregulation. But if the blood flow again comes back to the baseline in spite of the tourniquet, then you know that there is an intact autoregulation. So the static measures and dynamic measures. Clinical uses of autoregulation testing, as I said, usually not done clinically. Perioperative management of patients undergoing cardiac endarterectomy, you can think of doing it more of a clinical judgment rather than we put in devices to look for the cerebral blood flow. Blood pressure management in uncontrolled hypertensive patients that can be used, and blood pressure support in patients with carotid artery stenosis. So um, again, this is an important or interesting physiological variation. So if the patient has significant carotid artery stenosis, their autoregulatory range is very narrow. If you drop their blood pressure or map below 50, they will be obviously unconscious. But again, that lower level is pretty higher for them. So like their autoregulatory range will be between 90 to 120 of map. So you have to have a map of 90, otherwise they will have neurological symptoms and stroke. So as you have more stenosis of the carotid artery, the autoregulatory range can be narrowed. So it is an important aspect when we are doing vascular surgery to monitor brain perfusion on both sides while operating on the carotid artery. So there are different measures to look at. Some center do central oximetry, some center do Doppler. All those things can be done. But the measurement of static or dynamic measure of autoregulation in a what do you call continuous measurement is still not in the clinical practice as yet. But that can be asked in the exam. What happens if you lose your autoregulation? That is the following question. Either you can lose your autoregulation, which can cause different effect, like what is the outcome of what can happen to a patient if they don't have a intact autoregulation. So usually in traumatic brain injury, the autoregulation is absent or impaired. Even the cerebral perfusion pressure or cerebral blood flow is normal. So what happens is if you have a disruption of the autoregulation due to anything, usually it is a secondary brain injury that causes it. You can have or you can maintain a good blood pressure, you can maintain a good cerebral blood flow, you can maintain a good cerebral PO2, but still if the autoregulation is impaired, then worse outcome. In traumatic brain injury, there is cerebral hypoperfusion, either um, due to the sedation or the coma the patient has. So if you sedate the patient, there is less cerebral metabolic requirement, and you can have less blood supply to the brain, causing less perfusion or cerebral blood flow into the brain, or it may be due to the hypoperfusion or shock causing ischemia. So suppose traumatic brain injury having a hemorrhagic shock, in that case also there will be less blood supply to the brain. So these are the two factors that can cause a hypoperfusion state to the brain, which is in literally the less cerebral perfusion pressure, less cerebral blood flow, which can cause ischemia, and that can cause exacerbation of secondary brain injury, that can cause the loss of autoregulation. So all the pathological process happening in traumatic brain injury or any sort of insult to the brain, whether a stroke or a subarachnoid hemorrhage, can be explained in terms of brain injury due to low perfusion state, which can be due to either ischemia or metabolic injury. We'll talk about that in few more slides. So basically the outcome of loss of cerebral autoregulation is exacerbation of secondary brain injury. It is a vice versa process. Loss of autoregulation can cause exacerbation of secondary brain injury. Again, secondary brain injury can cause loss of cerebral autoregulation. Then there was a question about CSF, just changing gears. So formation, circulation, and function of cerebral spinal fluid. Again, these are very solid questions to score because the fact doesn't change in this physiology question. You need to have your understanding clear about it. So we'll talk about formation, secretion, absorption. So all three things come together. The rate of CSF formation is around 500 to 600 ml per day, and it is churned about 3 to 4 times in a day. So the circulation time is 8 hours. So within 8 hours, the whole of the CSF gets changed or gets circulated through a particular region of brain. So 3 times a day. Choroid plexus forms around 70%, ependymal wall or ventricles forms around 30% of the CSF. Plasma is filtered across the fenestrated membrane of the choroid capillaries endothelium via bulk flow or ultrafiltration. So this is the mechanism how the CSF is formed along the hydrostatic pressure gradient. So the formation of CSF is more or less due to the hydrostatic pressure changes, due to the gradient that is created. That's how the CSF is formed. The constituents of CSF, again, it is an important question. If you know it, you can write it, you cannot bluff it. So electrolytes in the CSF, sodium enters the CSF and potassium leaves the CSF actively against their concentration gradient. Chloride and bicarb move passively into the CSF down their concentration gradient, and water moves from the plasma into the CSF due to osmotic gradient. So the major constituents are electrolytes, sodium, potassium. They move against their concentration gradient. That's the active process. The negatively charged ion, chloride and bicarb, move passively in the CSF along their concentration gradient, and water goes through the osmotic gradient. So this is how the CSF is formed. If you write this much, that should be enough. Glucose enters the CSF by the facilitated transport. So glucose, to be sure, all over the body, it cannot transfer on its own. So it has to be a facilitated transfer always for the glucose. So you can write this sentence in any form of formation question. So how CSF is formed? So glucose enters the CSF by facilitated transport. Protein enters the CSF via vesicular transport across the cell, but some enters through the tight junction and via extrachoroidal site. So this is important because you will have a very low amount of protein in the CSF because of this mechanism. If you have inflammation, that can cause leakage of protein into the CSF1 or secretion of protein into the CSF2. So these are 2 reasons why you will have a high protein in any type of CSF insult, whether it is an infective or a non-infective causes such as malignancy or even trauma, subarachnoid hemorrhage. All these things will have a high protein in the CSF. This graph, again, very important. If there is a formation or CSF physiology question, make sure that you draw this graph. So the graph we talked about in the autoregulation and this graph, these are the 2 important graphs to remember in CSF physiology or brain physiology. So on the y-axis is the CSF volume, on the x-axis is the pressure. Again, you can see there are 2 mechanisms, absorption and production. So the production remains the same throughout the ICP. If the pressure increases, the production still is same to a particular level, but most of the range of the ICP, intracranial pressure, the production remains the same. But as you go higher on the intracranial pressure, initially within a physiological range, the absorption is balancing the production. So whatever you produce, that gets absorbed. But as the ICP increases, there is more pressure on the system to absorb more CSF. So then here the CSF absorption becomes exponential till a value where the pressure is too high, and then nothing can happen. Like everything shuts down when the patient is brain dead or there is malignant intracranial pressure. So this is important. The production is not affected by the intracranial pressure. The absorption is linearly increased after a physiological range of ICP. This is important to remember. Okay. Now, determinants of CSF formation, we talked about that. So for a CPP of more than 70, there is minimal change in CSF production rate. But if the CPP is less than 70, then the CSF formation also decreases due to secondary decrease in cerebral blood flow. So this is general understanding. If there is less blood going into the brain, there is less production of CSF. Absorption, again, absorption 90% is through arachnoid villi and less 10% through the cerebral venules. So production is 70-30 through the choroid, and ependymal ventricle is the secretion part. Choroid 70%, ependymal wall 30%. and absorption is 90-10. Arachnoid is 90 and cerebral venules are 10. Determinants of CSF absorption, we talked about that already. Circulation, CSF flow plus. So CSF flow is generated by the ciliary movement of the ependymal cells. Respiratory oscillation and also arterial pulsation cause CSF movement. How do you know that? If you transduce a CSF pressure, you will have the similar waveform as that of a arterial waveform. So there is impulse that is generated from the artery into the brain parenchyma and also into the CSF space like the ventricles, where the pressure corresponds to the changes in the blood pressure. Thereby the same dynamics happens. So the CSF is also propelled into the system or around the system by the changes in the pressure. Respiratory oscillation also, because respiratory oscillation also varies our pressure, also varies our CVP, that can indirectly affect the blood supply to the brain. Within the ventricular system, from the lateral ventricle to the third ventricle via the interventricular foramen, this is the circulation pathway. Then both the lateral ventricle come to the fourth ventricle via the cerebral aqueduct, and then to the subarachnoid space through the cisterna magna via the foramen of Mezenty and Lusca. Lusca, L for L, lateral is Lusca, foramen of Mezenty is medial in position. It then circulates in the subarachnoid space surrounding the brain and spinal cord. So that circulation happens 3 times a day. Now, functions of CSF, very easy to answer, solid question, and you'll get total mark if you know the points, how you answer it. So it has a protective role. So water acts as a water bath. So CSF acts as a mechanical cushion to prevent brain injury associated with acceleration or deceleration forces secondary to changes in head position or direct head trauma. Because of the low specific gravity of the CSF 1.007, so the effective brain weight is reduced from 1400 gram to 50 grams because of the CSF. When the brain floats in the CSF, then the weight of the brain gets less, so that if there is a acceleration or a deceleration process, there is less impact on the brain. It works as a buffer, so buffer for the pressure. So acute increase in ICP associated with acute space occupying lesions or any bleeding or anything that happens acutely. This is again translocated by displacement of the CSF from the intracranial space into the extracranial, like the spinal cord space, or from the brain into the spinal cord if there is an increase in pressure in the brain. It maintains the constant ionic environment. It supplies nutrition. It is responsible for excretion of toxic substances. Though there is no lymphatic system in the brain, but it works as a lymph for the brain. It manages the acid-base status of the brain, and it has also endocrine function, transport hormones to other part of the brain. So these are the points for function of CSF. Now going to the third question. So if we are talking about CSF, we'll talk about intracranial pressure. So sometimes what happens is people get confused in the exam. They will ask about enumerate the factor determining the formation of CSF, and people start writing about factors governing the ICP. Though they are overlapping, but they are not the same. At least when you are writing, it should not be mentioning vice versa. So if they're asking about CSF, talk about CSF. If they're asking about ICP, write about ICP. The factors are overlapping, but not common. So we'll talk about intracranial pressure now. So physiological factors that determine the intracranial pressure. Explain briefly how intracranial pressure is regulated. Discuss intracranial pressure dynamics in patients with brain trauma. All right. Intracranial pressure, again, definition is the hydrostatic pressure within the cranial vault, which is around 5 to 15 millimeter of mercury. The physiological determinant of ICP is governed by the Munro-Kelly doctrine. So important again, if it asks for this in the exam, it is a solid answer, because if you know, you can write, you can get the full mark. So in adults, the rigid and the closed cranial vault forms a fixed brain volume that contains brain, CSF, and blood vessel. So brain parenchyma accounts for 80%, CSF accounts for 10%, and cerebral blood and blood vessels count for 10% of the volume. So any changes in the volume of any of these components will alter the volume of one or more of the other component of the cranial contents. And this compensation happen to a particular range beyond which further compensation will not happen, will cause an exponential rise in the intracranial pressure. So that's the Monro-Cayley doctrine. So ICP determinants. So there are three factors: brain volume, CSF, blood volume. Now brain volume, again, brain volume means mass of brain, but there can be additional masses such as tumor, such as blood, cysts, abscesses, etc. that can increase the brain volume. Brain volume, then second part is the blood. That means, as I talked about, any hematoma, extradural, intraparenchymal, subdural hematoma, that all can cause an increase in brain volume. And edema. Edema is usually missed as a part of a brain volume, but this is an important part. In trauma or any inflammation to the brain cause significant edema, which can cause an increase in brain volume effectively, because edema means accumulation of water. Then the second important structure in the brain is the CSF. Again, CSF is governed by the production and absorption. So here the CSF comes. If the question asks about ICP, you have to talk this way: brain volume, CSF, blood volume. If the question asks about CSF, then you can talk about production and absorption. This is the overlapping factor here. So production is governed by multiple factors. That graph needs to come here, the flat CSF production curve with the pressure, but an equivalent or a linear increase in the absorption rate if there is an increase in ICP. So that graph needs to come here. We talked about that. So if the CPP is less than 70, there is less production of CSF. If the CPP is more than 70, there is no effect or constant production of CSF. Absorption, again, is based on ICP. If the ICP is low, there will be normal absorption. But if the ICP is high, there is linear increase in CSF absorption. The third point is the blood volume, which is mainly determine the cerebral blood flow. We talked about the factors governing the cerebral blood flow. Can anybody tell what are the factors we talked about? Any volunteers for that? All right, people try to keep quiet. That's good. Okay, blood volume, again governed by the cerebral blood flow.
An answer, Sanant.
Yeah.
CBP and CPP. What does Josna? What are you trying to mention here? Okay. Okay, you can go ahead. Yeah.
Okay, sure. We talked about this. Cerebral blood flow is governed by multiple factors: the myogenic factor, neurogenic factor, metabolic factor, all the four factors. So the cerebral vascular resistance is governed by those four factors. The other factors that is important is the temperature and cerebral perfusion pressure. This is the blood pressure, and temperature is an additional factor. So those four factors will come here: cerebral vascular resistance. Cerebral perfusion pressure is based on blood pressure, CVP or ICP, and temperature is an independent factor. All right, talked about that. Again, CVP and ICP increases with cough, sneezing, vomiting, that can alter your ICP. Cerebral vascular resistance, PO2, PCO2, that graph we talked about earlier, that will come here as an answer. Now describe the consequences of raised ICP. So initially there is compensation, there is this redistribution of CSF in the brain. If the pressure increases in the brain, so CSF is displaced to the spinal subarachnoid space, and or increased reabsorption rate, both happens. But later on, once there is decreased cerebral blood flow secondary to decreased cerebral, secondary to raised ICP, then it can cause cerebral ischemia, because if the pressure inside the brain increases, there will be less blood going into the brain. In very late stage, where the decompensation point is achieved, in that case, there is abrupt rise in ICP and there is quick decrease in the cerebral blood flow to the extent that there is no flow. That's how we detect the brain death. We look for a no flow state in a flow evaluation to see if there is doubt in brain death testing. That's why we send patient for either four vessel angiography or a isotope scan of the brain or flow scan of the brain to see if there is any blood going into the brain. So this is the decompensation point where the pressure is too high to allow any blood supply to the brain. So that's the consequences of raised ICP. All right, going to the next question. Pathophysiology of metabolic brain injury. Again, this is a very theoretical question that can come. You need to know certain points about it. You don't have to know in and out of the whole pathophysiological process in brain injury, but need to know few points to write in the exam. So discuss the mechanism of neuronal death and secondary brain injury, head injury pathophysiology. So this is important because TBI, traumatic brain injury, is very important. The whole question will be partitioned, like describe the pathophysiology of traumatic brain injury. How do you manage a traumatic brain injury? So part of that is clinical, part of that is theoretical in the exam. So for the theoretical part, you need to know few things to write down. Now, brain injury is classified into primary and secondary. Primary brain injury is what insult has happened to the brain, which includes either intraparenchymal injuries such as a diffuse actional or a contusion, or intracranial hemorrhage such as subdural, extradural, or subarachnoid hemorrhage that can cause secondary brain injury. All of that can lead to secondary brain injury. Also, pathologies such as hypoxia, ischemia, or an infection which can cause secondary brain injury because of either hypoperfusion state or hypoxia state or inflammatory state to the brain. So you need to know or have a clear idea about what do you mean by primary brain injury and what do you mean by secondary brain injury. So the care of neurotrauma patient is focused on to prevent ongoing secondary brain injury or transformation of primary brain injury to secondary brain injury. That's why the treatment is prevention of secondary brain injury in brain trauma patient. Now pathophysiology, so primary brain injury is straightforward. Either you hit your head or there is a hemorrhage to the brain or there is an infection to the brain. Okay, that's the primary brain injury. Secondary brain injury is the main part that determines the prognosis of a brain injury. There are different stages of secondary brain injury in a traumatic brain injury. This is talking about the traumatic brain injury, what happens. So there are stages of secondary brain injury, which is called as acute phase, subacute phase, and a chronic phase. Now, acute phase, due to any insult in the brain, ultimate final pathway is a hypoperfusion or low blood supply or a ischemic change to the brain. So either there is a metabolic failure because of direct injury or there is a hypoxia to that part of the brain that is governing the acute phase of the injury, that is within hours to few days, acute phase of the injury. So usually what happens is you have two phenomena that happens. One is lack of energy because there is a metabolic failure. The other one is something called as a excitatory injury, which is very important. So glutamate and arachidonic acid metabolites. So these are the two metabolites which can cause your excitatory injury to the brain. So the neurons are self-firing cells. Because of injury or irritation, they keep on firing, which is called as a excitatory injury, which is mediated majorly by the glutamate. What happens after that? If there is repeated hyperexcitability or hyperexcitatory state, there it leads to neuronal injury and subsequent neuronal death. That's why we treat any seizure activity very, very acutely. Suppose somebody has a convulsive or a non-convulsive seizure, we have to treat it because it is a excitatory injury to multiple neurons. If it keeps on happening for a longer period of time, there will be irreversible damage to those neurons, causing neuronal death. So that's the path how the excitatory injury to the brain happens. The second part, as I called, is a metabolic failure, where you have lack of energy due to ischemia, there is less ATP, there is disruption of normal iron gradient and increased calcium influx. So all the what do you call destructive pathway in the body goes through calcium. That is, at the end, there is increased calcium influx into the cell. So always write about increased calcium influx into the cell, thereby causing mitochondrial dysfunction, or vice versa. Mitochondrial dysfunction can cause increased calcium influx into the cell, thereby cell death. So acute phase has two components. One is excitatory, one is due to energy failure. These are the two components of that. Subacute is more what we know about, right? Either it is because of inflammation, either it is because of apoptosis, either disruption of blood-brain barrier or cerebral edema, or altogether, right? So there are at least four different types of mechanism that constitute a subacute phase of injury in a traumatic brain injury, secondary brain injury. Primary, you forget about that. You have injury directly to the brain, or there is a hematoma or something. So the primary is not a big deal. The secondary is the main thing. Acute phase we talked about. The subacute phase is governed by inflammation, apoptosis, disruption of blood-brain barrier, and cerebral edema. So inflammation, again, you need to talk about activation of glia cell, microglia cell, leukocyte infiltration, mediators such as all the inflammatory mediators, you can name them, interleukin-1, TNF-alpha, etc. Apoptosis, again, pro-apoptotic mediator is BCL2 and other Fas ligand, capsase 3 or cytochrome C. These are the mediators for the apoptosis. There is apoptosis that can cause secondary or subacute phase of the secondary brain injury. All of these can cause disruption of blood-brain barrier, which is a predominant finding in case of traumatic brain injury or ischemic reperfusion. If there is ischemic reperfusion, again, because of disruption of blood-brain barrier, there is ongoing insult to the brain. All these things can lead to cerebral edema due to increased vasodilatation through the nitric oxide pathway and other pathways. So the headings of this is important. The subacute phase happens because of inflammation, apoptosis, disruption of blood-brain barrier, and cerebral edema. The acute phase happens due to two mechanisms. One is excitatory, one is energy consumption or exhaustion of the energy. So if they ask about pathophysiology of brain injury, that's how you write. Primary, secondary is acute, subacute. Acute has mechanism, subacute have multiple four mechanism. Okay. I think this is the last one we'll talk about. Cerebral edema. Again, you can ask about the pathophysiology of cerebral edema, type of cerebral edema, and management. I think all of us know about the management of cerebral edema is working in a neurotrauma unit, but the main thing is to how to put it on paper. Cerebral edema, what are the types of cerebral edema? Now, there are at least three known type of cerebral edema: vasogenic, interstitial, and cellular. So vasogenic is increased permeability of the capillary endothelial cell. So increased permeability of the endothelial cell causing vasogenic edema. There is an existing incompetent blood-brain barrier which causes influx of protein from the intravascular space through the capillary wall into the extracellular space. It predominantly affects the white matter. So vasogenic is an incompetent blood-brain barrier. Now, cellular or cytotoxic is seen in head injury and hypoxia. This is because of swelling of glia cell, neurons, and endothelial cells due to release of toxic factors from the neutrophils and bacteria. Cytotoxic edema usually affects the gray matter. So vasogenic is white matter, cytotoxic is usually the gray matter involvement. Something called the interstitial edema, which is, you can see, usually reported as what do you call periventricular soiling or periventricular edema in the CT scan report. That's what is called as the interstitial edema, which is due to the hydrocephalus. There is CSF outflow is obstructed. There is increased intraventricular pressure. The pressure inside the ventricles are high. So there is movement of sodium and water across the ventricular wall into the paraventricular space. That happens. It can be seen in meningitis, Where there is obstruction of normal CSF pathway, you will have foramen of Monro is blocked, or there is a obstructive hydrocephalus that can cause increased resistance to CSF outflow, thereby increasing the pressure inside the ventricle. So there is more seepage of water and sodium into the periventricular space, which is causing interstitial edema. But pathologically, the vasogenic and cellular are the most important type in case of a traumatic brain injury. Now, etiology of cerebral edema, there can be multiple. Sometimes people miss about the non-neurological causes. So this is the one why I want you guys to focus. Neurological is easy. Anyone can write. So ischemic stroke, hemorrhage, brain tumor, meningitis, encephalitis, other brain infection, etc. can cause neurological causes of cerebral edema. But what are the non-neurological causes? This is important because the examiners want to see whether people know about it or not. So diabetic ketoacidosis, particularly in a young kid, is very, very important. So they have a significant morbidity due to cerebral edema and decay, particularly in young kid where the blood-brain barrier is not that mature. They have young brain. So any changes in the osmolality or glucose level very quickly can cause significant brain edema, or as such, ketone bodies can cause significant brain edema in diabetic ketoacidosis. Lactic acidosis, malignant hypertension, we talked about the Press syndrome, hypertensive encephalopathy, fulminant viral hepatitis, hepatic failure, Ray's syndrome, carbon monoxide poisoning, hyponatremia, SIADH, opioid abuse and dependence, some sort of bites of reptiles and marine animals, and also high altitude cerebral edema. So all these are examples of non-neurological conditions of cerebral edema. Pathophysiology, again, as I told, so this is the standard way of answering. Brain, there is excitatory glutamate, there is opening of calcium and sodium channels, inexpensive energy by ATP pump. So there is ATP exhaustion that can cause the pathway of less ATP to the cells, thereby the cell starts to die. And also there is influx of calcium accumulation that can promote the apoptosis and thereby causing further edema of the brain, and also direct injury to microglial cells and activation of microglial cells causing release of inflammatory mediators. So the pathophysiology pathway that I showed earlier, that also accounts for here, but you need to modify your answer a little bit to suit the cause of cerebral edema. Management, they can ask, this is, we talked about earlier about this, not in this class, but earlier in neurology domain, but the mainstay of treatment for cerebral edema is diuretic. Diuretic and osmotherapy. These are the main two stay of treatment, but some additional treatment that can be done in an acute setting, such as hyperventilation, and particular causes of cerebral edema can be responsive to corticosteroid. Let's talk about that. So diuretic usually has been shown to prolong reversal of blood-brain osmotic gradient established with the osmotic agent by preferentially excreting water over solute. So they cause more aqua diuresis or water diuresis if you use a loop diuretic. In that case, you retain your electrolytes compared to the water, and thereby it can cause reduction in the edema. Corticosteroid, again, chronic meningitis and in acute bacterial meningitis under cover of antibiotics. So in those cases, acute bacterial meningitis, tubercular meningitis, in those cases, steroids are mainstay of treatment at the beginning. Malignant brain tumor, you know that already. It is an important part of treatment in case of brain tumor associated raised ICP or post craniotomy for any tumor, etc. In that case, steroids are important. We do use it frequently in those patients. And as an adjuvant to the chemotherapy for CNS tumors, so lymphomas, etc., they are very responsive. So in those cases, steroids are mainstay of treatment. We talked about perioperative brain surgery. Hyperventilation recommended only for short term for control of ICP, as effective in sustained, as the effect is not sustained and there is rapid equalization or there is rapid homeostasis, thereby the effect of hyperventilation gets reversed because of the body's accommodation, but it can be used as a urgent measure to control acute rise in ICP. It causes cerebral vasoconstriction. It can cause direct cerebral ischemia if the CO2 is kept less than 25 or 25 for a prolonged period of time. So usual recommendation is only mild hypocarbia, like in the range of 35 to 40, that's fine. But if you acutely need to reduce your ICP till you have other definitive measure, then you can hyperventilate the patient up to 30 or less than that for only a limited period of time, knowing the risk that it can cause cerebral ischemia. Other measures include barbiturate. That's again reduces the cerebral metabolic rate and subsequently reduces the blood flow and ICP, thereby thinking that with the low blood flow, there will be less edema. Surgical, again, this is if there is something that is causing pressure and causing edema of the brain that needs to be released, needs to be done, decompressive craniectomy and osmotherapy. We'll talk about a little bit about osmotherapy. So how does osmotherapy work? So what happens is, again, the primary aim of brain trauma or brain protective measures are to prevent secondary brain injury. Now, secondary brain injury can happen due to either increase in blood volume in the brain or either increase in ICP in the brain, or if there is a space occupying lesion, right? So in those cases, hypertonic saline or what do you call osmotherapy, whether it is hypertonic saline or mannitol, can be very, very useful. What it has shown is mannitol works to reduce the vasogenic edema, and also it reduces the blood viscosity, thereby increases the microcirculatory flow through the pia arterial constriction, thereby decreases the cerebral blood flow. So mannitol can directly cause improved blood supply to the smaller arterioles by decreasing blood viscosity. It reduces the blood flow into the brain, like the effective cerebral blood flow can be reduced, and also it reduces the vasogenic edema. But when you look at the benefits of hypertonic saline, it has multiple other benefits along with the same as the mannitol. So what happens is hypertonic saline works both in cytotoxic and vasogenic edema. How does it work? So it increases the aquaporin 4 expression, thereby downregulation of glutamate transporter. So the inflammatory or the excitatory pathway of the brain edema is negated to some extent by the hypertonic saline. Second part, it reduces the TNF alpha, thereby which TNF alpha triggers the capsis 3, which is the apoptosis mediator. It reduces that. So the chances of apoptosis or rate of apoptosis also decreases. It also decreases interleukin 1 beta, again that reduces the apoptosis. So it has a more of an anti-inflammatory mechanism also, along with the reduction in vasogenic and cytotoxic. But unfortunately, there is no head-to-head trial for hypertonic saline to mannitol in a large scale. So that's why the current standing brain trauma foundation doesn't give you a preference of one over the other. So going as a comparative thing between the hypertonic saline and mannitol, so what happens is both hypertonic saline is superior to mannitol in control of ICP by easy and sustained effect. So it can cause a more sustained effect than compared to the mannitol. There is less chances of treatment failure. This is well documented in the literature. So if you fail with mannitol, sometimes in that case, hypertonic saline may be beneficial. It does work. And it controls ICP in cases where mannitol has failed, that I talked about already. And the important thing is mannitol causes significant diuresis. The patient may be intravascularly dry, thereby compromising the blood supply to the brain. But this is not so common with hypertonic saline. So you don't have to bother about chasing fluid into the patient. One way you are trying to decongest the patient to reduce the ICP, and the other way you are worried about the volume status. So that is not so with use of hypertonic saline. Theoretically, it is better than the mannitol, but as I said, there is no large-scale trial to compare head-on both of them. Now, what are the cons? So, if you use hypertonic saline, there is rapid changes of serum sodium. There is risk of central pontine and extrapontine myelinolysis, which is a potential practical risk. But there are many cons with mannitol. So what happens with diuretic? It can precipitate AKI because of dehydration. There may be local brain edema or rebound increase in ICP due to the accumulation of osmotically active molecules in the brain where the blood-brain barrier is disrupted. So what you call refractory or rebound local edema or local brain edema has been found as a consequence of mannitol. Both of them can cause initial volume expansion on rapid infusion, which can cause a precipitated heart failure in a borderline patient and pulmonary edema. So both of them can cause pulmonary edema. Abrupt discontinuation can lead to rebound intracranial hypertension, which is correct for both of them. So this is important. This table is important if they can ask you about compare and contrast between hypertonic saline and mannitol. As I said, Brain Trauma Foundation quotes a retrospective observational study with an increased ICP burden, that is number of days with a raised ICP more than 25 millimeter of mercury and length of ICU stay in mannitol group, but the mortality difference was not significant when they compared with hypertonic saline. So the control and the length of ICU is less with hypertonic saline, but there is no mortality benefit. In a RCT of 47 patients, documented better ICP control with hypertonic saline compared to mannitol. So there is scarcity of good randomized controlled trial in this aspect. That was my last slide. Thank you for your patient listening. If you guys have any question, I'm happy to answer.
Thank you, sir.
Thank you. All right. In that case, if there are no questions, then I will disconnect. Thank you.
Yes, sir. So my outline of the topic would be introduction, the types of albumin solutions which are commonly used in the ICU, and the important one is the role of albumin in different situations. Like what is the role of albumin in sepsis, ARDS, cirrhosis, renal replacement therapy, in perioperative period, and as a deresuscitative measure. So previously, two times the questions on albumin have been asked. One is in DRNB 2022, describe in brief about human albumin, what are its functions for 5 marks, and clinical utility as per evidences, 5 marks. The next was recently in 2024 May, they have asked about 20% albumin. So as we all know, albumin is a natural protein which is produced exclusively in the liver in amounts as high as 9 to 14 grams per day. So the half-life of albumin is around 18 to 19 days. So coming to the functions of albumin, so the main important function of albumin is that it maintains the colloidal osmotic pressure. Coming to the other things, so it helps in the transport of certain drugs. It affects the vascular integrity. It helps in binding and transport of certain molecules apart from the drugs. Also, it has some antioxidant and free radical scavenging functions. Also, it has anticoagulate and antithrombotic effects. And finally, it has anti-inflammatory action also. So coming to the different albumin solutions, so we have two forms. One is the iso-oncotic solution and one is the hyper-oncotic solution. So iso-oncotic solutions are available as albumin 4 to 5% and hyper is albumin 20 to 25%. So basically, what is the function of this iso-oncotic solution? It helps in intravascular volume expansion. So basically, it is used as an emergency treatment for some hypovolemic shocks, in cardiopulmonary bypass surgeries, and in acute liver failure. And this hyperoncotic solution is basically used for the restoration of the colloidal osmotic pressure. So the main functions are in hypovolemic shock, in hypoproteinemias, ARDS, hemolytic diseases of newborns, acute nephrosis, acute liver failure, in renal dialysis, burns therapy, and in cardiopulmonary bypass surgeries. So what is the role of, what are the side effects of hypoalbuminemia in critically ill patients? So what is hypoalbuminemia? It is nothing but less than 30 gram per liter of albumin in the serum. So most of the studies shows that this hypoalbuminemia leads to increased capillary permeability, leading to fluid redistributions from the intravascular to interstitial space. So this is associated with increased morbidity as well as mortality. Now coming to a meta-analysis which was showing that for every 10 gram per liter decrease in serum albumin concentration, the odds ratio of mortality, it increased by 137%. So there is a clear correlation between albumin serum concentration and morbidity rates. However, the question still remains that if albumin replacement improves outcomes or if hypoalbuminemia is just a marker for severity of illness. Now we will go to the individual uses of albumin in different situations. So the first important one is in sepsis. So what is the use of albumin in sepsis? So it is basically considered for volume resuscitation in septic patients because of its plasma volume expansion capability, and second, it potentially improves the hemodynamic stability. Now coming to the evidences which supports the use of albumin in sepsis, the first trial was the SAFE trial, which was published in the new NEGM in 2004. So basically, what is the clinical question in the SAFE trial? So does fluid resuscitation with 4% albumin compared to 0.9% sodium chloride affect mortality? So it is a 28-day mortality which they are speaking about. So this is all critically ill adult patients who have sepsis. Okay. So two groups, albumin versus saline. So there are two patient groups also. So one is all the patients who have been admitted to critical care units, and the other group was only the TBI patients. So what did the results tell? So they told that the 28-day mortality is similar for all patients when compared to the resuscitation either with albumin or 0.9% sodium chloride. So there was no statistical significance. But when you come to this TBI patients, the 28-day mortality in the albumin group has been increased. Okay. So we should not use albumin for resuscitation in TBI patients. Now, second trial is the Albios trial. This was also published in the NEGM in 2014. So here, patients with severe sepsis in the past 24 hours. So this was the inclusion criteria for this. So what was the clinical question? Does the replacement of albumin in patients with severe sepsis, it improves mortality compared to no replacement? Okay, so they have checked 30-day mortality and as well as 90-day mortality. But there was no statistical difference. Okay, so there was no much difference in both the groups. So whether to give albumin still remains a question mark. In 2011, there was one more study, the IRAS albumin resuscitation study, which basically included patients with septic shock. Here, the authors were able to demonstrate improved survival in the group receiving albumin compared to the group receiving crystalloids. But due to insufficient patient recruitment, this study was stopped before a clear conclusion could be drawn, and it was only published as an abstract. So, a pooled analysis of these three trials, the SAFE, the Albios, and the IRAS trial, they have identified improved outcomes for patients resuscitated with albumin. Post which, there is one ongoing trial, the ARIS trial, which has not been published yet. So they are also comparing the role of albumin in sepsis. So results are still awaited. Now, after all this trial, the recent surviving sepsis guidelines, what does it tell? It tells that for adult patients with sepsis or septic shock, we suggest using albumin in patients who received large volume of crystalloids. This has a low level of recommendation and a moderate evidence. Now coming to the concerns regarding albumin in sepsis. One is we don't have a clear, there is a lack of clear benefits of the use of albumin because the trials still show inconclusive evidence for the benefit of the use in sepsis. Second, because of the costs in our Indian scenarios, the cost is also one of the issues. And safety issues, like there could be a risk of hypervolemia, pulmonary complications, there could be myocardial insufficiency, and some hemorrhagic complications also. Now, the second is albumin in ARDS. So, we all know that restricted fluid management with reduced fluid intake or use of furosemide and albumin administration to achieve a negative fluid balance, it has been shown to be associated with improved oxygenation and reduced ventilation requirement in patients with ARDS. Okay, so what is the evidence for this? So, there was a RCT which was published in 2005. So where they combined furosemide with or without albumin in hypoproteinemic patients with acute lung injury. And what were the results? So they told that addition of albumin to furosemide in hypoproteinemic patients with either acute lung injury or ARDS, it significantly improved oxygenation. Plus, there was a greater net negative fluid balance and it had a better maintenance of hemodynamic stability. Okay, so there is a role of albumin in ARDS to achieve a negative fluid balance. So next, there is one more which was published in 2014, which is a systematic review and meta-analysis where they have compared albumin versus crystalloid solution in patients with ARDS. Okay, and this systematic review have concluded that colloid therapy with albumin, it improved oxygenation, but did not affect mortality. Okay, so this affected both the previous one, but here only oxygenation has been improved, but there is no role in mortality. Now, next important one is albumin replacement in cirrhotic patients. So, in patients with end-stage liver disease, albumin is used both as a medication as well as a volume expander. Okay, so more supportive evidence for the use of albumin in these patients is available for large volume paracentesis, patients with HRS, and those patients with SBP. So we will go with each one. So this is just a gist of use of albumin in liver cirrhosis patients. So as we told, it is used in circulatory dysfunction. Okay, it is used in ascites, it is used in spontaneous bacterial peritonitis and also in HRS. So each one has a specific role. So in HRS, albumin has an anti-inflammatory effect. It helps in small volume fluid resuscitation. It helps in improvement of the cardiac function and it prevents renal dysfunction. Coming to the circulatory dysfunction, because of its oncotic pressure, it restores the circulatory volume, helps in fluid redistribution, helps in improved hemodynamic stability and maintains or increases the MAP. In ascites, it helps in reduction of the edema, that is the abdominal edema or the ascites. It prevents the something known as paracentesis induced circulatory dysfunction. It helps in the expansion of the plasma volume and also leads to improved response to diuretic treatment. And lastly, in SBP, it has anti-inflammatory and antioxidant effects, helps in reduction in the renal impairment, and it improves the antibiotic delivery because most of the antibiotic basically are carried by this albumin. Now, the first one is large volume paracentesis. So, what is large volume paracentesis? Removing of more than 5 liters in a single situation. Okay, so when this happens, there will be some hemodynamic instability, which is known as paracentesis-induced circulatory dysfunction. Okay, so if you come to the pathogenesis of this, so in patients with cirrhotics who has ascites, cirrhotic patients are already having a pre-existing arterial underfilling. In such patients, if you do a large volume paracentesis, so what happens? There will be some mechanical decompression of this splanchnic vascular bed, which leads to splanchnic vasodilatation and accentuated decrease in the systemic vascular resistance. So when this happens, there will be further decrease in the arterial filling, leading to the activation of the baroreceptors as well as the RAS system activation. So when this happens, there is rapid water and sodium retention, leading to a lot of phenomena like accumulation of ascites. Once you remove, there will be reaccumulation. There could be renal failure, there is a HRS. There could be hepatic encephalopathy. There could be some metabolic derangements like hyponatremia, uremia, and hyperammonemia. Okay. So to prevent this paracentesis induced circulatory dysfunction, so the British Society of Gastroenterology has recommended the use of albumin. So what is a dose of albumin for this? It is 6 to 8 gram for every liter of ascites removed. So this equates to around 100 ml bottle of 20% human albumin for 3 liters of ascites that is been drained. So roughly, if you want to remove around 5 liters, so you require 2 bottles of 20% human albumin. Okay. So in patients who are hemodynamically unstable or those who are already suffering from a AKI, not a HRS, but there could be an AKI, 8 gram of albumin should be replaced for every liter of ascites, even if the amount of parasynthesis is under 5 liters. Okay. In such cases, you have to transfuse it when the patient is hemodynamically unstable and if the patient has a pre-existing AKI. Okay. Now coming to the spontaneous bacterial peritonitis. So this is most common in patients with cirrhosis and ascites. Why does it happen? Because of the intestinal ischemia, the mucosal surface and the intestinal epithelia, they are damaged, leading to the bacterial translocation into ascites, causing SBP. So albumin has been shown to significantly increase the MAP through its potent expander qualities, leading to organ perfusion. Also, it reduces the RAS pathway activation, which has been explained previously. It improves the circulatory dysfunction, which is seen in SBP, and it reduces the renal impairment. But if your creatinine is less than 1 and your bilirubin is less than 4, then you need not give albumin infusion because these patients have a low risk of developing renal failure. What is the dose of albumin for SBP? Okay, it is 1.5 gram per kg upon diagnosis of SBP and then 1 gram per kg on day 3. Okay. So you should know the different doses of albumin in different scenarios of CLD. Now next comes the hepatorenal syndrome. We all know this is a serious complication which might lead to high morbidity and mortality. So this is basically characterized by circulatory dysfunction which exceeds the compensatory mechanisms of the kidneys, prompting the vasoconstriction of the vas deferens resulting in decreased GFR. So as we know, the treatment of HRS is one is vasopressor, that is nothing but the terlipressin which we use, and albumin combination. So what is the dose of albumin for HRS? So on day 1, 1 gram of albumin per kg body weight should be infused, which is followed by 20 to 40 gram daily for 2 to 16 days. So maximum you can give it for 2 weeks. Now, this is, I think, already we have discussed in our previous top classes about the pathophysiology of HRS. So, most important thing is in HRS pathophysiology. So, portal hypertension in cirrhosis may lead to increased splanchnic arterial vasodilatation, which causes decreased systemic vascular resistance, leading to decreased blood volume, which leads to activation of RAS, renal vasoconstriction, decrease in GFR, and hepatorenal syndrome. Now, where does our albumin act in this pathway? So, it acts in 2 places. So, one, it binds to the nitric oxide and the TNF alpha, and it reduces the splanchnic vasodilation. So, this is the first, mechanism where it acts. The second is here. Okay, so it increases the intravascular circulatory volume and it provides fluid resuscitation. So the effective blood volume will be increased by albumin. Okay, so when this is increased, the further pathway will be blocked. Now, is there a role of albumin in hepatic encephalopathy? As such, not proven, but it helps in treatment of hepatic encephalopathy. How? So, One is because of its potent plasma expander qualities, it can reduce the level of ammonia. How? By increasing the urinary excretion of ammonia. That is the first one. Second, it has some unique structure that is nothing but the free cysteine 34 residue. Okay, what does this thing do? It can ameliorate the inflammation by binding to TNF and interleukin 6, thereby preventing the breach of the blood-brain barrier. Third, it has antioxidant effects. So usually, the ions of copper and iron, they form free radical, which contribute to the development of edema, that is cerebral edema in these patients, hepatic encephalopathy patients. So what does albumin do? The albumin binds these free radicals, the copper and the iron, and exhibit a protective effect. The last one is it has a marked reduction in oxidative stress markers. So all these also help in the prevention of hepatic encephalopathy or in the treatment. So Sharma et al., there is a study done by Sharma et al. Who administered albumin with lactulose, and he observed that there is a decrement levels in the ammonia and there is reduction in mortality and reversal of HE in cirrhotic patients. So this is a beautiful slide which tells where all you can give albumin in cirrhotic patients and what is the dose of albumin. Okay, so if you write it in exam with this one slide, most of your albumin in CLD patients treatment will be completed. Okay, so for large volume paracentesis, for ascites, spontaneous bacterial peritonitis, hepatorenal syndrome, what is the dose? Okay. So next, there are some trials which are very important in this. I mean, a lot of trials are there where you can use albumin in cirrhotic patients. I'm not going in any details. Just if you know some names, you can write it in the exam. So you can write about answer trial, ATAL trial, and match trial. So you can go through it in detail later. I'm not going through it. Now, the role of albumin in renal replacement therapy. So albumin administration during hemodialysis, they have seen that it improved the hemodynamic stability, it improved the fluid withdrawal, and also it increased overall safety. So there are two trials which actually support albumin in RRT. The one is the Mesido et al. They conducted a randomized crossover study to evaluate the effect of albumin in renal replacement therapy. So what they have done is they have assigned one group with albumin and the other group with a sodium chloride 0.9%. Both received 100 ml each. So they found that the albumin group experienced fewer episodes of hypotension compared to the sodium chloride group. The next is the renal study. Renal study is very popular. Basically, it gave the doses of CRRT. Basically, it gave the levels of intensity of CRRT doses. So, a subgroup of these patients who underwent a post hoc analysis to evaluate the effect of albumin, they have found that albumin treatment was associated with more effective fluid removal. So these two trials, they support the role of albumin in renal replacement therapy. Studies with larger sample size confirming these data are still lacking. Now, what is the role of perioperative albumin replacement? So one is, there was a prospective study conducted by Norberg. So they have conducted in both thoracic as well as abdominal surgeries. So they have seen in esophageal and pancreatic surgery. So whether during the perioperative period, is there a decrease in albumin levels? So they have measured it pre-operatively and 72 hours post-operatively, and they found that around these 3 to 4 days, because of increased third space losses and all, there is a decrease of albumin concentration in these patients. But there are very less trials which showed whether supplementing the albumin preoperatively will improve any mortality or improve, in the wound healing. No, there are no much trials. There is still a lack of evidence for this. Okay. Now, second is they evaluated the effect of albumin in cardiac surgery patients. So what they have done is patients with preoperative serum albumin of less than 4 gram per liter, they received albumin to maintain the serum concentration of more than 4 gram per liter. And they saw that those who were given albumin and they maintained the level more than 4 grams throughout the cardiac surgery, they saw that there was less risk of developing AKI in these patients. The third group was patients who are receiving the VA ECMO. Okay, so ECMO itself can trigger inflammation with capillary leak and intravascular volume depletion. So in these patients, they have given either albumin or balanced crystalloid solutions, and the results show that there is significant better survival in the albumin group. Okay, so this is in the perioperative management of the patients. Now, what is the role in de-resuscitation? Okay, so something known as PAL treatment. So this was published in 2012. So placebo with PAL treatment they have done. So what is this PAL treatment? P is for high levels of high levels of PEEP. Okay, A is for hypertonic albumin and L is for Lasix. So combining these three in patients with acute lung injury, they saw whether there is any benefit. Okay, so this PAL treatment is associated with a negative fluid balance. There is a reduction of extravascular lung water, and there is also a reduction of intra-abdominal pressure with some improved clinical outcomes without compromising the organ function. So this is about the PAL treatment. So this is a Kaplan-Meier plot which shows that the cumulative survival is better with the PAL treatment, and the proportion of mechanically ventilated patients, those requiring ventilator, were actually less in PAL treatment because all these three combination together has made a restrictive fluid management in acute lung injury patients. So this is a beautiful slide which says where is albumin recommended, where it has a possible role but limited evidence, and where it is a harm. Okay, so it is recommended in sepsis resuscitation after large volumes of crystalloids, recommended in CLD patients with spontaneous bacterial peritonitis, hepatorenal syndrome, and large volume paracentesis. And the last one is ultrafiltration in patients with hypoalbuminemia. Sorry. It has a possible role, but evidence is limited or uncertain in cases of diuretic resistance, sepsis, and cardiac surgery. And it is harmful in case of extraperitoneal infections in patients with liver cirrhosis and acute brain injury, especially the TBI. So these are my references.
Steroids have been used in multiple settings, be it ARDS or otherwise, like community-acquired pneumonia. So please look into the next slides as well. Over to you, ma'am.
Yeah, so steroids in ICU. Steroids are used in ICU, very rampantly. I never knew that you use it for so many things, but when I was preparing this slide, I was surprised that actually we use for many of the scenarios in the ICU. So we'll just go through it. So I'll be discussing about the introduction, the physiology of the steroids, and its role. Basically, it is used in many situations. So we'll just go through the topic directly. So steroids are basically classified into glucocorticoids and mineralocorticoids. So we'll be dealing here with glucocorticoids. So glucocorticoids are potent anti-inflammatory medications which are frequently used in the treatment of critically ill patients. So the most common systemic glucocorticoids which we use are prednisolone, methylprednisolone, and hydrocortisone. And they all have the action which are similar to that occurring in the body. So now, what is the role of this cortisol or the glucocorticoids in our body? So it acts in it acts on each and every system. So basically, in the eye, it has an anti-inflammatory, anti-angiogenesis. In nervous system, it maintains the homeostasis and it responds to the stresses. In cardiovascular system, it has an anti-inflammatory, cardiomyocyte survival. It helps in increasing the blood pressure and vascular tone, and also it has an anti-angiogenesis property. In the immune system, it suppresses the pro-inflammatory cytokines. There is a regulation of the immune cell maturation, migration, as well as apoptosis. So in musculoskeletal system, it has anti-inflammatory properties. It has muscle catabolism and anabolism properties. There is insulin resistance and osteoblast apoptosis and osteoclastogenesis. In reproductive system, it is very important for gonadal function and fetal organ maturation. It also helps in glucose regulation and lipid homeostasis. And in respiratory system, it has suppression of cytokines, chemokines, and cell adhesion molecules. Because of all these mechanisms, a trial of glucocorticoids is often used in critical illness when dysregulation of the inflammatory response is proposed to be the underlying pathology. Because it helps to limit the organ damage, it promotes the recovery of organ function, and helps in improving the mortality. However, there are a lot of serious side effects which happens with steroids. So the important ones in ICU being any new infections, hyperglycemia, and critical illness myopathy. So in order to maximize the benefit and to limit the harms, we must be aware of the evidences which justify the use of glucocorticoids. So this is just some physiology. So cortisol is basically a product of cholesterol metabolism in the zona fasciculata. It is highest in the morning and it is lowest during the night while sleeping. Under non-stressed conditions, the normal value is around 20 mg. Whereas in any stressors like infection, trauma, or diseases, it might increase up to 150 to 200 mg. Now coming to the physiology. So we know that endogenous cortisol production by the adrenal gland is actually controlled by the HPA axis, right? And this occurs basically in a diurnal and circadian patterns every 24 hours. So due to a lot of CNS stimuli, which could be temperature change, energy expenditure, any stresses, inflammation, tissue repair, all these CNS stimuli will lead the hypothalamus to release the corticotropin releasing hormone. So this hormone acts on the anterior pituitary and releases the ACTH, which acts on the adrenal cortex, and via the adrenal cortex, it goes to the end organs. Okay. Now coming to the role of steroids in septic shock. So sepsis and septic shock, they develop when the inflammation spreads beyond the initial site of an infection, leading to systemic pro-inflammatory cascade, which overwhelms the body's anti-inflammatory processes, leading to diffuse cellular injury and multi-organ damage. So this inflammatory mechanism, it provides a rationale for the use of steroids in the treatment of septic shock. So there is a lot of theoretical benefits of steroids in septic shock. So basically, it increases the sensitivity of alpha and beta adrenergic receptors. It decreases the release of adhesion molecules. It increases the transcription of anti-inflammatory cytokines, decreases the transcription of pro-inflammatory cytokines. It inhibits arachidonic acid. It inhibits the platelet activating factor, prevents neutrophil aggregation. It inhibits the inducible form of nitric oxide, and it prevents complement activation. So these are the theoretical benefits of steroids in sepsis. Okay, so a lot of evidences, a lot of research has been done in this steroids in septic shock. So it started from around 1976 and now it's still ongoing. So we'll just discuss about the important trials. Okay, this is very important for you for the exam. So the first trial was the ANAN trial. So where it is a double-blinded study where they gave 50 mg of hydrocortisone Q6 hourly with fludrocortisone 50 mg, and they've compared it with placebo for 7 days. And what did they find? They've seen that 28-day mortality in septic patients with relative adrenal insufficiency. Okay, they've basically seen the primary outcome was deaths. So in hydrocortisone plus fludrocortisone, the 28-day mortality was around 60, that is 53%, whereas in the placebo, it was around 63%. Coming to the secondary outcomes, they saw was mortality at the end of ICU stay, mortality at 1 year follow-up, vasopressor therapy discontinuation at 28 days, and median time to vasopressor therapy discontinuation. So coming to this, there was no significant effect of steroids on mortality in responders, but among non-responders. Who are non-responders? Patients with septic shock and adrenal insufficiency. Low-dose steroids have reduced the 28-day mortality and also the vasopressor dependence time. Okay, so this showed some positive effect, steroids in septic shock. Now, next came the Corticus trial and the Hypris trial. Okay, so Corticus trial was in 2008 and this Hypris trial was in 2016. So Corticus trial had also compared hydrocortisone with the placebo, and they have concluded that there was no significant difference in 28-day mortality in patients who did not have a response to corticotropin. Okay, so there was no much response. Now coming to the Hypris trial. So Hypris trial also, they have given hydrocortisone with the placebo. So they showed that a continuous infusion followed by the tapering dose of hydrocortisone, it did not prevent severe sepsis to septic shock progression within 14 days of treatment initiation when compared to the placebo. Now next came the adrenal trial and the approaches trial. So adrenal trial, both were in 2018. So what did the adrenal trial tell? Same, this also hydrocortisone with placebo. They told that continuous infusions did not result in lower 90-day mortality. Okay, but the steroid use had led to more rapid resolution of the shock, shorter inpatient ICU time, and lower incidence of blood transfusion. So mortality wise, there was no much benefit, but requirement of vasopressors was less in adrenal trial. Now, what did the approaches trial tell? So in approaches trial, they used hydrocort plus fludrocort. So in ANN and approaches, they used both hydrocort plus fludrocort. So what they have showed is the combination showed both a mortality and resolution to shock benefit. So here, this is the one trial which has showed that there is some mortality benefit. This was in the recent 2018. So, but the steroid regime was also shown to be safe because there was less incidence of hyperglycemia and also less incidence of new onset infections. So, now when you give the steroids as a septic dose, would you require a tapering of the steroid or can we stop it abruptly? Okay, so basically if you come HPA axis suppression, so standard dose cortisone, which is nothing but 20 mg per day, which we usually give 50 q6 hourly, it mimics the physiological cortisol production during stress, which minimizes the risk of HPA axis suppression. So tapering is not required for less than or equal to 7 days of therapy. Okay. Second, shock resolution. So abrupt cessation of corticosteroids after 5 to 7 days showed no recurrence of shock or rebound inflammation in many of the RCTs, especially in the adrenal trial and the approaches trial. Now, as I told, duration, if it is less than 7 days, you need not to taper it. And adverse effects, if you give it within 200 mg per day, then adverse effects are also less. Okay, so whatever dose which we are giving for the sepsis, there is no much adverse effects and you need not to taper the dose. You can stop it abruptly. So driven by all these trials, results and all, the 2024 sepsis guidelines, they included a conditional recommendation in favor of low-dose corticosteroids in patients with ongoing shock following fluid resuscitation. Now coming to the respiratory system. So first we will see role of steroids in ARDS. As we all know, ARDS is an intense inflammatory process which occurs at the level of alveoli, alveolar blood membrane, and pulmonary interstitium. So when this happens, this alveolar space is filled with fluids, cellular debris, and inflammatory cytokines, all of which leads to severe gas exchange abnormalities with subsequent hypoxia, and in severe cases, it may even lead to hypercapnia. And we have to remember that the inflammation in ARDS is dynamic. It changes very rapidly. So normally in the initial phases of the disease, it is basically characterized by the development of edema and hyaline membrane formation. Whereas in the second week, it is basically characterized by the presence of interstitial inflammation and development of interstitial fibrosis. So these are the different trials which have been done with the steroids in ARDS. Important one which you have to remember is the Meduri trial. Okay, So basically in 1987, the Bernard showed that when you give methylprednisolone every 6 hours, there is no difference in mortality. Okay. But Meduri 1998 showed that methylprednisolone in a dose of 2 mg per kg followed by tapering showed improved lung injury severity score, plus there is improved ICU and in-hospital mortality. From then, a lot of work has been done on this steroids in ARDS. Then came Steinberg, who told that no, there is no difference in mortality when you give steroids. So again, after this, Meduri in the next year, because he has done this and he showed that there is an improved survival rate, he has again done it with low dose, methylprednisolone 1 mg per kg. So here he has done it with 2 mg per kg. Here it is 1 mg per kg for around 28 days. And he showed that there is an improvement in the length of ICU stay is decreased, the duration of mechanical ventilation is decreased, and ICU length of stay is also decreased. Okay, so in 2021, Lin has done a meta-analysis of 9 studies, and he showed that steroids have improved the mortality, the ventilator-free days at 28 days, and there is an increase in PF ratios. So after all this, the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, they proposed or they suggested the use of steroids in patients with moderate to severe ARDS within 14 days of disease onset. If you give it after 2 weeks, there is no role of steroids. Okay. However, this recommendation was conditional and it was based on moderate quality of evidence. The same guidelines also recommend that you have to do surveillance to see if there is any hospital-acquired infection during therapy, because steroids cause new onset of infection. Now, role in severe pneumonia. Okay, so basically, the community-acquired pneumonia is characterized by inflammation due to increased pulmonary as well as circulatory inflammatory cytokines. That is where you have to use steroids. So now this started in 2005. There are a lot of things that initially they told that it has improved mortality. Then in 2011 to 22, there are a lot of studies. Even Meduri has done a study here in CAP, and he told that there is no difference in mortality. Now, recently in 2023, Dickwin has done a trial that is nothing but the Cape Cod trial. I think you people have heard about that. So here they have given hydrocortisone 200 mg daily for 4 to 7 days and then tapered it. And this trial showed that there was an improved 28-day mortality. Okay. So the evidence supporting the use of steroids in severe community-acquired pneumonia, it appears relatively strong when this hydrocortisone infusion is administered early in the course of the disease. Whereas there are trials which has also seen the benefits with methylprednisolone, but compared to hydrocortisone, they saw that the benefits are less compared with methylprednisolone. Data on nosocomial pneumonia are very limited, and the safety of steroids in influenza pneumonia, it still remains in question. So if there is an influenza pneumonia, should we give steroids or not? Initially, they told it is contraindicated, but now there is still a lot of ongoing research being done on this. Now, what is the role in COVID-19? I think everyone know about the COVID-19. What is the recovery trial? Basically, it became very famous. So we were giving steroids to those patients with who are on oxygen requirement. So glucocorticoids were among the first therapies which were studied in the management of patients with severe SARS infection. So inflammatory markers and cytokines including CRP, ferritin, interleukins are elevated in COVID-19, and it correlates with the intensity of the disease also. So there were 3 trials which were doing side by side the work on this. So in 2020, we have 2, Dickwin and Tomazini were doing the trials, but then in 2021, recovery trial has been started. But before these both could publish their results, the recovery trial told that dexamethasone 6 mg daily for up to 10 days has improved the mortality. Okay, so both these trials should be stopped early because the recovery results were already released. Now, this is about the 2024 focused update for the guidelines on the use of steroids in sepsis, ARDS, and community-acquired pneumonia. So what does the evidence tell? In sepsis and septic shock, they suggest administering steroids to adult patients with septic shock, which is a conditional recommendation and a low certainty evidence. But in those patients who have, they have recommended against the administration of high dose, short duration, that is more than 400 mg per day of hydrocortisone. So they recommended against the use of this high dose, which is a strong recommendation and moderate certainty evidence. Coming to the ARDS, they suggest administering the steroids to patients with ARDS, which is a conditional recommendation, whereas in community acquired pneumonia, there is a strong recommendation for administering steroids to those patients who are hospitalized with severe bacterial community acquired pneumonia. Okay, so just go through the doses. Okay, if you have time. Now we'll come to what is the role of steroid in hypercapnic respiratory failure, that is the COPD. So we know that in COPD patients, a lot of steroids has been used, right? So systemic steroids are used extensively in the treatment of hypercapnic respiratory failure due to COPD because airway inflammation underlies the acute exacerbation and it results in air trapping, which impairs the ventilation. But despite this widespread use of steroids, there is very little evidence to support this use in COPD patients. So we have just only 2 trials. Okay, the ALIA trial and the OBRAM trial, and both of the trials showed that there is no difference in mortality, whereas it significantly reduced the duration of mechanical ventilation and failure of NIV. And in OBRAM, it showed increased hyperglycemic events. So as such, there is no mortality benefit in COPD patients in respect to the steroids. So in patients with hypercapnic respiratory failure due to asthma, okay, there is a clearer role of steroids. Okay, you should give steroids in these patients. So now coming to the guidelines. So for COPD exacerbations, what does the GOLD 2024 guidelines tell? You can give steroids in the dose of 40 mg per day for a maximum of around 5 days. Whereas for asthma exacerbations, the GINA guidelines 2024 tell that either prednisolone or any equivalent, the dose is around 1 mg per kg per day, maximum of around 50 mg per day, and you can give it for 5 to 7 days. Now, what is the role in airway edema? So airway edema, especially the laryngeal edema, is actually because of the complication of the endotracheal intubation. So this laryngeal edema may lead to post-extubation stridor and increased chances of reintubation. So hence we give steroids, especially the most common used steroid is dexamethasone, around 0.5 to 2 mg per kg divided over 4 to 6 hours, started 24 hours before extubation, and it is continued for 24 hours after extubation. So you give around for 2 days. So there was a systemic review and a meta-analysis which was showing the comparative efficacies of various corticosteroids for preventing the post-extubation stridor. So they have compared methylprednisolone, dexamethasone, and hydrocortisone, and they told that for stridor, to prevent stridor, the best one would be methylprednisolone, and to prevent reintubation, dexamethasone would be the best steroid. Okay, so what does the clinical recommendation now suggest? So corticosteroids, they are most effective when administered pre-extubation, that is 24 to 48 hours. Post-extubation use is not routine, but may be considered for those patients with high-risk features, like if the patient tested for a positive cuff leak test, or if there is severe airway edema, then in such cases, you can even continue it post-extubation also. So there are a lot of regimes, pre-extubation, methylprednisolone, or dexamethasone can be given, whereas post-extubation, dexamethasone 5 mg every 12 hourly for 48 hours in selected high-risk cases you can give. Now, what is the role in ILD or pulmonary fibrosis? So, a lot of guidelines here. So, for idiopathic pulmonary fibrosis, corticosteroids are not recommended routinely. Only it is used in acute exacerbations, that too on a case-by-case basis. Now, coming to the acute exacerbations of the IPF, as I told, you can give in acute exacerbations. The dose is 0.5 to 1 mg per kg per day of prednisolone. You can give it for 2 to 4 weeks and then taper. Now coming to the connective tissue associated like SLE, associated ILD, you can give prednisolone in the dose of 0.5 to 1 mg per kg per day and then taper it. It is often combined with other immunosuppressive therapies. And coming to the last one, the hypersensitive pneumonitis, you can give prednisolone for around, you have to give it for a longer period for hypersensitivity pneumonitis. It is 4 to 6 weeks. So what is the role in PCP pneumonia? So basically in PCP pneumonia, glucocorticoids or corticosteroids are given as an adjunctive therapy with the standard treatment like cotrimoxazole, right? So usually the steroid dose is 40 mg twice daily for 5 days. Then the same 40 mg once a day for 5 days and then 20 mg once daily for 11 days. So totally in PCP pneumonia, you are going to give the steroids for 21 days. So what is the effect of the steroids in PCP pneumonia? It reduces mortality, particularly in moderate to severe PCP cases. It showed improved survival benefits. It reduced the complications such as pneumothorax and also respiratory failure. Okay, and a meta-analysis showed that it reduced the mortality by 0.55 times compared to the control groups where only standard therapy has been given. So now the guidelines recommend that steroids should be initiated within 72 hours of starting any PCP therapy, that is a standard therapy. And if the patient has a resting room air oxygen saturation of less than 92%, or if the PaO2 is less than 70 mmHg on room air, or if there is a increased AA gradient of more than 35 mmHg. In all these situations, you need to start the steroids in PCP pneumonia 72 hours, within 72 hours of start of the standard therapy. Okay, so this is the guideline. Now coming to something known as metabolic resuscitation. So what is metabolic resuscitation? I think this is an expected question in your exams. So what is metabolic resuscitation? It is nothing but mitochondrial target therapy, especially for sepsis and septic shock, is known as metabolic resuscitation. Okay, this resuscitation could be either pharmacological or nutritional. Okay, why this concept came? Because mitochondrial dysfunction, it occurs early in sepsis and it has a central role in the development of multi-organ dysfunction syndrome. Okay, so what is the most common metabolic resuscitation that has been, previous few years this was there, the HAT therapy, the hydrocortisone, vitamin C and thiamine. So this therapy was proposed as an adjunctive therapy for sepsis, which was aimed at addressing the mitochondrial dysfunction and oxidative stress, which was the central to sepsis pathophysiology. So this combination was synergistically, it was modulating the mitochondrial metabolism, it was reducing the oxidative damage, and it was improving the outcomes in septic patients. So this is the synergistic action of the HAT therapy. So if you see, thiamine is basically a coenzyme for many cycles or many metabolic pathways. So important one being the glycolysis and the Krebs cycle. So thiamine is required for these. Second, vitamin C in septic shock, basically it reduces the oxidative stress, increases the microcirculation, decreases the neutrophil extracellular traps, increases the catecholamine synthesis. And hydrocortisone, it actually facilitate the transport or transshipment of this vitamin C. And in fact, vitamin C also promotes the synthesis of this increased synthesis of steroids in the body. So hence they have done this HAT therapy as a part of metabolic resuscitation. So I think you know a lot of trials on this HAT therapy has been done. So it started in 2017 and that is Marik et al. Started this. So which showed that there was improved survival and vasopressor independence in septic shock. Later, Anane et al. In 2018 showed that it also reduced mortality and improved hemodynamic stability. But later on, from 2020, a lot of vitamins trial, oranges, ACTS, Victor, everything has been showed that there is no significant difference in the mortality or the vasopressor free days. So I think during the COVID time, everyone was giving this HAT therapy, but post 2020, I mean, it's been slowly reduced, this HAT therapy. So now, what is the role of steroids in central nervous system? So first one would be your meningitis and encephalitis. So it has a role in streptococcal pneumonia meningitis because it's reduced mortality and also it prevents neurological complications. Okay, so the dose is dexamethasone 10 mg IV every 6 hourly for 4 days. So this steroids should be administered before or with the first dose of antibiotic in case of streptococcal bacterial meningitis. Okay, next in H influenza, which is most commonly found in children, steroids are indicated here. Secondly, Neisseria meningitis, there is a limited evidence. Coming to the Listeria monocytogenes and cryptococcal meningitis, basically they are contraindicated because it has very adverse outcomes. It has increased the mortality. Coming to the tuberculosis meningitis, steroids are recommended and the dose is 0.4 mg per kg per day, tapered over 6 to 8 weeks. Now, coming to the herpes simplex virus, it has limited evidence, may be used in case of HSV-induced cerebral edema. In autoimmune encephalitis, the main treatment only is about steroids. So, the commonly used steroid is methylprednisolone, 1 gram IV daily for 3 to 5 days, which is followed by oral prednisolone tapered over weeks. In neurocystisarcosis, it is recommended with antiparasitics. And in brain abscess, it has limited limited to cases with cerebral edema alone. Now, what is the role in spinal cord injury? So, initially, a lot of evidence showed that high dose steroids in spinal cord injury will reduce the inflammation and then the chances of decrease in weakness of the limbs. So, basically, why do we need this? Because it has an anti-inflammatory properties to reduce the spinal cord edema. So what are the neuroprotective effects of steroids? It improves vascular perfusion. It prevents calcium influx, modulation of inflammatory cells, prevention of neurofilament loss, inhibition of lipid peroxidation, and inflammatory cytokines. So what is the key agent here? It is methylprednisolone. So we have a lot of trials. So basically the NASIX 1, 2, and 3 trials are the important trials for the steroids in spinal cord. So the first trial was done in 1984, which compared low-dose steroid versus high-dose steroid, okay, within 48 hours of the spinal cord injury. And they showed there was no difference in neurological improvement, but higher complications with high-dose methylprednisolone, okay. Here, there was no placebo, only they compared high and low dose. Now, in NASIX 2, they compared the methylprednisolone, naloxone, and placebo within 12 hours of spinal cord injuries. And they showed that significant motor and sensory recovery with methylprednisolone within 8 hours of spinal cord had showed some mortality, benefit, but there is some increased complications like infections. Whereas the NASIX 3, it compared 24 hours versus 48 hours methylprednisolone within 3 hours of spinal cord. So if you see, initially it was 48 hours, then it came to 12 hours of spinal cord injuries. Now this came with early initiation of steroids within 3 hours only. Okay, so but there was no difference in outcomes for treatment initiated within 3 hours. Okay, so what does the guidelines tell? So the guidelines tell that initially in 2017, the AO spine guidelines suggested a 24-hour high-dose methylprednisolone infusion within 8 hours of spinal cord injury as a treatment option. But now, after lots of trials, the evidence show that there is no neurological improvement with this high dose of methylprednisolone. Now, coming to the role in cerebral edema, I think Sananta sir has already discussed about the management of cerebral edema. So what is the recommendation for the ICH? It is not recommended for intracranial hemorrhage due to increased mortality and infectious complications. The reference is the CRASH trial. Now coming to the vasogenic edema. Yes, it is the corticosteroids are used to decrease the vasogenic edema, especially in brain tumors. Okay, so what is the dose here? The preferred agent would be dexamethasone and the dose would be 4 to 10 mg IV or orally every 6 hours. Okay. Now coming to the other uses of steroids, one is role in anaphylaxis. So basically, how does it help in anaphylaxis? So these corticosteroids, they reduce the number of mast cells and basophils. They downregulate the transcription of pro-inflammatory molecules, and they upregulate the anti-inflammatory mediators, and they rapidly decrease the mast cell release. This is how steroids have a role in anaphylaxis. So what does the guideline tell? So we all know that epinephrine is the first line therapy, whereas glucocorticoids are suggested as second or a third line therapies by almost most of the guidelines, except the American guidelines, which do not endorse their use at all. Okay. Now coming to the role in thyroid storm. So how does steroid help in thyroid storm? They reduce the conversion of T4 to T3. Thyrotoxicosis is associated with subtle impairment of adrenocortical reserve by itself. So there is a role of steroids for this. So what is the dose? So we use hydrocortisone 100 mg every 6 to 8 hourly, or you can also use DEXA, but it's not regularly used. The most common was hydrocortisone. So analysis of a nationwide administrative database, it indicates that administration of the steroids does not improve the survival of patients with thyroid storm. It is only, basically, it reduces the conversion of T4 to T3. Now, what is the role in myxedema coma? So, possibility of secondary hypothyroidism and associated hypopituitarism is most commonly seen in myxedema coma. So, hydrocortisone should be given until the adrenal insufficiency is excluded. Okay, so it should be given at a dose of same 100 mg every 6 to 8 hourly. Not treating the adrenal insufficiency with hydrocortisone may precipitate the adrenal crisis. That's why you need to treat these patients with hydrocortisone. So before therapy, a random cortisol level should be drawn, and if not depressed, the hydrocortisone can be stopped without tapering. Now last one, in brain dead patients. Yes, we use steroids as a part of triple therapy. Okay, brain death can cause pituitary deficiency, promoting hemodynamic instability. Steroids may reduce the inflammation, thereby improving the graft organ functionality. So most commonly used is the methylprednisolone 15 mg per kg immediately after the diagnosis of brain death, and then every 24 hours afterwards. Alternatively, you can also give methylprednisolone as 250 mg bolus followed by 100 mg per hour infusion until organ retrieval. So this completes the second topic, and I'm sorry, there is one more topic left.
It's really great that 42 of you have stayed back till the end. I think so you're going to benefit from this. So that was a really good presentation, ma'am.
Thank you. So my last talk is on ARNI. Okay, some few slides, so we'll just go. So I'll be discussing about the introduction, the neurohormonal activation in heart failure, because that is how the mechanism of action of ARNI comes, and then we will discuss in detail. So coming to just some introduction. So heart failure, it is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. So this is a beautiful classification of heart failure. So you have the AHA or ACC classification, the NYHA classification, and the intermasses profile. So AHA, ACC stages, you should know A, B, C, D. Okay, I'm not going to go in detail about that, but just remember about the C and D. So basically A is at risk patients for heart failure, but there is no structural heart disease and there are no signs and symptoms for heart failure. B is there is a structural heart disease, but there are no signs and symptoms of heart failure. C is there is a structural heart disease with prior or current heart failure symptoms. And D is refractory heart failure, which requires specialized interventions. NYHA class, I think you people know it. Now coming to the new classification of heart failure according to the ejection fraction. Okay, so we all know that, yeah, there is a reduced ejection fraction, there is a preserved ejection fraction. So there are others also. So reduced ejection fraction, we know that if the ejection fraction is less than or equal to 40%, and preserved ejection fraction is more or equal to 50. So in between there is 40 to 49, something known as heart failure with mildly reduced ejection fraction, and there is something known as heart failure with improved ejection fraction. So what does that mean? Baseline, the ejection fraction was 40%. Later, because of some treatment, the ejection fraction has improved to more than 40%. So that is known as heart failure with improved ejection fraction. Now coming to the neurohormonal activation in heart failure. So what happens in heart failure? Three important systems will act. The first one is the RAS system. Second one is the sympathetic nervous system. The third one is the natriuretic peptide system. Okay. So what happens in the failing heart? In the failing heart, the RAS system gets activated. So the renin is released, which converts the angiotensinogen to angiotensin 1. And this angiotensin 1, okay, will be converted to angiotensin 2. And this angiotensin 2 has some receptors which acts on it, and then it leads to worsening of the heart failure. Okay, so the RAS system basically consists of the angiotensin receptors, the aldosterone, okay, and the basically these both, angiotensin and the aldosterone. So where does this ACE inhibitors act? Basically, they stop conversion of angiotensin 1 to angiotensin 2. That is where the ACE inhibitors act. Where does this ARB acts? They act on the angiotensin receptor 1. They block these receptors. Okay. The third one is the second one is the sympathetic nervous system. So where you give the beta blockers. Okay. And the third one is the natriuretic peptide system. The important, the substance which is important here is the neprilysin. Okay. So it basically changes into inactive peptides, leading to natriuresis, vasodilation, and PNS activation, leading to heart failure. Okay. Now, if you see the action of ARNI, so ARNI contains two important things, the sacubitril and the valsartan. So valsartan is nothing but a ARB. So basically it acts on this angiotensin receptor 1. And sacubitril is nothing but the inhibitor of this neprilysin. Okay. So basically this ARNI acts on two important pathophysiological systems. One is the RAS and one is the natriuretic peptide system. Okay. So you need to understand this diagram. So coming to the natriuretic peptide family properties. So basically this family includes three different molecules. One is the ANP, BNP, and the CNP. All these play a key role in the cardiorenal homeostasis. So they are mostly synthesized within the heart in response to volume overload and myocyte stress, and in response to some neuroendocrine regulation. Okay. Mostly these natriuretic peptide effects are mediated by vanillyl cyclase receptors. Okay. So in that we have two, NPR-A and NPR-B. I think you need not to know in detail about this. So what is the biological signature of this NPs? It is to reduce the body fluid, and it maintains the BP and the cardiovascular homeostasis. And by this, there is a physiological antagonists of both the sympathetic nervous system as well as the RAS system, which are nothing but the fundamental factors in heart failure. So coming to the ARNI, so it is approved under the FDA's priority review process for use in heart failure in 2015. So basically, as we know, ARNI combines two things. One is the natriuretic peptide inhibition due to sacubitril, and second is the angiotensin 2 receptor 1 inhibition by the valsartan, which offers the benefits of the two-step approach, whilst it avoiding the side effects of an increase in bradykinin due to dual inhibition of its metabolism. So this basically contains, as I told, valsartan and a sacubitril. Sacubitril is a prodrug. Okay, it is converted into an active form, which is known as sacubitrilat. Okay, by deethylation via esterases. So both are in 1:1 ratio. The concentration is in 1:1 ratio. Now this is important. Something known as co-crystal formation of sacubitril, and valsartan. So if you see individual agents, how they look, okay, sacubitril and valsartan. So when you combine it, okay, that is known as co-crystal formulation. Okay, so the single chemical entity of sacubitril and valsartan in 1:1 ratio. So what is the advantage of this co-crystal formation? Okay, so it has a higher dissolution rate. There is a simultaneous release with the desired simultaneous inhibition of both the neprilysin as well as the angiotensin receptor. Also, it has a higher bioavailability. So this is the advantages of the co-crystal formation. Now coming to the pharmacokinetics. So absorption, the time to peak is around 30 minutes, whereas the time to peak of the metabolite, the active form of the sacubitril, is around 2 hours. Coming to the distribution, the protein binding is around 94 to 97%, whereas the volume of distribution is around 103 liters. Metabolism I've already discussed by esterases. And what is the T-half? Elimination T-half is around 12 hours, and basically it is eliminated in urine and feces. Valsartan in urine and sacubitril in feces. So this is important. Who should be treated with an ARNI? So this is considered as a first-line therapy in patients with class C. Okay, the AHA class C, heart failure with reduced ejection fraction. So these are the patient who has to be treated with ARNI. Okay, so it can be started either in hospital once the patient has been stabilized, or you can start it as an out of hospital also. So the second question is, should ARNI be used as a monotherapy or in association with other agents? And is there any specific order in which these drugs has to be started? So in patients with class C heart failure, this ARNI should be used in association with a beta blocker and a mineralocorticoid. So in order in which these agents should be used is individualized. So as a rule of thumb, when to start Vimada in patients, in hospital patients, is the systolic BP over the preceding 6 hours should be more than or equal to 100 mmHg. Second, the diuretic doses should be stable enough. There should be no intravenous vasodilators in the preceding 6 hours. And there should not have, patient should not be on intravenous inotropes or pressor agents within the preceding 24 hours. So this is the time when you start sacubitril and valsartan in hospital patients. Now, in patients who present with a new onset heart failure in out of hospital settings, that in an OPD, the order in which these drugs has to be initiated is flexible. Okay, so which are the factors which decide upon which has to be initiated first? It includes what is the blood pressure of the patient, what is the patient having a renal dysfunction, and if there is a renal dysfunction, how severe is the renal dysfunction, what is the potassium levels, and what is the magnitude of congestive signs and symptoms which the patient has. So now important is what is the starting dose of sacubitril and valsartan. So it depends on whether the patient has come to your OPD or whether the patient is better. So this is just for your information how to start in an OPD basis. Basically, the starting dose will depend on the dose of RAS blockers which the patient has already been taking. Suppose if the patient is on ACE inhibitors, okay, then you have to see the dose of ACE inhibitors. Suppose if the patient is taking enalapril or any other equivalent, so if the dose is less than or equal to 10 mg, then you have to start with mg twice daily. But if the patient is taking more than 10 mg of an ACE inhibitor, then the dose is 100 mg BD. And there should be a mandatory of 36-hour washout period for this. Means if the patient is taking an ACE inhibitor, you have to stop the ACE inhibitors. 36 hours later, you need to start the ARNI, because there is a lot of chances of angioedema and bronchospasm in these patients because of the ARB and because of the ARB component. Now, second, if the patient is on ARBs, okay, so the starting dose is based on the valsartan units if what the patient is taking on. Suppose if the ARB dose is less than or equal to 160 mg daily, then you have to start Vimada as 50 mg BD. But if the dose is more than 160, then it should be started as 100 mg BD, and there's no need of having a washout period in if the patient is already on ARBs. You can start directly the ARNI. Now, what about the in-hospital patients? So in-hospital patients, the initial dose, basically it is determined by the systolic blood pressure of the patient. So if the systolic blood pressure is more than 120 mmHg, then you can start 100 mg twice daily regime. But if it is between 100 to 120 mg, then you have to start 50 mg twice daily. Okay, this is how you start for the in-hospital patients. But what is the target dose of sacubitril and valsartan which is needed? So regardless of the start dose or the clinical setting, the final dose is around 200 mg twice daily. That is the target dose of sacubitril and valsartan. And the up titration can be performed slowly every 2 weeks. So if the patient is on 50 mg, after 2 weeks, you can increase to 100, then 150, and finally, over 4 weeks, you can, over around 6 weeks, you can increase it to 200 mg. So increases in serum creatinine or potassium levels or any onset of symptomatic hypotension may either delay or prohibit the up titration. So in general, if the patient is on Vimada, increase in serum creatinine levels of less than or equal to 0.3 mg per dl or a decrease in eGFR of less than 25% from the patient baseline are considered acceptable. So you need not to stop the drug. Okay. Similarly, you can maintain a potassium level of less than or equal to 5 mg. Okay. If it is more only, you stop the drug. Otherwise, you need not to stop the drug. So this is one of the important things while adjusting the dose or when to stop the drug. Now, what are the clinical applications of ARNI? So as we know, heart failure with reduced ejection fraction, class C, was the thing that we thought is the indication for ARNI. So there are a lot of trials which supported this. Okay, you have to just know the trial names. Okay, please go through the trials. Just if you remember the names, it is more than enough. So you have the Paradigm heart failure trial, transition trial, Pioneer HF trial, and titration trial. These trials are all for heart failure with reduced ejection fraction. Okay, now next, is there a role for heart failure with preserved ejection fraction? It does not have an official indication in these patients, but it has a beneficial effects in these patients. How? It blocks a pro-fibrotic or pro-hypertrophic metabolism, which is the function of valsartan, while stimulating an anti-fibrotic or anti-hypertrophic mechanism by the sacubitril. So, since it has some protective role, there are trials which have done or compared the role of ARNI in case of heart failure with preserved ejection fraction. So the first one is the Paramount trial, which showed that it had a greater improvements in the NYHA class, and it has a preserved better renal function compared to the valsartan group alone in patients with heart failure with preserved ejection fraction. There is one more trial, the Paragon HF trial. So it showed that ARNI was not associated with decreased CV mortality and heart failure hospitalization. So this is one of the negative trial. Okay, this is a positive trial, whereas this is a negative trial. So there is one more trial which is still ongoing, the Parallax trial. So we'll just wait for the results of this trial. So they have compared here with ACE inhibitors versus ARBs versus NORAS inhibitors, nothing but sacubitril and valsartan. So they compared these three groups and the results are still awaited. Now, the last one is, it is also used in hypertension patients. So the trial is the parameter study. So this study showed that at 3 months, the ARNI reduced central aortic systolic BP more than the olmesartan, and it also reduced the mean 24-hour ambulatory brachial as well as the central aortic systolic BP. So this is one of the new drugs for even the treatment of hypertension. What are the adverse effects of ARNI? It may lead to postural hypotension. It may lead to worsening of renal functions and hyperkalemia. may cause cough because of valsartan component and angioedema. Now coming to the contraindications, if there is a history of angioedema or anaphylaxis to ACE inhibitors or ARBs, then you should not use ARNI. If there is an underlying renal impairment, better not to use it. And if the patient has an hepatic impairment, that is the Child-Pugh-C, only if there is Child-Pugh-C, then that is a contraindication for ARNI. Now, what does the guideline suggest for ARNI? So in patients with heart failure with reduced ejection fraction, so this ARNI is included in the standard therapy, okay, both by the ESC as well as the AHA guidelines. Whereas heart failure, okay, coming to the heart failure with preserved ejection fraction, first we'll see there. So it is not included in the standard recommendation because the trials are still ongoing, okay. Whereas in the AHA, it is included as a class B in the standard therapy, okay. So now coming to the ejection fraction between midway, that is 41 to 50, ARNI can be used in the standard therapy, in the ESC guidelines, also in the AHA guidelines. Whereas those patients with improved ejection fraction, you have to continue it as in standard therapy. So basically, other than the preserved ejection fraction, you can use in the other classes of heart failure. ARNI can be used. Whereas in the preserved ejection fraction, there is no recommendation yet. Trials are still ongoing. So mostly post the trials, they might make a new recommendation. So these are my references. Thank you. We are very, very sorry for